Good morning, everyone. Good morning. A very warm welcome to all our distinguished dignitaries, respected doctors, delegates, and guests. It's a privilege to host you today at Kauvery Head Injury Conclave, a platform dedicated to advanced knowledge, collaboration, and excellence in the management of head injuries that calls for precision, expertise, and seamless multidisciplinary care. We are honored to have with us an exceptional panel of experts from across Kauvery network, and we thank each one of you for being part of this significant gathering. And this is Akshaya, your host for today. To share the insights into the vision and purpose of this conclave, may I now invite Mr. Dr. Krish Sridhar, Group Mentor Neuroscience and Director, Institute of Brain and Spine, Kauvery Hospital, Radial Road, Chennai. With a huge round of applause, please.
Good morning and vanakkam. Good morning. I know you're all tired after the workshop, but good morning. Thank you first for coming on a Sunday morning. I know a long weekend, Sunday morning, very tough. But I think we are meeting here today for a very, very important purpose. March 20th each year is commemorated as the World Head Injury Awareness Day. And it is important that we make people aware of the problems of head injury. And we also discuss among ourselves what it is that we can do better to, number one, prevent, and number two, help the patients who suffer a head injury. And what better way to do that? What better way to do that than to get the strength of the Kauvery Hospitals group here? Give yourselves a big round of applause, please. Because very frankly, when I was speaking to people when we were just about discussing how to go about this, if you actually look at the Kauvery Hospital group, if you look at the neurosurgery, neurosciences, ER, radiology, you look at the group and the expertise and the experience that we have here, it is frankly unmatched. And I'm very proud to say that I do not think we have anywhere in the country such a strong group which is dedicated to patient care. And I'm really proud of this. And I would also like to thank each faculty member who's come forward and traveled and come here on a weekend to be a part of this conclave. The other idea of this conclave is also to showcase the possibility of collaboration between and within the Kauvery group to perhaps do multicentric research, bring out data, and also perhaps bring out scientific papers and presentations. And that would be phenomenal once we start doing this. And I think this conclave can be a starting point for something like that across the group. And I think there are senior, very, very senior people here, Dr. Mohan Sampath Kumar, Dr. Ramakrishna Ishwaran, my colleague and friends, Dr. Ranganathan Jyoti, Dr. Jose Jasper, and many others who are pioneers and doyens in their field. And I think if we all can come together and do phenomenal research work on multiple fields, let us start with the most common field a neurosurgeon tackles, which is head injury. And not only that, we also want to focus on the work done by the ER, the EMTs in the ambulance for on-site care, which is equally important, and also the work done after and beyond what neurosurgery does, which is in the neurocritical care concepts, which is as important as us doing surgery or anything else. Radiological possibilities on how to detect early problems, detect them early so that we can work on them early and sort of rectify those problems. And finally, rehabilitation of these patients to get them back into active social life. So I think there is a lot of work that we can do together, and we should start doing together, and let this be the starting point of that. So I won't take much more time. This program is going live on YouTube Live, and we'll share the link with all of you so that you can send it to all your friends. Those who could not be here can watch it live and gain from this knowledge. Thank you very much.
Check. Thank you, doctor, and to anybody who's involved in saving lives, applause to all of you. I think you're all equivalent to God. Thank you so much. And let's quickly move on to the session 2. May I now invite the chairpersons, Dr. Ramakrishna Ishwaran, Director Neurosciences, Kauvery Hospital, Bangalore region. As I call by all the chairpersons, I request all of you to kindly give a big round of applause and welcome them onto the dais. Dr. Meena K, HOD, Emergency Medicine, Kauvery Hospital, Radial Road, Chennai. Dr. Sriram Varadarajan, Senior Consultant, Neuro, Radiology and Clinical Lead, Brain and Spine Imaging, Kauvery Hospital, Radial Road, Chennai. And Dr. Rajesh Menon, Consultant Neurosurgeon, Kauvery Hospital, Alvapet, Chennai. Kindly join us on the dais, and thank you.
Thank you, Sridhar, for the invitation. It's a very nice gesture to do on the World Head Injury Day. And thank you again for, setting the agenda and the pace for today's meeting. More importantly, for what's going to follow this from now on. Right. So, we start with the first talk. This is by Dr. Preeta Elangovan. She is the HOD and Consultant of Emergency Medicine at Kauvery Hospital, Vadapalani, Chennai. She's going to talk about pre-hospital care, the road behind, and looking ahead.
Yeah. Thank you, sir. Good morning, all. I'm Dr. Preeta from a ER consultant from Kauvery Hospital, Vadapalani. My topic today is pre-hospital care in traumatic brain injuries, which is an interesting topic because there is a scope of improvement, as Dr. Sridhar Chris said. So we could be able to establish a pre-hospital setup, EMS setup within Kauvery Hospital. So with this note, I'll proceed with my topic. So the road behind, what does this phrase mean? So what happens before the patient even reaches the hospital determines the neurological outcome in traumatic brain injury. So what happens when there is an impact, when there is a trauma? So the patient suffers a primary injury, which could be a hemorrhage or a contusion, or it could be a DAI, diffuse axonal injury. But what happens afterwards in the golden hour, in the few minutes starting from the field to until the patient is transferred to a level 1 trauma center where the patient undergoes imaging and has definitive neurosurgical care. So what happens during this time is a lot of changes happens at the cellular level, which includes generation of free radicals, neuroinflammation, and neurotoxicity, which can affect the mortality of the patient. So the strategy here is to rapid assessment, stabilize the patient at scene, and quickly transfer the patient to the level 1 trauma center. So what causes these secondary injuries at the tissue level? So there are 3 heads which usually causes it. So which is an episode of hypotension where the blood pressure, low blood pressure starves the injured brain of perfusion, and hypoxia, inadequate oxygen delivery compounds these cellular damages, and hypocarbia as a result of hyperventilation. This causes cerebral vasoconstriction. So the recent studies over the past 2 decades have confirmed that even one episode that happens before the patient reaches the definitive care facility, it could double the mortality of the patient. So as per ATLS guidelines, so initial stabilization, assessment and stabilization involves control of any external bleeding, followed by airway. So care should be taken when it comes to traumatic brain injury that we should presume all cases of severe brain injury to have C-spine injury as well. So care should be taken when we are trying to open up the airway. Instead of using the head tilt jaw thrust maneuver, we are supposed to, head tilt chin lift maneuver, we are supposed to use the jaw thrust. With when there is a threatened airway or the GCS is low, we have to intubate the patient. The guideline still says the same, GCS less than 8. So use of airway adjuncts like oropharyngeal airway, nasopharyngeal airway, supraglottic devices like LMA can be used with C-spine, with care on C-spine immobilization using a hard collar or manual inline stabilization. So breathing. Routine use of high flow oxygen is recommended in all the studies, even if there is no hypoxia at the scene. So if the ventilation is inadequate, it also recommends the use of back mask ventilation. So circulation, as per ATLS, 2 large bore IV access, and we should use isotonic fluids like normal saline for resuscitation. Disability scoring, we have to note down the GCS at scene with the pupil assessment, noting the size, symmetry, as well as the reactivity, and look for any lateralizing signs at the scene and en route during transport. Exposure, full body check for other associated injuries, other system involvement, polytrauma, and care should be taken to maintain euthermia in these patients. So what does the updated physiological targets say? So we have new standards over the studies from recent years, from 2023 to 2026, after the publishing of BTF third edition, which states that the blood pressure should be maintained more than 110. It's not 90. It's not anymore 90. It's not anymore MAP of 80. So the systolic blood pressure should be maintained more than 110 in the age groups between 15 to 49 and more than 70 years, and they have given a slightly lesser target of more than 100 in the age groups 50 to 69. So oxygenation, you have to oxygenate the patient to maintain the saturation more than 90 as per the BTF EPIC studies. But there are few studies like SIBCC, which is Seattle International Brain Injury Conference Consensus Study, which or even suggests maintaining the saturation more than 94%. So ventilation, we have to avoid hyperventilation in order to avoid hypocarbia, as we have seen in the sessions in the morning. So what it can cause to the cerebral perfusion, and how it can affect the penumbra, the survival of the penumbra. So ventilation should be monitored via capnography en route and it should be maintained within 35 to 45 mmHg. So temperature, all the studies suggest monitor and maintain euthermia between 98 to 99 degree Fahrenheit. So common pitfalls to avoid, apart from preventing hypoxia, hypocarbia, as well as hypotension, the common mistakes. So head injury usually can coexist. There could be confounding factors for altered mental status, which could be drug intoxication or alcohol. And it should not be presumed that altered mental status is attributed to those. And moving the patient's neck without stabilization at the scene, and removing helmets unnecessarily without using proper maneuvers with inline stabilization for removing helmets by untrained professionals. So rash intubation without proper indication. So the recent trials have also discussed about the use of Tranexa in the pre-hospital setup. So the routine use is not supported, though certain studies have shown beneficial in moderate to severe TBI, it is not strongly recommended. So transport and documentation before getting the patient to the definitive care center. So all these field triage protocols should alert the EMS to directly transport these patients to a level 1 trauma care center where there is imaging facility and there is a neurosurgical intervention which is possible instead of stopping at small clinics or small centers. So key interventions, all these recent trials and studies supports that to maintain oxygenation and certain blood pressure targets, and we have capnographic reading targets. But they strongly say that these key interventions like intubation, doing an RSI for airway protection, or using mannitol or hypertonic saline to treat ICP, raised ICP or herniation, seizure control, all should be done only if it is clearly indicated. So documentation is very critical for the continuity of care. So the EMS at scene should note down the mechanism of injury, GCS assessment at scene. So various studies have suggesting that the motor response in the GCS component is very important when you are going to pick up the patient at scene, and even monitoring the motor response is very important during the transport. So any drugs, intoxication, or the drugs that you use for sedating the patient, all should be documented. And the GCS and pupils reactivity size and should be recorded every 30 minutes during transport to the definitive care center, including the vital strengths, which include saturation, heart rate, BP, and the capnography readings. So looking ahead, though we have defined protocols in place and all these studies have given us protocol-based simple interventions to be followed, whether it is executed, whether it is practiced everywhere, no. So there is no equity in access, still challenges remain. So looking ahead is this, what does this phrase mean? So the road behind will prevent the mortality, but looking ahead is what we should do better than the damage control. So goal-directed resuscitation in the field, tailoring based on the mechanism of injury, the physiological response with the real-time monitoring. So this includes a smart monitoring in ambulance with telemedicine, 5G incorporated. So pre-hospital, strict enforcement of pre-hospital neuroprotection algorithms, setting up advanced pre-hospital teams, and personalized field resuscitation with incorporation of predictive AI and decision support tools. So smart monitoring in ambulances, these are emerging tools. So we have all these studies recommend to maintain portable to monitor portable capnography with readings between 35 to 45 mmHg. This ensures optimal ventilation and non-invasive BP trending. Real-time, this will help in real-time hemodynamic assessment and NIRS near-infrared spectroscopy for detection of cerebral autoregulation and any hematomas, intracranial hematomas present. So incorporating predictive AI tools will into this EMS data will help will help the EMS in triaging, predicting the triage severity, and predict outcomes in real time, enabling smarter decision in destination, resource allocation, and earlier intervention. Advanced pre-hospital teams, which includes physician-led teams, which is in practice in Europe, certain countries of Europe, where doctors respond directly to the scene, and training the critical care paramedics with expanded scope of practice, and telemedicine integration, where these ambulance have a camera and these are connected by 5G. This can be relayed in real time to the referred center, where the real-time guidance with regard to fluid resuscitation or ventilation can be provided by the emergency physicians, and even a virtual trauma team can be activated. A neurosurgeon can be called on to ER even before the patient reaches ER. So what are the capabilities when a physician is involved, or the critical care paramedics when they are trained to secure an airway in via rapid sequence intubation? They can use controlled intubation with sedation and paralytics, field ultrasound, apart from doing E-FAST to assess the other life-threatening, to predict other life-threatening injuries like tension pneumothorax, cardiac tamponade, or intra-abdominal bleeding. We can also use the POCUS to assess the ICP via optic nerve sheath diameter measurement. So early blood products usage, when it is all activated, when we have a smart monitoring and it's all connected via 5G, so we can, during the time of activation, we can send along blood products to scene. Training the first link. So looking ahead, it's not about setting up fancy monitoring devices, but also training the community people. So because that first 10 minutes, even before the EMS activation and ambulance arrives, is handled by the lay responders in the community. So training should involve police, bystanders, and drivers. What they should be trained of, all about TBI awareness, head injury. So management, helmet use, and importance of early EMS activation. So the context for India, strengthening the ambulance services, even if it's going to take time to strengthen 108, but of course, as Sir said, we can incorporate the Kauvery ambulance, we can form a team, we can make some standardized TBI protocols, and these involve low-cost innovations. It's not like a high investment. All the ambulance should have portable monitors. There should be structured checklists to follow, and establishment of regional trauma networks. So looking ahead requires task shifting to community responders, mobile-based triage algorithms, policy-level investments in trauma systems and road safety measures, so that the ambulance will be able to reach the definitive care center within the golden hour. Summary takeaways: pre-hospital care for TBI focuses on preventing secondary brain injury by avoiding hypoxia, hypotension, and managing ICP. So updated guidelines emphasize on higher blood pressure targets, continuous capnography, and immediate oxygenation. So the road behind has been uneven, with marked gaps between guideline recommendations and on-ground reality. So looking ahead, the main themes are standardization, data integration, and equity. Implementation will require structured training, protocol integration, equipment upgrades, and compliance monitoring. The future of TBI care begins at the roadside, guided by data, precision, and speed. So the road behind prevents death. The looking ahead ensures meaningful survival. Thank you. Yes, sir.
Thank you, Preeta. We'll call the next speaker, Emergency Room Management of TBI, the pit stop by Dr. Ashok. Okay, the consultant and clinical lead, Kauvery Hospital, Alvapet. The discussion, after all the three talks we can have.
You have 12 minutes, Doctor.
Okay. Very good morning, all. I'm Dr. Ashok. I'm from Alvapet branch. I'm heading the ER there. So, Dr. Preeta had already mentioned about secondary, brain injury prevention, which is one of the main goals for the ED doctors, is to prevent secondary brain injury. So, as she was mentioning, there is, outcome of a patient following a traumatic brain injury is mostly dependent on all the sets of care, pre-hospital, intra-hospital, and I mean in the ED and in the theatre. So first of all, we need to ensure that the secondary brain injury is prevented. So rather than going to D, it should be A, B, C, and then D. And as she mentioned, we should not forget C-spine. So this one I would like to mention here, that this is a score alternative to GCS, which can be used in a patient who is already intubated. And the lower the score, it is directly proportional to the severity of coma in patients who are intubated. So regarding secondary injury, so any kind of insult in any vital parameters will worsen the amount of secondary injury. So the last thing, pain, which I would like to emphasize here is, mostly what we do in the ED is, particularly if the patient is having borderline GCS and there is no clear indication for intubation at the onset, then if the patient is being shifted to neuro ICU for medical observation or management, what people don't give importance is that they don't ensure that the patient is comfortable throughout, in the sense, for example, if you are catheterizing the patient, the amount of effort you put to ensure that they are comfortable during the process and securing an IV access, all the small things, we need to ensure that it is done at an extremely comfortable level so that it doesn't indirectly increase the ICP. So these things she has already mentioned. So cerebral perfusion pressure is, we can't, in the ED we can't measure intracranial pressure. So the only way is to ensure that MAP and the systolic blood pressure is maintained above 100 in certain age group and more than 110 in certain age group. So if you see the graph of cerebral autoregulation, you can see that the normal, the perfusion pressure drops significantly once the MAP goes below 80. Yeah, so this was already emphasized. So any drop in systolic blood pressure less than 100 will definitely increase the mortality into 2. So we need to be extremely cautious. And you need to remember that there is the role of permissive hypotension in a patient with traumatic, polytrauma shouldn't be applied when a patient is also having a traumatic brain injury. So you need to ensure that the blood pressure is maintained above 100 systolic at least throughout. Yeah, again, as I mentioned, there are certain measures which can reduce or prevent increase in ICP. You need to nurse the patient with the elevated, head elevated position up to 30 degree, and you need to. So there is a concept called, rather than spinal immobilization, there is a recent concept called spinal motion restriction. So you need to ensure that the hot collars placement should not affect and indirectly increase ICP. So as you all know, there are two options to when it comes to giving anti-edema measures. One is mannitol and other one is hypertonic saline. So mannitol, you need to be careful in patients who are already in shock otherwise, and if they are having renal impairment, it should be avoided, whereas in those situations, hypertonic saline is what is preferred. And the last point is routine use of anti-edema measures where the patient is not having moderate or severe traumatic brain injury is not indicated. So again, coming to the sugar levels, even glycemic control is of very most important. So what they recommend is you need to maintain a target of somewhere around 140 to 200. Anything low or more can impact and can lead to secondary brain injury. Yeah, so ETCO2, she had already mentioned about it. You need to target between, ideally between 35 to 45, but this is controversial. In case when a patient is crashing and you can see that the patient is, for example, going into herniation, there is a concept which supports that a temporary measure where you target hyperventilation, but then that hyperventilation should not be too much so that the ET CO2 drops below 25. It should be maintained between 30 to 35, not less than that at all. And regarding post-traumatic seizure, based on the onset, if it is less than 7 days from the time of injury and more than 7 days, less than 7 days, it is called early post-traumatic seizure. Within that period, in situations where there is a moderate or severe brain injury, it is recommended to give anti-epileptics in the ED, but it will not prevent late post-traumatic seizure. Okay, and the role of anti-epileptics in early traumatic seizure, post-traumatic seizure, to be continued as a long term is a question mark, which I think the panelists would be able to help us. Coming to RSI, this is very, very important. Particularly, you understand that RSI is performed in patients who are having moderate and severe brain injury only, and not when in mild cases. So it is very important what drug you choose, and what kind of paralytic agent you choose, and what steps you follow to ensure it is extremely smooth. Yeah. So laryngoscopy in the background of inadequate sedation is a bad thing, particularly in a patient with an increased ICP. The concept of administering pre-medications, for example, fentanyl or lidocaine, which is preferred in children, is again, not very concrete. So, for example, studies say that fentanyl you need to be giving from, here I have mentioned like 2 to 3, which is the normal dose which we give. However, as a pre-medication, what they recommend is up till 7 mics per kg, which will be a very huge dose. And it can actually cause more complication rather than preventing the sympathetic drive secondary to laryngoscopy. So, in a nutshell, it is better to prefer proper sedation rather than trying to give pre-medication. So these are the induction agents of choice we have. Out of these 4, thiopentone and propofol can significantly reduce the blood pressure, so it needs to be used with extreme caution. Particularly if there is an associated injuries which is causing blood loss, then it's a big no. You should not use thiopentone and propofol at all. Etomidate. So as I mentioned, it can, the hemodynamics are unpredictable and it can cause significant drop in blood pressure. Etomidate is one of the drugs which can be used, particularly if the patient's hemodynamics are maintained and the patient is having isolated brain injury. Ketamine, they used to tell that before ketamine and scoline was relatively contraindicated in a patient with increased ICP, but then the concepts are changing now. Particularly in a patient who is having a polytrauma and associated hypotension, ketamine should be considered. So, post-intubation sedation. So this is also one of the common mistakes we do in the ED, where we sedate and paralyze the patient, we intubate, and then, for a brief period of time, people tend to forget to maintain the sedation. So it is important to continue immediately after the intubation as such. So midazolam and propofol, provided the patient is having an isolated brain injury and there are no other associated injuries, is the drug of choice in this situation to maintain sedation. So rocuronium is preferred when it comes to paralytic agent. And after intubating, long-acting, so for example, vecuronium can be used to continue with paralyzing the patient. As I mentioned, you need to be extremely gentle when the RSA is being performed and ensure that the patient is completely sedated. Your laryngoscopic technique should not induce gag. So if it happens, then indirectly it says that there's a possibility that you are increasing the ICP. So Preeta was mentioning about tranexamic acid, which is not recommended in traumatic brain injury. That is in pre-hospital setting. Whereas if you have diagnosed intracranial bleed, traumatic brain injury in moderate and in severe cases, it is recommended that you give tranexamic acid. That is particularly if the patient comes in within 3 hours of the injury as such. So regarding anticoagulation reversal, it will be a very tricky situation for patients who comes with traumatic brain injury who is on anticoagulation. I mean, recently there was an article from Trichy Kauvery, I believe. So this was warfarin-induced coagulopathy, and the patient had bleed, and that patient received a 4-factor PCC. And apparently the patient improved significantly. The problem with 4-factor PCC is it's expensive. However, the duration on the onset of action is only 15 minutes. So in an emergency situation, it can be considered, whereas the alternative would be FFP, for which you will have to cross-match. You need to thaw the FFP, and then only you can transfuse, which will take loads of time, precious time, in managing the patient. So I have mentioned the respective anticoagulation reversal for the various anticoagulants. So this is an interesting thing. I don't know if it can be used in India, or this is FDA approved is what I went through online. So brain injury markers, there are multiple markers as such, like we do troponin for the cardiac status. So one of which is like GFAP. So they say that this marker will not be elevated. It's quite specific is what they say. And another one is UCHL1. So this again is also similarly effective, and it can be done. The ISTAT, which we do troponin, they have these markers being used in the USA. And they say that it can be used in situations where you suspect concussion, or the patient is not having definitive indication for a CT brain, or where the facility is not immediately available. So you can consider using this. I'm not sure how useful it will be or if it is recommended. And yesterday we had a patient, a nurse who came in from Omundra, actually ER nurse. She sustained traumatic SAH. So the neurosurgery team has seen the patient, and so one of the consultants was calling, and we were discussing because we received calls from Omundra ER to know how she's doing. So she had SAH, but clinically she was doing good. So I was wondering, should we consider using nimodipine in such cases? I think there are no much of concrete recommendation in traumatic SAH. I mean, correct me if I'm wrong. Yeah, thank you.
Next is calling Dr. Professor G. Jose Jasper, HOD, Brain and Spine Surgery, Kauvery Hospital, Cantonment, Trichy, for delivering his lecture. The relevation point, imaging in traumatic brain injury under the scanner.
Okay. So my talk is about how to proceed with imaging in traumatic brain injury. Now, I'm not going to talk about all this. All this we know, the types of primary brain trauma that we see. Vascular injury, neurovascular injury as a component of traumatic brain injury, and chronic sequelae of brain injury, like all your encephalopathies and dementias. So your imaging has to cover all this. To start with, what does the Radiological Society of North America say about imaging in traumatic brain injury? It has to serve only two purposes. One, it has to help you make a therapeutic decision. Do I need to operate? Can I medically manage, or I just observe this patient? So therapeutic. Second is prognosticating. To counsel the family, plan for rehab, prepare for end-of-life care. And in India, very important, we have to prepare the patient relatives to understand the gravity of the situation, plan their financial workup so that they know whether they can afford the care here, etc. So which scan do we do? There are lots of scans. We know you have X-rays, ultrasounds, CT, MRI, angiography, PET, SPECT, etc. And there are lots of guidelines. What scan do I do? When do I do? There are lots of guidelines. NICE, PICAN, Nexus, Canadian HCT, all that. But again, I'd just like to simplify and place it in front of you. Going back to the same RSNA statement, 2025, very clear, no role for X-ray in any form. CT brain plane is the methodology of choice. MRI only in certain indications. Persistent neurological, cognitive, behavioral changes or new onset or progressive deficits which you're not able to attribute to the CT findings. Only then you do a MRI. All other investigations like MRI DTI, MRI spectroscopy, MR perf, perfusion study, PET, SPECT, vascular, MEG, all these are research products. So X-rays, no role, even for cervical spine injuries, only in certain very low risk scenario where you have a very mild clinical suspicion, you can consider X-ray. A better investigation is a CT scan only. So why CT scan? Why do we think of CT scan and not a MRI scan? One, it's easily available. Everywhere it is easily available. Very cost effective. It saves time. A CT takes between 2 to 3 minutes. MRI takes at least 40 minutes. And half your patients are going to be intubated, hypotensive, hyperglycemic, fighting for their lives. And you don't want them to spend 45 minutes inside the MRI machine. And it is easy also because otherwise your ventilator has to be MRI compatible. All those things come in. You don't know whether the patient has a foreign body inside. All those things can be adjusted. And it's very easy to interpret. I am sure looking at the CT, it's very easy to make out a fracture, parenchymal injury, vascular injury. MRI, very, very difficult even for trained radiologists to interpret. So what does the NICE guidelines say? They divide it into two, below 16 and above 16. Adults and below 16 is the children or the pediatric population. So in adults, CT must always be done within 1 hour. Obviously, you have to think of all those X, A, B, C, D, E and all that. A GCS score less than 15 is always an indication for a CT scan. You don't need any other criteria. 15 is the number. 2 hours after the head injury, the patient's GCS is less than 15. It can be even 14, but you have to do it. At admission, GCS 12. And if you suspect any fractures at all, any focal neurological deficit, any post-traumatic seizure, all these are basic indications. And in adults, even one episode of vomiting is an indication for CT scan according to the NICE guidelines. Why I have highlighted that in red is because when you go to the pediatric population, all the others are the same. GCS less than 15, you do a scan. If you suspect any fracture or the fontanelle, open fontanelle is tense, you do a scan, CT scan. Any focal neurological deficit, any post-traumatic seizure. But vomiting, up to 3 episodes, you can sort of take it lightly. But in adults, it is 1 episode. And if you think you have a suspicion, it's a non-accidental trauma, maybe abuse, then you have to go in for a scan. And in babies, even scalp abrasions or bruising more than 5 centimeters is an indication for a CT scan. And again, in NICE, age more than 65, always safer to do a CT scan. So GCS 15, absolute criteria, less than 15. Age more than 65 is also a criteria. If the patient already has a bleeding disorder, known case, half the population now is on aspirin, cloplet, and apixaban, and on all the other drugs, neuro-oral anticoagulants. Any dangerous mechanism of action of injury, very common in India. All our RTAs are dangerous. And more than 30 minutes of amnesia. This again, why I have highlighted in red is because obviously there's a difference. For the pediatric population, any loss of consciousness or amnesia more than 5 minutes is enough to make you take a CT scan. If there is any drowsiness, so again that is a very subjective term, drowsiness, any dangerous mechanism of injury and current bleeding and clotting disorder. What they say is you have to see whether you can try the minimal dose of radiation possible for the pediatric population. But there is another one, PECAN. This is a Pediatric Emergency Care Applied Research Network. They say very clearly, In a child less than 2 years of age, if the parents feel the child is not normal, it's a purely subjective. GCS is 15, child is not drowsy, there is no bleeding diathesis, nothing, no fracture, no skin abrasions, but the parents feel my child is not normal, again you have to take a CT scan. Now findings, I'm not going to spend too much of time here, I'll just run through it a little bit. CT scan, simplest and easiest finding, obviously the different types of fractures, linear fractures, depressed fractures, comminuted fractures, open fractures, skull-base fractures, all these can be very, very easily made out in a CT scan. We cannot do this in a MRI. And another one place where CT plays a very big role is in 3D construction. Most of these severe head injuries that we see, because most of our population do not wear helmets, so they end up with a craniofacial injury. And you're going to operate with the plastic surgeon, craniofacial surgeons, etc. And a 3D reconstruction is a very useful tool to have. Epidural hematoma, again, usually temporal, biconvex, within the sutures, it is limited within the sutures, very severe mass effect. It's a very good indication for emergency surgery. And always there is associated skull fracture with predominant middle meningeal artery involvement. Subdural hematoma, the plane of the blood is inside the dura. It is subdural and it causes direct compression on the brain, so it can cause local hypoperfusion, local hypoxia. And it is crescent shaped, concavo-convex, and usually it causes severe mass effect. Again, this is a very good indication for surgery. Subarachnoid hemorrhage is usually a part of a coup contra coup injury concept, where you have direct vessel injury causing bleed into the subarachnoid plane. And if blood is found predominantly in the sylvian fissure or one of the skull base systems where you know the circle of Willis is, you have to definitely think of an aneurysm also. Going on to the intraaxial, the parenchymal injuries, we know all this. Surface contusions, parenchymal hematomas, burst temporal lobe, burst frontal lobe, diffuse axon injury, post-traumatic infection, brainstem injury, all these also form a part of the continuum of health injury gamut. So intraparenchymal hematomas usually are again part of the coup contra coup injuries, very commonly found in the frontotemporal region, and these parenchymal lesions can cause subfalcine herniations and uncal herniations, which is why you have to be very, very careful. And always remember, if you have any neurological or clinical deterioration, urgent CT scan irrespective of the time is mandatory. So any worsening in neurological status, especially in the first few hours, you have to be very careful. When do we routinely repeat a CT? We repeat a CT within 6 to 12 hours if the first CT is abnormal and if the patient already has clinical deficits. If you have multiple contusions in the brain, then even one of them can sort of expand and grow. Acute subdural, which you are managing conservatively, acute epidural, which you are managing conservatively, and even SH, because 1/3 of this population will go on to worsen needing surgery. Delayed repeat CT. You can repeat a CT after 12 to 24 hours, especially in the elderly, age more than 65, and especially if there is any coagulopathies, either iatrogenic or inborn. Another just 2 minutes. So is there a role for MRI? MRI, lots of advantages, but major disadvantages: cost, limited availability, length of examination time, difficulty in interpretation. All this do cause a problem. But in certain clinical cases like diffuse axonal injury, brainstem injury, and persistent coma, it can play a very good prognosticating role also. So when you see a patient who's unconscious, a MRI can show you a brainstem injury component, a diffuse axon injury component, and help you prognosticate that the patient is going to take at least 4 to 6 weeks for recovery. Another thing is MR tractography. We have done quite a few patients, especially delayed after 3 to 6 months after head injury, where we have found that when you do a tractography post head injury, if the predominant injury is on the left side, then the left side tracts definitely show atrophy. And another indication is in patients with persistent coma, where you can do a tractography of the reticular activating system also. This also is possible and is being done. But all these do not come into the immediate post-traumatic stage. So all the other investigations that I said, all this need expert judgment, and it depends on the particular patient. If you think there is a post-traumatic aneurysm, you might ask for an angiogram, maybe even a DSA. So that keeps on changing, and that is very patient-specific and then cannot be extrapolated and constructed and considered to be guidelines. So again, going back to the RSNA statement, no role for X-rays. CT brain plane is the imaging methodology of choice. MRI only in clear-cut selected cases to prognosticate, and all other investigations is pure research based only. Thank you.
Sir, thank you, sir. We'll just request you to be on stage, sir, if there are any questions. And also the previous speakers, we would kindly request them the stage is open for discussion. And knowing Dr. Sridhar sir's, strict agenda for time, we would have at least around 5 to 6 minutes, sir, for the discussion.
Sriram, I have a question. Since this is a pan-Kauvery thing, the very good thing we have the ER HODs of all 3 units. We have the neurosciences HOD from RKE sir is there, Sridhar sir is there, RJ sir is there. We have radiology, Dr. Sriram, Dr. Satya here. Yes, Salem also. That's why I wrote pan-Kauvery. So the thing is that I just want to know, see, when we are trained, any polytrauma that comes, the teaching we have is we do a CT brain, CT spine, trauma series, then fast. I just want to know what the consensus here, what is being practiced in all these units, because we see a lot of variabilities happening over places when people, the manipulate, the physician's judgment call, idu matta pannunga, adu matta pannunga, because there's a meta-analysis saying react to steady. Pan CT, which used to be done for all patients, now is gradually coming down, because the CT brain, C spine, and the trauma series and fast is again coming back. But here we have a caveat also. For the ER physicians are well trained to do the ultrasound on emergency basis. But what happens when they are not? What happens? You don't have a radiologist on call doing this. So I just want to know what is the consensus in all these places.
Sir, here, I mean, in Kauvery Allopet, what we do is, it depends on the patient's presentation mainly. If it is a polytrauma, then definitely we'll go ahead with trauma protocol CT with IV contrast. Yeah.
That you mean a pan CT?
Yes.
So we usually involve our trauma team during the secondary survey as early in the ED. So when we have information about the patient coming in the ambulance, we used to activate the trauma protocol, and at least we will be able to assemble the general surgeon and orthopedician. So if it is an isolated injury with regard to the system, we'll go by individual CT, and as usual, we'll do the trauma series X-rays, X-ray chest, pelvis, and EFAST by the ER team itself. But in case if it's a low GCS and with unstable vitals, we go for pan CT.
I'd like to hear the surgeon's perspective, because as surgeons...
One thing important
Can I?
Which he said, unstable patient, what you said?
Unstable hemodynamics. With low GCS patient is intubated when the history is not very clear, the mechanism of injury is not clear. The presentation, when we examine, we do find some external bruises and all that. Seatbelt injuries, when we suspect seatbelt, we'll go for pan CT.
See, unstable means, that doesn't mean instability. Unstable means patient is hemodynamically unstable.
Hemodynamically unstable.
We don't do a CT at all, right? Hemodynamically unstable patient has no business in the CT suite, right? A trauma patient who has got hemodynamic instability, fast positive, has to go to the OT.
OT directly.
Right? So this is the thing. So the investigation part is very, very clear.
That is why this question came up, because there should be some consensus. Because as surgeons, for me, I'm just bothered about the brain and spine. That is cleared, or that is the emergency. I just want to know, because many other times at the ground level.
Can I?
Yes, sir, please.
Yeah. I think what Dr. said is very clear. It is, although we have guidelines, finally it's expert driven. What we are doing in Kauvery is like that only. So when the patient comes into the ER, there is a very good ER team, I think across all Kauverys now, which is led by good people. And most of the teams are there on site now, because at least from our center, I can tell you, when the patient comes in, there's a neurosurgeon already there, there's an orthopedic team there, plastic, whatever, everybody is there. So screening CT is not something we do routinely. We do a CT brain, we do a EFAST, we do a X-ray chest. We monitor all the parameters. What is necessary is done. And if you still feel you need a screening CT, yes, definitely. But all this is done only after you stabilize the patient and primary care is given.
No, I think I would like to differ with you. So it's not like that. See, the imaging protocol is very clear in the ATLS principles, okay? But thing is that many institutions, we don't talk that language. We should start talking that language of trauma. When a patient comes, we should say that the patient is hemodynamically normal. If he is abnormal, he is a transient responder or a non-responder. So this kind of communication is, although people are trained in that, they don't communicate in that way, all right? So if a patient is hemodynamically abnormal, and if he's a transient responder or non-responder, so that becomes a priority. Forget about CT, brain, everything. Hemorrhage control becomes a priority. When a patient is hemodynamically normal, and if there's a severe head injury, it is wise to do a pan CT, because you take the patient immediately to the theater, you waste time in doing CT chest, X-ray chest, pelvis, abdomen, everything. And if the patient has got a pneumothorax, which you have missed, it's a simple pneumothorax, which will not be evident clinically. By the time the rush hours, you shift the patient to the theater, when you ventilate the patient, it's going to become a compound pneumothorax, tension pneumothorax. So then when the patient's decompression is done, the patient is going to have hypotension. So they will not be responding. You will not know whether it is post-decompressive hypotension or because of brain bulge and because of post-DC there's hypotension. So all these things can be avoided. And pan CT, most of the Australian ICUs, I think they go with pan CTs. I think Dr. Satish, like said, in our institution, I think we need to standardize this based on patient's hemodynamics and the severity of the head injury. If the patient has mild head injury, fine, whatever your protocol will work. But if the patient has to be urgently rushed to the theater, it puts a lot of enormous stress on the anesthetist and the intensivist who's going to take care of the patient without knowing what's happening to the other parts, which can progress over a period of time, which may not be evident on the presentation.
So when I started the question, I told pan CT was routinely done more. Now it's come down because the REACT-2 study, which was meta-analysis, said, no matter how many pan CTs you do, the person on the ground makes the decision. So like Dr. Joseph said, if there's enough people on the ground to make experienced judgment calls, that is also very effective. Just because you get a pan CT is not that we rule out everything. So pan CT initially in institutions, level 1 centers, where they used to abuse pan CTs, where they used to do for all patients, GCS 15 walking also, do pan CT, do pan CT. So what happens is, எல்லாருக்கும் pan CT பண்ணுவாங்க. So the radiology, themselves they got confused. So the effectiveness of the radiology also came down. So I think if you have an effective ER team running, the judgment call on the on-field people are able to make the judgment call, that is also very much valid.
Thank you, Dr. Satish.
I'll just say one point and close, sorry. We did an audit, sir, around 3-4 years ago we did. I know Sridhar sir is very angry, sorry. But yeah, I know you are bothered about the time, I understand. But we did an audit where we were doing pan CTs for all the patients. Then we did the audit. In fact, the audit was brought up because Dr. Manivannan was very worried about why so many CTs were being done. And all the patients, the first time you do a pan CT, in a private hospital, you have to talk of cost also. So when that happened, we did the audit and we found out that, in fact, the radiologist, the emergency physician, all this team put together, when we converted into conversion rate or findings which affect your treatment, the percentage was very less, which is why we have switched over to this. We'll have a talk later. Now,
No. One small point. So the judgment call, what you are talking now, it's not necessarily to do an X-ray pelvis for all the patient. It's not necessarily to do fast for all the patient. Okay, so that's also a judgment call. Only in patient as adjunct to primary service, these are allowed. When a patient is unstable, when you cannot shift the patient to the CT. So like how you argued, there's no need to do a X-ray pelvis for all the patient who can walk. What's the point?
Okay. I take your point. I think these are solutions that are being evolved over a period of time. From a time when we used to do reckless CTs, we have moved on to focused CTs. And the call should be taken by the people in the emergency as to how stable the patient is, whether he can go to the CT suite or not, and what should be done in the CT. Brain CT is very fast to finish. Other things take a long time.
I'll end this.
Final.
I'll end this with one comment. I think what we are talking here is across a spectrum of patients. I think we must realize that. So it has to be case specific, and it has to be age specific also. So I think both these are there. So I think it will be good we can pan Kauvery, sit down and create a protocol for what will work and what not. The protocol can change over a period of time depending on audits and other things. But I think if we do a protocol, pan Kauvery, it will be a good opportunity now to kickstart thinking of doing a protocol pan Kauvery. So I think
Happily put, sir. Pan Kauvery, Pan CT. We'll be able to understand when is the need to do it or when is the need not to do it.
great. So
So about moving the unstable patient to OT, that also we have to be.
yeah,
That's-
those are all things which
Yes,
will
sir.
come off in the protocol.
Thank you, Preeta. Thank you, Ashok, and thank you, Jose. Very nice contributions, and you set the pace for the whole meeting today. I think others also will hopefully stick on to the time.
I just want to say this, being so many experts and having in Kauvery, all three Kauverys, I'm telling in Chennai, we should have an integrated, well-integrated trauma system, sir. So that we have to bring Kauvery Hospital as number one trauma care center in the city. Yes, thank you, sir.
Also, a very simple radiology guidelines, sir. For us, the flow chart is very simple. If the ER calls us, the first thing I ask, has the neurosurgery team been informed? If yes, please follow their instructions. If no, please inform them. Thank you so much.
Thank you so much, and please give a huge round of applause to our chairpersons and the list of panelists who came here for the discussion. Thank you very much for this interactive session. Now, moving on, we're going to have a short commercial break. Let's quickly go for a tea break and say come back in 15 minutes exactly. And also we have a group photo that's going to be held outside. So you're all invited to be a part of the group photo.
So just go on to the room opposite. So we will first have the group photograph, and then we will have coffee and get back inside, hopefully in 15 minutes.
Thank you. See you all in 15 minutes. Thank you everyone for being here on time. So let's quickly start off with session 3 under the topic interactive clinical case discussion. And firstly, let's invite the panelists, Dr. C. Krishna Mohan, consultant neurosurgeon, KIMS Hospital, Nellore, to kindly join us on stage. Please give a big round of applause, everyone. Thank you. Dr. Anbuselvam M., Senior Consultant Neurosurgeon, Rela Hospital, Chennai, to kindly join on stage. See, we need more energy as we have lined up of discussions. Dr. Tejas M. N. Rao, Senior Consultant, Spine Neurosurgery and Endovascular Stroke Intervention, Kauvery Hospital, Maradahalli, Bangalore. And let's invite the moderators for the session, Dr. Ponnaya Vanamurthy, Head and Senior Consultant, Neuro Anesthesiology and Neurocritical Care, Kauvery Hospital, Radial Road, Chennai. Yes, please. And Dr. Satyanarayanan R., Senior Consultant, Head of Diagnostic and Interventional Radiology, Kauvery Hospital, Radial Road, Chennai. Over to the moderator, and thank you.
Thank you. So welcome to this interactive clinical discussion, and this is going to be one of the sparkling highlight of the whole conclave. And initially when myself and Dr. Sridhar Dukadar used to do, Dr. Ranganathan Jyoti sir, we are aware of this format, how we used to do. It used to be a very fierce debate, but all subject, and people have different opinions. And before I go into this topic, I just want to know this. So there are known knows. We know things exist, and we know that we know. There are known unknowns. That's to say, there are things we now know, previously we don't know. But there are also unknown knowns. There are things we do not know and we do not know. So if we talk about brain, we know so many things we do not know. And even last year, if I would have said that RCB is going to win the IPL champion, that was unknown, all right? But it happened last year. From 2010, 2012, 13, 14, 15, people are just, and they are also losing hope. And finally it won after so many years. So RCB winning an IPL is unknown. But if I say this year RCB is going to win, I think RCB going to win? See, look at that. So people won't agree. So this he's saying yes, our panelist. So this is not going to happen. But these are all things which are known, but still people argue for it. That Hindi is our national language. Is Hindi our national language? We don't have any national language, and it's written very clearly in the Official Languages Act, but still people believe, my North Indian friends, they don't leave me only when I say, hey, India doesn't have a national language. No, Hindi is Rashtra Bhasha, Hindi is national language. So these are the beliefs which we have. These are all known things, but still people argue for it. All right? So why so many things which I brought is here? Because brain is even more complex than that. We have an anatomy, physiology, blood-brain barrier. Now there are glymphatic systems which you are talking about. Not forget about the vasculature and other things. We talk about glymphatics, which clears all the debris from the brain and improves the outcomes. And even the vascular system, my God, it is not same as other vascular systems, but it needs blood all the time. Throughout the diastole, brain is the only organ apart from kidney which needs blood all the time, which cannot even starve diastole. So he is my favorite actor. He is, I know who, you know who is it? Yeah, Taken, all right? So very famous dialogue. I don't know who you are, I don't know what you want, okay? So most of the times I used to compare with an intensive care job, more so with an anesthesia job, because at the end of the day, we do not know how anesthesia works, but every time we make sure it benefits the patient. It works. Nobody in the world knows what's the mechanism of anesthesia. We give something and you do it successfully with NNT of 1. Only one therapy in the world which works for all the patients. All right? So this is his wife. All right? So she should not have died, but she's no more. You know why she's no more? Anybody know why she's no more? She's also an actress, famous actress. Car accident is not because of an EDH. EDH, we are learning this from our MBBS schools, can kill a patient, okay, at this era. Such a popular actress, okay, she was skiing and she developed an injury. She didn't take she had a loss of consciousness apparently. I don't know which hospital she went, and 3-4 days later, she died. And when in the last presentation, they were talking about a most important thing. We should shift all the patients to a level 1 trauma center. We should not be carrying them at the lower centers. For example, this scan, which was done in an outside CT center, was done in a center where there was no neurosurgical facility. But the first scan, which is there in the top, and when the patient deteriorated, when the patient herniated, coned, then he was shifted to the level 1 trauma center. Sir Anbu Selvan, sir, I'll just go directly to you. So, you know the importance of ED. Can you just stress, should these patients be directly shifted to level 1 center, or if the patient is conscious, they are okay, hemodynamically stable, they can be still observed in a center which doesn't have a neurosurgical facility?
I feel they should be observed better in a level 1 center.
Level
Even
1
if
center.
you are not operating, the observation should be in a level 1 center, rather than the primary other centers where after deterioration, if you are not able to do, you are going to kill a person who can be saved, whose life can be definitely be saved.
Do you agree with that, sir? Because India is a country where they'll say he's okay. Why should you shift to another center? He's talking, walking, he's eating. Why should you go to another center? So can that be practically applicable?
So what I've observed is, I come from Nellore, and most of the people for me come from the rural areas around the city. And I don't know if it is a fortune or misfortune for the patient that CT is available even at the remote areas also nowadays. The patient before, even if the patient is, this is a talk and die syndrome as you mentioned, EDH, it gives time, sometimes the patient will be normal. So the misconception is that head injury is taken very lightly in remote areas. So it is better when we should educate the people to know the red flags of a head injury. As soon as the patient comes, it is better to shift the patient instead of observing at remote areas. So the patient should be definitely shifted to a level 1 center. So
this is one small example. So the concept is that always a trauma, especially a polytrauma. Polytrauma doesn't mean that patient has to be unconscious, he has to be hemodynamically stable. Based on the mechanism of injury, based on the anatomical and also the physiological. These are 3 ways we classify that the patient is said to have polytrauma. So based on the dangerous mechanism, based on the anatomical and the physiological thing, these patients actually should be shifted to a level 1 trauma center. So we got a 22-year-old female, came as a train accident victim, and she was shifted from an outside hospital with a low GCS of E1, V1, M4. Hemodynamically normal. She had a slight pupillary differences. The left side was greater than the right side. So because the neurology was poor, she was intubated, drug-assisted intubation was done, and CT scan was done here. So initially when I saw the CT scan, I couldn't see any major differences, but there was a minimal pneumocephalus and there was some skull base fracture. So once she is being admitted to the ICU and she was being monitored, she remains to be in this GCS. She was not coming around, she is not obeying commands, although the mechanism of injury say that she has got a severe head injury. She is in this stage. So the neuroimaging aspects, Dr. Jose was talking about advanced imaging, when to do advanced imaging, or what to do next. So next thing, what we thought was whether it could be a seizure, ongoing seizure or non-convulsive status epilepticus, and hence an EEG was done that didn't show any seizure activity. So how would you proceed? Directly we should go with an MRI, or we should wait, or how should we proceed, sir?
MRI need not be done immediately, sir. So we can wait for 24 hours. We can see how the GCS improves. If there is a drop in GCS, then better to do a CT than to immediately go ahead with an MRI. MRI will be mainly for prognostication and how long it will take if there is a diffuse axonal injury.
All right. So we all agree with that, sir. Sir, should we do an MRI immediately in this patient? Because do you expect this finding to be with
the CT showing no midline shift, no mass effect, sulci gyri well seen, you can still observe the patient. And whether we are going to do an MRI is going to, because the CT, this patient is not going to be taken to the theater for the surgery with this CT. But with this CT, the clinical finding is this. So if the patient is going to deteriorate further, or you want to know the patient is not improving from this status, then you go for an MRI to find out whether there is a diffuse cerebral injury component in that. But with this CT and the clinical finding, there is no correlation between the two, and the patient is not going to be taken to the theater. So you can wait, start your treatment for as you are going to treat for a diffuse cerebral injury.
I think here the dictum is when the CT findings are not correlating with a neurological deficit, we have to rule out a vascular injury.
Right, sir. He has brought a point, vascular injury. But before we go that, everybody is talking about imaging. Are there any intensivists here? Should we not monitor the patient further? Or just everything stops here with only imaging in neurosurgery or imaging in brain injury? Should we not check what the ICP is Are we even trying to do the ICP? See the candidate for ICP monitoring? Yes, as per the guidelines, this lady is a candidate for ICP monitoring. There is a pupillary size difference also. So how do we explain that? There's a skull base fracture. Would you like to do anything? Before sir said we have to rule out a vascular injury. Very valid point, sir. So do you agree with that, sir? We should rule out a vascular injury in this patient?
I think a patient like this, I would rather agree with what sir said. I differ from what Dr. Jyoti sir said here, although he's my mentor and my guru. So what I feel is a patient comes like this, we have two sets of problem. One is the patient itself. What is the outcome we are going to give? What is our diagnosis and how we are going to treat? That is one. The second major question that we always answer is to the patient's relatives, because they'll come and ask you, sir, MRI, there is nothing. That is what you're saying. But the patient is unconscious. The CT is normal, but the patient is unconscious and we're already spending so much of money. She's very young, 22. What are the options open to us? Is there a better center? Can we do something differently? Will another hospital do anything different? All these are questions which we have to answer. So what I would do, ICP monitoring, I may consider. We do routinely, but in this patient, I'm not so sure, because Salsai a little bit is still seen, third ventricle is a little bit there, basal system open. So I would rather wait on ICP monitoring, wait for 48 hours, monitor the patient here, make sure all the secondary complications are set right. And within 48 hours, I would rather ask for a MRI, because then I can see what is inside there and I'll be able to tell the patient relatives and I'll also be able to plan.
So we have our radiology moderator here.
You are concerned about the pupils. That's what you are saying, no? You said there is a pneumocephalus. So obviously there is a fracture over the frontal aspect. So it could be a traumatic third nerve or RAPD is going to be there. And as such, in CT, the patient is presenting with a low GCS. She is not deteriorating, so presenting with a low GCS. Obviously, there is going to be a diffuse axonal injury component. So I won't rush for an MRI. But as Sir said, yes, we need to prognosticate. Nowadays, people come out with saying, why not an MRI is not done. So in that aspect is okay, but technically it's not needed immediately.
Point well taken. Diffuse axonal injuries, optic nerve injuries, all these things can happen in these patients. Okay. And about waiting period, but I'm a little bit uncomfortable with it. How can you wait for 48 hours? So you mean to say that if the CT brain is okay with sulci and gyrosine, there cannot be an increase in intracranial pressure?
You say this is a CT scan which shows a increased ICP. What are you going to do? Are you going to do a bifrontal craniotomy? No. You are going to, medical management. So that's what I am saying. A diffuse cerebral injury, you are going to do a medical management, not that you are going to operate. Because there are a lot of studies going on where initial stage of within 24 hours, ICP is more than 20 millimeters of mercury for 15 minutes. Early decompressive craniotomy, you can save the patient, but the prognosis, long-term outcome is not so good. So,
no, we are not even talking about surgery, sir. Just want to know whether there is an ICP or not.
Even if the ICP is going to increase, you are monitoring the ICP and it is high, what are you going to do? You are going to treat, it's going to be a medical management as you are going to give this thing, hypertonic saline or mannitol, or you are already intubated.
So I'll come to this point. Now, without monitoring the ICP, are we going to give something for the patient because the neurology is poor? Are you going to give mannitol? Are you going to give Lasix? Are you going to give dexamethasone? Are you going to give steroids because the patient has got injury? Thank you, sir.
Intubation, you are already intubated, but it is not working. You have already intubated. You are this thing, the ventilation, good ventilation, and good oxygenation. Remove the carbon dioxide. Maintain the carbon dioxide at 30 to 35, and see whether you are going to do the next CT within 12 hours and see whether the ICP is.
So you mean to say CT is the only monitoring that we have to do?
Sir, can I add one more?
Yes, sir.
Yes, sir. In our neuro ICU, our critical care specialist, what we do is we do routine optic nerve observation. We do transcranial Doppler also. Sorry, we do transcranial Doppler and we do optic nerve study also or to monitor ICT changes. So a non-invasive test like that, yes, definitely yes.
Excellent. So points taken. So brain should not be just left like that. Sir, point an important point. Whatever means you got, it's not necessarily an invasive ICP monitoring. We saw in the workshop, there are non-invasive ways also to assure that the patient is safe. There's no markedly elevated increase in intracranial pressure. So with respect to steroid, even if the patient,
This current day and age, relying only on a CT scan's image for looking at whether patient's ICP is progressing or not, I don't think it is acceptable, because we have regularly seen similar images, but ICP will be different because of the compliance of the brain. So I think there should be some form of monitoring other than CT, non-invasive preferable, but I think we should look at that aspect as well.
see, even if you are an aggressive center, you put an ICP. If the ICP is going to show 40 despite mannitol, are you going to believe it? So the first thing what we have to do is we have to correlate with the CT scan. When it's not correlating, think about probe malfunctioning, or you do one more secondary neuro monitoring modality with the TCD or ONSD, and then you proceed accordingly. So,
excuse me, sir. Just
hi, sorry.
Yeah. Sir, I just joined a little bit late. Probably you would have given a better slide, previous slide, I don't know. I just wanted to know clinically, was there an evidence of bilateral papilledema for this patient?
We don't see papillary edema at all in
Sir, but still
patients.
from a neurologist point of view, I would like to stress on
Don't
this
involve
particular
neurology only in the TBI.
No, sir, but as a part of this neuroscience, I have to involve even neurology.
No,
into that.
papilledema is for chronic ICPs, or acute ICP, no papilledema. We teach people don't do these things. Okay, so that should not be done. We should not be wasting time looking at the dilating the pupil, looking for papilledema, all those things.
But what other cause could have been explained in case there is a bilateral papilledema?
We don't see only. Why should we? So probably this you can help me. See, this is an algorithm for non-convulsive status epilepticus. All right. So that is also a DD in this patient. All right. So most of the time we don't have an expert to say whether it is a probable, possible, or because that diagnosis itself is a little bit confusing. We need very good epileptologist to say that the patient is really having a non-convulsive status epilepticus. That also can cause morbidity. But usually this question is asked last, but I ask in the beginning itself. Does AI has any role in scenarios like this? Because everywhere people are talking about AI, and especially in EEGs. We are seeing that nowadays remote EEG is possible, and there are millions of algorithms which are incorporated, and they can interpret findings better than an epileptologist. So that's what people are promoting. Z2 and other companies are FDA approved now. We can use in India, still we have not got it. But do you think that AI has a possible role if these concepts are going to be true, Sir Krishnamurthy? Even for triaging the patient, shifting the patients, identifying early injuries.
I think nowadays, as you speak, this AI is interfering with most of the things which a physician or a surgeon can do. And in this scenario, I think it's better for us to give such an algorithm to the AI and decide what can it do.
To identify whether it is epileptic or not, you do prolactin level, it will give you whether it is epileptic or non.
Sir is asking for some biomarkers to see whether it is epileptic or not. So this patient had diffuse axonal injury, this patient had SAH, and this patient also had aneurysm when he was evaluated, when she was evaluated. So whenever a case comes like this, you see a history, but you also see an aneurysm. Always we have doubt whether it is an SAH followed by a trauma, or patient fell in the railway track because he was found in the railway track. People say that she was hit by a train. So all these confusions happen. Even if we receive cases who has gotten traumatic SAH, patient going into a water tank cleaning and then fell down, and patient will be brought as a trauma. Patient has got an SAHs, and so many cases like this we used to get. So how to go about it? Should we rush for aneurysmal management, or should we wait? Is it an aneurysmal subarachnoid hemorrhage presenting as a TBI, or it is a TBI and if the aneurysm is an incidental finding? So these are all some of the questions which the neurologists are, yourselves are, how do you proceed in this scenario? You want to quickly secure the aneurysm, or you would like to wait in this scenario?
If it is a traumatic aneurysm, we can see by imaging if there is anything related, but usually it will be pre-rupture followed by a fall or an accident. That's how it will be most of the cases. If it is the aneurysm is the primary cause, then we have to secure the aneurysm before proceeding with anything.
But how do we know? This is the presentation. How do we know, sir?
Usually these aneurysms will have secondary changes. If there is any blebs, and if it is multi-lobed aneurysms, and based on locations, it can be based where the SAH is, where the aneurysm is, based on which we can decide probably it is an aneurysm.
We'll just go for a small voting. So how many neurosurgeons would like to secure it immediately?
Is this a CT angio or is it a DSA?
DSA.
Okay. So how often would you do a DSA straight away rather than a CT angio in this scenario? Where there is subarachnoid hemorrhage, would you do a CT angiogram or would you do a DSA? Satya also can answer. So, would you do a CT scan, CT angiogram, or would you think a DSA is better here?
So, you have to look at the distribution of SAH. If I feel the SAH is more centered around the aneurysm.
No, we don't know there is an aneurysm. We only know there is some blood in some subarachnoid space.
Okay.
There was no SAH, no, sir? In the
No, I'm just extrapolating from this.
See, when we saw for our eyes, for a neurosurgeon's eye, we didn't see any SAH, but the radiologists say possible Corey. But after MRI, he was confident that there was SAH. So that was how.
So my question is this: would you want to go for a CT angiogram or would you want to go for a DSA?
CT angiogram will be better imaging, non-invasive.
So you would prefer a CT. I think one first vote would be on CT angiogram or DSA. That would be, I think, the way to go for the voting.
Straight away we can raise the hand. CT angio or DSA?
CT angio, those please raise your hands for CT angio. I don't think MR angio is warranted.
Anyway, MR angio is done as a part of the.
Yeah. Now the second point. Second point is, in a CT angio, do you think you can actually look at the changes in the wall of the aneurysm to see that this has bled and this is primary cause or not? I'm not very sure. Satya, can you?
If technically done right, which most of the time it's not possible, we won't be able to make out whether that is the reason for the bleed. Those information will be better got in DSA, sir. But if the patient is not stable enough to be shifted to DSA, and CT angio should give most of the information, I feel, in this patient.
So the second question, when do you secure the aneurysm? Immediately or at a later stage? No, we don't know whether it's incidental. There is an SAH. Whether it's traumatic, SAH.
Somebody hand over mics or go to the mic, please.
Mic circulate.
Pattern of bleed doesn't look like an aneurysmal bleed. It's a diffuse axonal component. Even in the MRI, probably the nuclear level injury in the midbrain might be the reason for the dilated people. Or it might be, as Madhu suggested, it might be due to the local injury. That's all. If it is a frank, sometimes if you see the CT, the bleed might be in the in and around the perisylvian region, something like that. In that case, we can go ahead straight away, you can plan for a elaborate investigation for the aneurysm. Otherwise, it doesn't look like an aneurysm.
So you feel more like an incidental aneurysm.
It's a,
It
yes.
can be handled later.
can be handled later after stabilizing the patient.
Also had vasospasm. She developed hemiparesis, so the vasospasm was handled. And see, about these points, steroids, everybody said not, but sometimes head injuries are associated with optic nerve injuries. Ophthalmologists now also, they wanted steroids. So how many neurosurgeons are comfortable giving steroids when the patient having optic nerve injury and also an head injury?
We are giving, if the patient is having ophthalmic injury, definitely we are giving.
Despite the
Straight
patient
away
having
for-
head injury?
No problem at all. Sir. Actually, if the only head injury,
Like
no
Satish
need.
want to make a point.
Sir, we are talking about evidence. In head injury, level 1 evidence says no steroids.
Not for the head
but
injury.
since you asked about the optic nerve injury, there you can give, the ophthalmologist feels there is evidence, you have to give. But for head injury,
In
level 1...
optic, now also there is no evidence actually.
No, but generally that's an ophthalmologist call, not us.
Yeah,
But I am talking about my profession.
No, it's not about ophthalmology, neurosurgery. We'll just talk about evidence.
No, for traumatic brain injury, level 1 evidence says no steroids.
For brain injury, no steroids. Optic nerve injury, yes, ophthal will ask, but if you have associated anterior skull base fracture, where you are worried about CSF, fulminant meningitis and all that, I don't think
this
the risk
patient has
of-
got a skull base fracture.
Yeah, so that's what, I would not really prefer steroids.
Prefer steroids. Sir, your experience, sir?
I experienced the steroids don't make a difference to a patient with a complete optic nerve injury. If it's a partial optic nerve injury, I've seen patients recovering after steroids. So it's a balanced judgment based on the clinical
There may be
situation,
incidental
risks and benefits you have to consider. The risk is mainly infection and gastric bleeding.
So this patient received steroid and she developed bloodstream infection. It was a MDR Klebsiella. It prolonged her ICU stay. She went in for sepsis, septic shock. All the things happened. Don't think steroids are safe. So optic nerve itself, this means I'm come about spinal cord injury. So how many of you still prefers to give?
If we are talking about evidence, I think Mahapatra came up with an article long time back from AIMS which showed no use of steroids. So there is evidence that there is no use for steroid. I think Mahapatra came up.
In the same article, he also talks about decompressing the optic nerve 27 days after the injury.
Correct. But we are talking about evidence. I mean, evidence is what is there in literature. That's about it.
So quickly I'll cover this point, sir. Skull base fracture, CSF leak present on how many of you want to give prophylactic antibiotics? We'll just go with the voting session only. Prophylactic antibiotics to prevent meningitis. How many days, sir? But we have to end it somehow.
You start the war, you don't know how to end the war. No, but you cannot be
Satish, you have to answer this because from next generation.
No, look.
Again,
Sir, a student, so padikumbodhu we used to give, but evidence, no evidence.
So I'm coming to that point, vaccine. I think vaccine will be a better choice. But vaccine is not going to act immediately, maybe for long term. And it's very clear now evidence that there is no role for prophylactic antibiotics. We should not be giving prophylactic antibiotics. I think we should stop neurosurgeon from prescribing antibiotics. That should be the way forward.
No, but in our setup, I feel that how many of your patients, a very clean surgery you have done for a trauma or whatever it may be. How many days do you give antibiotics post-operatively?
Never.
You don't give?
No.
No, sir. We just give 3 doses. We leave it to them. Just 3 doses.
Yeah. First we are
We
talking.
were giving 3 doses. Now we don't give antibiotics outside the OT. If the surgery is prolonged, you repeat the antibiotic. If there is blood loss, repeat the antibiotic. But don't give. Then that's not prophylactic. It becomes therapeutic if you want to give.
Then you have treated that patient. How many of your patients, post-operatively, where do you keep the patient? ICU. How many of the patients come out without any infection? If I keep the patient in the ICU, probably my ICU is not as good as your ICU. But how many of the patients? I should come and see your ICU. I should come and see your ICU, and I should see
so
your.
Basically, the point is surgical prophylaxis is targeted against organisms which are in the skin, gram-positive thing. But whatever secondary infections you get later on, they will be gram-negative. That you are not anyway not going to cover with the prophylactic antibiotics. So it is very clear.
Any antibiotic you start with is only cell wall acting antibiotic, which is common in the skin and which might get into the.
We
so we start on
next admission.
So I continue antibiotic for 2 or 3 days.
All right, so I'll inform your ID team right away. Right. Okay. So, aneurysm we secured in a later stage at a second sitting once the vasospasm, hemiparesis. Pardon, sir? How much? I think it's probably after 3 weeks. 3 weeks. 3 weeks we secured the aneurysm. Surgically clipped. It was surgically clipped. So this was again a patient who came to the hospital only because he had a fall after taking his bike. But he had the stroke symptoms even before 2 days. Unfortunately, we couldn't give thrombolysis or thrombectomy. So like you said, for blunt cerebrovascular injuries, there are guidelines for us to guide when to go for an angiogram when we have injuries. Dr. Satya, you could, this is a guideline which was shown. Even for a near hanging patient, they recommend to do a CT angiogram along with a plain CT. So that is what it is. So if time is over, then we'll wrap up. We have got some interesting cases also to come. So yeah, we'll wrap up. Sir. Thank you.
The girl had a liver injury and they're doing a contrast. In what phase of the contrast you will do a CT brain angio? How much contrast will you give if you are going to repeat the contrast for the brain?
No, we give the contrast based on the weight. We don't give extra dose just to do for the brain. So in the arterial phase, we cover the brain and then come below covering chest and abdomen.
Possible?
Yeah, it is possible.
Sir, for CT angiogram, sir. No, the patient has a liver injury. So you suggest the technicians to start from the head?
Start from the head, thorax and abdomen.
Okay, yeah, thank you.
I think there is a protocol which has been given in some text on how to subdivide your doses and give accordingly. Is that followed?
Yeah, it is there, but it also depends upon the mission what we are working with. If the mission is a low-end mission, if it's not able to cover in the correct timing, we won't be able to time it accordingly. So in high-end mission, we will be able to cover brain, chest as well as abdomen in a single phase.
We thank all the panelists for coming. Sir.
Thank
Thank
you.
you so much. Sir. I hope this was an interesting discussion and we'll carry it forward. Thank you.
Thank you so much for yet another insightful session. Please give a huge round of applause to our panelists and the chairperson. Let's move on to session number 4 under the topic Standardization of TBI Management Challenges and Solutions. Let's first invite chairpersons on stage, Dr. L. Shankaranarayanan, neurologist, Lakshman Neuro Clinic, Tambaram. Please give a big round of applause and welcome him onto the dais. Dr. T. N. Ravi Shankar, family physician, Sudar Hospital, Chennai. Dr. Meenakshi Paramasivan, lead consultant radiologist, Women's Imaging Radiology, Kauvery Hospital, Tirunelveli. And let's invite the speaker, Dr. Krish Sridhar, Group Mentor, Neuroscience Director. Okay. Over to you, sir.
So, this talk is on forward. Sir, okay. So this talk is basically, since we are talking pan-Kauvery, since we are talking about different ways different people work, whether standard trauma care delivery is possible, what are the challenges and what are the possibilities that we can get it standardized. That's the basic idea of this talk. We know that the trauma burden is very, very high. It is the #1 cause of death between the ages till 45, 46. And 5 to 6 million trauma-related deaths are there every year. Unfortunately, when these are publicized in any forums unrelated to neurosurgery, people zone out. And I think my friend Jose will like what I have written there. The Phil Collins song, he pretends he can't hear her and seems embarrassed to be there. And that is the general response people have when you talk about incidents of trauma and TBI. Unfortunately, that's the truth because it has not got enough importance that it needs to have. So if you look at trauma burden, road traffic accidents are number one. You have all the other types. And if you look at road traffic, traumatic brain injury, it is RTA. And if you look at RTA, it is two-wheelers, and then it is no helmets, no seat belts. And it is a worsening situation. And 2004, it was number 9. And they expect that by 2030, it is going to go up to number 5. So it is one situation where even though we are developing in a sense of economic development, it does not seem to reflect on traumatic brain injuries. This was the road accidents in India, which was brought out in 2022 by the government of India. The interesting part is, if you leave those numbers, okay, they are big numbers. But what we think is that the national highways should have the maximum number of injuries. But it is not that. It is not even the state highways, but it is the other roads. It is the other roads which cause almost 45% of all accidents and 40% of all deaths. So this is a sort of difference from what we all generally think, that majority of these accidents and head injuries happen on the main highways. So the challenges which we have is, of course, diversity in capabilities, geography, socioeconomics. If you look at the terrain of India itself, it is different. The terrain of Tamil Nadu is different in various parts of Tamil Nadu. And this causes a lot of issues on delivery of healthcare systems. If you look at rural development across India, that itself is widely different. You sometimes, the mode of transports which are available in different parts, even in our state, which is one of the more developed parts of the country, itself is different. There are parts of Tamil Nadu where madam is involved in women's radiology, where it is difficult for them to get a mammogram. So these are things which are there, which is the relevant part of our discussion. Manpower, infrastructure, again, Tamil Nadu unfortunately has got a much, much better infrastructure and sometimes not so good manpower availability. The lack of in-hospital delays, the factors which are there, which is there in literature, shows that malfunctioning of CT scans, we are all talking about CT scan being easily available, but if the CT scan is malfunctioning, what do? What does the neurosurgeon do? Limited theater space. Now, 28%. There was a case where NSI was involved, which happened to a senior neurosurgeon during COVID, where a patient came with a head injury, but because of COVID, there was limited space. There was only one theater allocated for non-COVID cases. And what happened was that he had to wait for a case which was already going on to finish because he couldn't post it anywhere else. And the patient died. And a case was put against him by the, not only by the consumer, but by the police and other people, saying that you should have taken it up. Of course, now the case has been dismissed. But you can imagine his plight. What does the neurosurgeon do at that time? The glaring dearth of facilities for low income and overburdened state of existing facilities. People working in public hospitals know this. There is an overburden, and perhaps that has to be streamlined further. The challenge, social awareness. We just had the World Head Injury Awareness Day, but we still see all these on our roads every day. It's not something to be proud of, but what I have been trying to say and do on multiple forums is that we need to talk to society to change the mindset to be safe. The person on the road needs to think, I have to be safe. It should not be that the police will catch me and therefore wear a helmet. It has to be, I have to be safe so that I can go home to my family. But why don't people do that? It's the not me syndrome. People believe it will only happen to the bike rider next to him. It won't happen to me. So I can go any way I want. Politics and regulations, we don't have proper road systems which have proper turns. There are no proper inlets and outlets, exits on main roads or different other roads. People can just cross across. Even here, even if you have a median, you have multiple people, if you see, jumping across medians. You won't believe how agile our Indian population is. They jump across even 3 feet medians. Unfortunately, we don't do so well in the Olympics, but on the roads, we are fantastic. The mere presence of a law requiring a helmet for riding motorbikes does not ensure such a practice is widely adopted. And this is a paper which from NIMHANS, Indra Devi and Dhaval Shukla were involved in 2025, which means that this is a problem. And advocacy. It's a very sad fact that trauma is the leading cause of death and disability, but receives less than 1% of global healthcare funding. And this is something which all of us need to be aware of. It is not that it does not matter to us, it matters to us because any one of us can be a victim here. We had a global plan. There was a 2021 to 2030, there is a launch on the UN vision for road safety. There was one before as well, which did not work. There is again, it has been put. So there are things which are being put in place, but not implemented on the road. The post-crash response, there are 5 pillars which are there for it on what to do, how to do, etc., but not being implemented. Now, pre-hospital endotracheal intubation. This was a study which was done, I think, in Australia. Or the effects of pre-hospital intubation depends on the experience of pre-hospital health workers, who are those, if the paramedics are not well trained, it markedly increases mortality. So when we talk about here protocols on the previous session was on pre-hospital work. If we talk about protocols where we say, we must get them on-site intubation, resuscitation and things like that, we have to then make sure that the paramedics are trained properly to do that and not just do a 3-month course and get onto the field. Because it is now evidence that it worsens the situation rather than helps the situation. What are the possibilities then? We have spoken enough about the problems. We all know the problems. There is a national program which looked at trauma networks. And it has been shown that ever since they have implemented the trauma networks, things have improved. And this was the NICE guidelines, I think Joe spoke about it, where it covers both pre-hospital and intermediate hospital care, and it's the best evidence available to support for optimally managing and encouraging increasing uniformity of care. And this has shown development of integrated trauma networks with coordinated multidisciplinary care helps improve outcomes of trauma patients. You have the WHO emergency toolkit, which people in remote areas can use. And you have the national guidelines done by NTSI and NSI in India. It has been a little criticized that it is not standard of care across the world, but it presents what can be done in the remotest place with the least amount of facilities. And I think that is where we need to do. What can be done to save the life when you have the bare minimum at the level 4 or level 3 trauma centers, not what you should do at level 1, because at level 1 you will automatically do. So I think at the pan-Kauvery level, we should look at forming networks. We should look at forming networks and protocols on how to manage and have maybe a Kauvery guideline on what to do. It is a guideline, it is not written in stone. It can be changed with evolving times. But if there is a guideline, it will help people across our group to look at how to better outcomes. And if we look at 2-year outcomes, or even a 12-month outcome of all our head injuries, we can sort of say that it can be validated and, if necessary, changed over a period of time. Of course, now things are better, especially in 17 states across the country, and Tamil Nadu is one of the things where we have the 108, which is a great help. We have private ambulance systems like the Kauvery Hospital system, where also it helps. But I think what we need is to have partnerships like this so that patients are looked after immediately on site. Now, if you look at schematic diagrams as to how the government is thinking of having level 4 to level 1, you can see that it makes logic and sense. You have more number of level 4, where it's basically ambulance driven, and then you have the level 3. So if you have level 4, 28, you have level 3 and level 2, which is only 6 to 8. And then level 1 trauma centers are only 2 over a 1,400 kilometer stretch on a national highway. So I think we are looking at things, but it is not getting implemented fast enough. So let us start implementing this at the Kauvery level. There is a traumatic brain injury global coalition where countries from, including the NSI, we are part of this, where we are trying to sign a resolution and pass a resolution to make it a notifiable disease. Because once it becomes a notifiable disease, and I'm sure the people on stage understand what this means, once it becomes a notifiable disease, it has to get the spotlight from all governments. And once it has to get spotlight from governments, there has to be data which has to be submitted across. And once that happens, automatically we hope that things will improve because implementation will take place. So why are numbers then not showing an improvement? Because standardized and systemic care are seen only in pockets. We need to overcome the issues at each region. Now, if we look at the Nilgiris, we cannot talk about trauma care in the Nilgiris equivalent to trauma care in Chennai. So we have to look at the regional aspect. And I'm only talking about Tamil Nadu. India is a much bigger thing, but let us concern ourselves only of this area. We need to understand the local need and adapt. We cannot talk about high-end technology at places which are very remote. What is the local need of the person working there? How can he save the life of the patient? So what can we do? Create a network, a hub and spoke, where people can ask for help, get the necessary help if necessary by phone, train paramedics and other EMTs and other first responders. I think this is very, 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 very important. We have to train them to be experts at what we expect them to do on the field. Rapid bypass transport to level 1 centers if it is a severe complex trauma. Let us not waste time at smaller centers, but let us bypass all of them to level 1 trauma centers. And that should be the way so that we save time. And there should be a green corridor concept at level 1 centers where they get immediate care, whether it's a corporate hospital or a public hospital. There should be a green corridor without wasting time. We talk about the golden hour, we talk about secondary damage, but we need to work on that to reduce the time taken to deliver care. So it's a pandemic, so let's take action away and not shy away. We need to educate, empower, endorse, ensure, and engage so that we make standardization at the macro level and we need to adapt at the micro level. Thank you very much. Any questions?
Any questions?
Also, Dr. Shankar Narayan is also the current president of the Tamil Nadu Academy of Neurology.
Any questions from the floor? So it was a wonderful lecture. It is a practical problem. Whatever we talk about golden hour and all, when you go in the street, it itself will take more than 1 hour to reach the Tier 1 hospital. So it should be looked at. Any questions from the floor?
IMA. Vote to IMA people.
Thank you, Kicha, for giving me this opportunity. There's two things there. It was a nice talk on a social talk. That's why I didn't know why I was here. I thought a lot of intelligent people are here. There is two things here. One is prevention of those trauma. I have a passion for driving for 35 years. But then I have never overshoot any signal or anything. Because this has to be a culture that has to be cultivated from the school days. I used to think why these people are crossing zigzag, the two-wheelers or all, because it has not been taught from the school. From the 6th standard onwards, it's the society's response, our responsibility to teach those school guys when they come out of the school, and before the school they start driving because the parents give them the vehicle. They are not being taught about the rules and regulation. We frame the rules, we bypass the rules. So our target has to be at the school level, because you try to educate from the school, I think they will be much better. If Tamil Nadu cannot get an air ambulance, no other state in the country will do. There had been centers in Tamil Nadu who tried air ambulance for the golden hour, but they could not sustain the financial cost. I think that's one thing which is going to help in the golden hour. I think educating the public from the school level, and an air ambulance, which if Tamil Nadu cannot get, no other state in this country will have it, sir. I think it's like the neurosurgeons will have to take a pledge together, work together. When you say you are joining together all the centers, I think it's from your side, you will have to do it with presidents and people like you. Thank you.
One thing I wanted to mention regarding the terrain you were talking about in Tamil Nadu, since I was in Chennai for the last 25 years, and in the last 1 year of my experience in my own native, I'm out of head injuries. Out of 3/4 are RTAs, and 1/4 are still assaults. People are still roaming around with swords and sickles, and vengeance is there. It is not a movie, cinema, or anything. It is happening in reality. And the packages what we give in our center is, we have a major package and a minor package. RTA, majority are high velocity injuries, and the majority of them need to go for pan-CT, and majority of the assaults are mainly aimed at head and neck. So we cover only head and neck in case any body injury is there. So we have to customize according to the region as well as the terrain. Correct. So this is the cultural difference what we find, and as a casualty medical officer, I have seen all these cases 25 years back, and still now things have not changed.
It is peculiar to Tootukurin and Sankaram Koil, in and around.
Thank you.
Thank you very much, and a huge round of applause to our chairperson and the speaker. Thank you. And without any further ado, let's move on to session number 5. Let's invite all the chairpersons onto the dais. Dr. Mohan Sampath Kumar, Senior Consultant, Neurosurgeon, Kauvery Hospital, Alvapet, Chennai, to kindly join on stage. With a big round of applause, can we all please welcome him? Dr. C. Krishna Mohan, Consultant Neurosurgeon, KIMS Hospital, Nellore. Dr. S. Bala Murugan, Consultant Brain and Spine Surgeon, Kauvery Hospital, Alvapet, Chennai. Thank you. Over to you.
Dr. Ramakrishnan is going to deliver his lecture.
This is go. Just tell me.
Green forward, sir.
Okay.
Previous slide.
Point to thank you, Sridhar, for inviting me, and also for initiating the process of cooperation between the Kauvery hospitals. I think we have a very large workload in all Kauverys put together, and so what we're talking about today is going to be the seed of a big thing that's going to grow out of it. We take no pride in the fact that the Tamil Nadu and Karnataka are the capitals for head injury and deaths due to head injury. And it's surprising because the number of vehicles we have got per head, per capita is much smaller, but still we have more loss of lives and accidents. And so this is a hard fact that we've got to live with, and this is an urgent reminder for us to do something about it. So we already talked about pre-hospital care, the triaging, and the resuscitation of the patient, the triage, stabilization of the patient, trauma protocol, CT, all of them have been covered very well by the previous speakers. These are absolutely important before the patient comes to the OT, because only a stabilized patient does well when he comes to the theatre. Now, I'm going to talk about triaging of injuries in the individual polytrauma patient, because that seems to be the big talk over here. So let's look at that. In my practice, I find that those which are threatening life are the ones that need to be attended first. So you cannot overlook a tension hemopneumothorax in spite of the fact that the patient may have a big extradural hematoma. This requires urgent attention. This can be done most likely at the bedside in the triage rooms. The hemopericardium is also the next big emergency, because these can kill within minutes. Oops, not moving. Major external bleeding, we said sometimes we don't even take up the patient for CT just by the fact that the patient has got an external bleeding is very obvious to you. It needs to be stopped immediately. The patient may be moved to theatre in such a situation. Severe intra-abdominal bleeding, which causes hemodynamic change, is also very important, and that needs to be addressed first. The next priority would be an acute intracranial hematoma, because this can kill over a few hours or a few days. Then hollow viscous injury in the abdomen. This is followed by diffuse brain injury refractory ICP. This, of course, happens a few hours or days after the admission of the patient, because you already tried all of the methods, they have failed, and then you take the patient for theatre. Unstable spine injury, you can have some methods of stabilizing the spine non-operatively till the patient is readied for surgery for the unstable spine injury. Compound skull fracture is the next one. Facial-maxillary injury, long bone compound fractures, closed fractures, soft tissue injury. That's the kind of priority that we have. Not that every patient will have all these injuries, but whichever the patient has higher up in the list has to be dealt with first. This is my principle. But it's easy to say all this, but then there are practical difficulties. What are the difficulties? Dr. Sridhar already mentioned about availability of theatres. Exactly at the time when the patient comes into the hospital, all 6 theatres in your hospital are occupied by cases which are going on for a long period of time, elective cases. No theatre is available. Equipment availability, sometimes things like drills and all that are shared by departments, so the equipment may not be available. Surgeon schedule, I have patients in whom there is a head injury which cries for attention, the neurosurgeon is operating, the plastic surgeon says, I'm free, I will do my part first. That sometimes happens, and we have to find a way of how to sort out all these things. Then I find that the worst time for patients to enter the hospital is when there is a shift change. And sometimes blood availability is a limitation, and odd hours, holidays, again, there is not enough of consultants available, and therefore the care may be delayed, and taking the theatre may be difficult. This is talking about polytrauma patients. Now, what about patients who got head injuries? Which is the first injury that you should attend to in a patient with a head injury? In my opinion, an exsanguinating external bleeding, this usually happens because of depressed fracture over the sinuses, which is still open. The venous sinus is bleeding away. You may have to take up the patient to theatre just to stop the bleeding, even before you have got a CT done in such a situation. Progressive deterioration of the Glasgow Coma score. This typically happens with patients with lucid intervals. They become a high priority if they have got a space-taking intracranial hematoma. The next priority would be those which are small lesions, not yet requiring evacuation, but you might require to monitor them, and therefore you might have to place an ICP monitor. Like you saw in the morning, sometimes it can be placed in the casualty or in the trauma ICU, but it's much better to do it in the theatre because these are invasive procedures and you don't want the patient to incur the risk of infection. The next thing is patients who have a diffuse axonal injury, edema, they may require a decompressive craniotomy or cisternostomy. Dr. Ranganathan will be talking after me, and he'll be detailing about the DC and cisternostomy. Enlarging hematomas are definitely a need for surgery when the patient is under observation. And unfortunately, these things tend to happen at 4 a.m. in the morning when we are least prepared to go to the theatre and operate on these patients. Compound fractures are the next priority. And then persistent CSF rhinorrhea comes last because you can wait for some time for it to stop. If it doesn't stop, you take up the patient for surgery. So this is, in my opinion, the kind of prioritization that you should have, the kind of triaging you should have in the individual patient. I'll also talk about a little bit about these surgeries that are done. Extradural hematomas, all of us know about it. Just look at this one. This is the hypodensities that occur in an extradural hematoma. You saw from Dr. Joseph's slides in the morning that these are all uniformly hyperdense, but sometimes you have these hypodensities. This may be because of bleeding that is going on here, this one. And this is because air may come from the sinuses or from outside due to a fracture. This patient had a very funny problem. She had a hemoglobin of 2 grams because of pre-existing iron deficiency anemia. This is an acute extradural hematoma. Clotted blood found at surgery. But look how it is it is absolutely hypodense because of the anemia. There is not enough iron to produce the hyperdensity in the hematoma. This was a patient who came on the 7th day and already it had started liquefying, but still there is still mass effect, severe headache. I had to operate on this patient. Again, a hypodense extradural hematoma. You would not believe that it is like an extradural hematoma. And this is a case from the literature. Prabhuraj, my friend from Le Mans, has reported this. 10th day after trauma, the patient has got a clotted, infected extradural hematoma with an extradural abscess. Again, becomes hypodense. The other thing we've got to be careful about is the normal criteria that you use for taking up for surgery, the volume criteria, do not apply in the posterior fossa. And many of these occur in children, and they deteriorate rapidly because of small volumes, so you should be very careful about this. And they may be bilateral, and they may also extend above the tent. So these are things that you should be aware of, and unless you have a good, like for example, this is one which you underestimate. If you just go by axial scans, this looks like not a very big extradural hematoma. But you look at it on a sagittal and a coronal view, you know how big it has become. So this is the kind of the need for multi-dimensional, three-dimensional formatting of your images. You can do conservative management of some extradural hematomas, provided they are in good grade and the hematoma thickness, volumes, all these things are mentioned in the literature. There is no progressive deterioration, this is very important, and there is no other additional lesion that requires surgery. And this can be done only in a place where there is availability of close monitoring and 24/7 facility for conversion to theatre. It can't be done in a level 3 or level 4 trauma center. This has to be done only in a level 1 trauma center. So this is the kind of patient in whom the volume was just tad short of that 30 ml limit, managed conservatively because the patient was absolutely fine, there was not even a headache, and this is completely resolved in 3 weeks. So you can choose your patients for this kind of conservative management. And in the surgery, you should have the volume, the size of the craniotomy flap should match the size of the extradural hematoma. There's no point in doing it through a small flap and trying to go underneath and trying to evacuate this because the bleeders may well be there. And the basal temporal craniectomy is often done in these patients when the hematoma extends to the bottom. And if there is a fracture there, what happens is your craniectomy extends directly right up to the foramen spinosum. And then there is a terrific bleeding, much more than what you started off with when this happens. So when you do the craniectomy, you've got to be careful. You can employ a drill or you can use very small bites of your rhonda to take that out. And do not try bipolar coagulation. I see a lot of the residents do this. For venous bleeding, it never works. You have got to put a hitch stitch and use gelatin sponge. And oftentimes after evacuating the hematoma, the dura looks bluish, it is tense. You have to open the dura. Don't hesitate to open the dura in those cases. And the CT must be done to rule out enlarging contracoup hematoma, which happens in some of these patients. Acute subdural hematoma, again, these are the indications for surgery. Again, all well mentioned in the textbooks. Low GCS, size more than 10 mm, midline shift, progressive deterioration, additional lesions that require surgery, persistent high ICP in spite of medical measures, and acute arterial subdural hematoma. This is something which I want to engage your attention on. This may be because of an aneurysmal rupture, but much more commonly it is because of a previous infarction that has caused shrinkage of the brain. When the brain shrinks, the arteries come up on the surface. Normally the arteries are buried within the sulci, but when the brain shrinks, the arteries come up on the surface and they can bleed. And in these patients, you'll find a hematoma here. So if you go to the trials have been done about craniotomy and craniectomy. The results with craniotomy are generally better, but then the craniectomy patients are generally far worse than patients who had craniotomy in the first place. And this is the result of the various studies that have been done, meta-analysis. Everything proves that craniotomy is better for acute subdural hematoma than craniectomy, but the call is taken on the table after you've finished evacuating the hematoma. If the brain is very lax, you can put back the bone flap, but then you should be prepared for facing a recurrent subdural hematoma. The recurrence of rate is higher when you put a craniotomy rather than when you do a craniectomy. Traumatic intracerebral hematoma is another big chapter. Two standing examples. This patient had a low GCS. This was the volume of the hematoma. Did a fairly big craniotomy thinking that this patient might require removal of the bone flap, but the brain became absolutely sunken after the evacuation of the hematoma. Bone flap replaced, but the midline shift did not resolve at all after surgery. Then secondarily, I had to take out this bone flap in this patient. And this patient had a poor outcome, in spite of the fact that the hematoma was evacuated. It's fully evacuated, but still the patient did not have a good outcome. This patient was in a good grade. He deteriorated in hospital. The volume was 20 ml. Again, a big craniotomy, small craniotomy just for the taking out the hematoma was done. Brain did not become lax, so it was extended and made into a big craniectomy. And this patient also had a good evacuation of the hematoma, complete resolution of midline shift, and a much better outcome in this patient. So you always try to individualize the treatment depending upon what the brain situation is, depending upon what the ICP is, but you may not always get it right. And about the trial, this is a trial in which I think Dr. Sridhar also participated. This is way back in 2012 or 13, it got ended and it was reported in 2013. And says that early surgery is good in many aspects, but it does not give you a good overall outcome. Same thing has been found also by a more recent study. So these are the things that we have to, these are the hard facts that we've got to live with. This is something which is not for me, it's for the next speaker. So ultimately, it's about creating these protocols. I have not quoted any protocols from outside India. This is a protocol that has been devised in 2024 by the ICMR in India, suitable for Indian conditions. And this is the kind of thing that we have to make for our own group of patients. Thank you so much for your attention.
Thank you so much, sir. Now I invite Dr. Ranganathan Jyoti sir to deliver his lecture.
Forward? Thank you for this opportunity. My talk is, what is the dilemma between decompressive craniotomy versus medical management? Resolves around treating a refractory intracranial hypertension for a traumatic brain injury as well as malignant MC stroke. Critically ethical and clinically a dilemma on deciding between a decompressive craniotomy and a medical management. A decompressive craniotomy reduces the mortality, increases the functional outcome, but only in a selected patient. No consistency in favorable clinical outcome since there is a high risk of severe disability. It is how one has to balance between survival rate against the risk of a severe disability. To proceed with the decompressive craniotomy should be based on individual patients like a pre-injury functional state and family involvement. As you know, a surgery for a traumatic brain injury, you do a large craniotomy, a lax duroplasty, bone flap either replaced or removed. The mechanism and rationale, it increases the intracranial compliance, lowers the ICP, improves the cerebral perfusion, improves the space for brain swelling, and reduces the risk of herniation and death. Whereas a medical management, as you know, head and elevation, sedation, analgesics, hyperosmolar therapy, giving mannitol or hypertonic saline, CSF drainage by doing EVD, intubation, tracheostomy, and hyperventilation, and a barbiturate coma. When compared, there have been a lot of studies comparing extensively between the traumatic brain injury and malignant infarct, either decompression or medical management. One of the trial is Decompressive decompressive craniotomy trial, wherein evaluated bifrontal craniotomy for a moderate raise in ICP, more than 20 millimeters of mercury, for 15 minutes within 1 hour for a diffuse traumatic brain injury. You take them for a surgery, bifrontal craniotomy. It definitely reduces the ICP and ICU stay, but when you see the overall functional outcome, it is worse in 6 months in a decompressive craniotomy when compared with the medical management. And mortality, when you see the mortality, it is almost same in both the decompressive craniotomy and medical management when you go for a bifrontal craniotomy at an earlier stage. Another trial is rescue ICP trial, where decompressive craniotomy as a rescue for a sustained refractory ICP, more than 25 millimeters of mercury for 1 to 12 hours. It lowers the mortality. The mortality is only 26% diffuse craniotomy, decompressive craniotomy when compared with the medical management. But a higher rate of survivors in decompressive craniotomy, but severe disability or vegetative state. Long-term follow-up after 24 months showed some improvement in functional outcome. When comparing the DECRA study and rescue study, a moderately raised ICP, conservative management is generally better than early aggressive surgery. Whereas in a rescue study, later salvage decompressive craniotomy for severe high-pressure injuries result in lower mortality, but outcome and a better outcome when compared to medical management. Another study, acute SGH trial, it compared replacing the bone flap and removing the bone flap. Both, there was not much of a difference in mortality and functional outcome. This is one of the baby, 10-year-old baby who had come within a few minutes of injury to our hospital, showed a fracture skull with the initial CT showing. We had observed the patient. Within 12 hours, the patient started deteriorating in the form of a left pupil dilated and showed a hypodense area. Immediately, the patient was taken to the theater and opened, and there was a large STH which was removed. And the bone flap was replaced, and a floating bone flap was kept, and STH was removed. And after 2 days of, this is after the removal of STH, after 2 days, the baby started showing some improvement. And after the 10th day, baby had a very good improvement in conscious level with the right side paucity, and after 1 year, now the patient is almost normal. So the meta-analysis says the decompressive craniotomy, definitely the ICP reduction is significant. It lowers the mortality. Hospital and ICU stay is shorter in decompressive craniotomy. Favorable functional outcome, but at 6 months, not statistically significant. So practical implications, indication for decompressive craniotomy, refractory ICP after a maximal medical therapy, clinical deterioration and neurological decline, large mass effect with the midline shift on imaging. Timing, early decompressive craniotomy may reduce ICP, but not always improve the functional outcome in diffuse non-mass lesions. And delayed decompressive craniotomy for refractory ICP may reduce the mortality with a potential functional gain. So same is the case with the malignant MC infarct. Indication for craniotomy, decompressive craniotomy is a massive infarct with a massive edema with the early signs of herniation not responding to medical management. There are a lot of studies here also, Destiny trial, Hamlet, decimal trials. says that early decompression within 48 hours in patients less than the age of 60 reduces the mortality and functional outcome. But older patients more than 60 years reduces mortality, but outcome may not be so good. So functional gains in decompressive for a malignant mortality reduction is substantial in 50% of cases. Functional outcome depends on the age. The greater the age, outcome may not be very good. And also the timing of the surgery, if done within 48 hours of the midline, within 48 hours of the infarct, the outcome is good. So risk and limitations, most often vegetative or minimally conscious level, severe disability impacting daily living, complications like infection, hydrocephalus, subdural hygroma, sinking skin flap syndrome, seizures. Ethical consideration of balance between survival benefit and quality of life to be weighed, and hence informed consent and family discussion is a must before taking the patient for either medical management or decompressive craniotomy. This is a sinking bone flap. Even after a month of cranial decompressive, you can see it is pushing the brain to the opposite side as though there is a big mass effect. So clinical decision principles, the individualized approach, the consider patient's age, comorbidities, baseline neurological status. Refractory ICP after maximizing medical therapy is the primary indication for decompressive craniotomy. Informed consent. The family should understand about mortality reduction and potential severe disability. Long-term follow-up is crucial for assessing the true beneficial effect. Outcome of treatment for eyes. Decompressive craniotomy effectively reduces ICP, improves the survival in both traumatic brain injury and malignant infarct when medical therapy fails. Functional outcome may initially remain poor, but some improvement occurs after 12 to 24 months. Medical management alone may avoid severe neurological disability, but carries high risk of early mortality in refractory cases. Decision making should always be patient-centric, integrating prognosis, ethical consideration, and family preference. Long-term outcome after decompressive craniotomy survival rate. Improves long-term survival in 12 to 200 months follow-up if patient selection is appropriate and comorbidities are managed. Factors influencing long-term survival include GCS score, age, preoperative intracranial pressure, complications like infection, hydrocephalus. Early cranioplasty also can influence long-term survival positively. Timing is crucial. Early cranioplasty improves neurological cosmetic outcome, also reduces risk of sinking skin flap syndrome. So the survival improves, but the functional outcome is suboptimal, may have persistent neurological deficit ranging from mild cognitive deficit to severe disability. So outcome measures use either Glasgow Outcome Scale for traumatic brain injury and modified Ranskin scale for stroke patients. Some achieve moderate disability, but very few reach good recovery. Severe disability remains the prevalent. So long-term quality of life after decompressive craniotomy, emotional aspects may be affected, either depressed or anxious. Cognitive functions, attention span, memory, executive functions may be reduced. Physical independence and mobility may be impaired. So multidisciplinary rehabilitation include physical, occupational, speech, and cognitive therapy. Regular follow-up is necessary to monitor neurological deficit, seizure, hydrocephalus, and bone flap complications. Hence, concluding, decompressive craniotomy saves lives but often results in incomplete functional recovery. Long-term outcomes vary widely depending on initial injury, severity, patient selection, surgical factors, and post-operative care. Optimal prognosis relies on a timely cranioplasty, comprehensive rehabilitation, careful long-term follow-up. Survivors may experience physical, cognitive, psychosocial challenges and require sustained health care support. Thank you.
Thank you, sir. Now I invite Dr. Ponnaya Vanamurthy, sir, to deliver his lecture.
Good afternoon, all. So after hearing very nice lectures about surgery, I'm just going to talk about how to monitor this box, this the intracranial compartment in the brain. So where do you start, where do you end? Because brain is always a mystery, and there are a lot of things which we can monitor. Lesions like this, you must have heard about, or straight away they go for surgery. So there's no need to initially monitor and take the patients up. But lesions which are diffuse injuries, which is graded by Marshall grading system, especially the grade 3 and grade 4 lesions and some grade 2 lesions also, if they have other factors, they have to be monitored, and there will be dilemmas at times whether your medical management works or don't work, or patient has to go to a decompressive craniectomy, and again decompressive craniectomy is not that everything is a smooth procedure, it has its own issues. So even after decompressive craniectomy, patient's brain can be bad and we need to monitor it. So I'll just quickly go through some of the monitors which are available and which are in the progress and everything. It's not that every monitor we have to employ in all the patients. It's not necessary also. So if you see the guidelines in traumatic brain injury, sir was talking about the Indian guidelines by the ICMR, which will be applicable to most of our patient population. But we should also know what is happening internationally. So there are guidelines which are formulated by Brain Trauma Foundation, that is one thing. And there is a guideline which say the CBIC guideline which we talk about if the patient has gotten intracranial pressure monitoring. And another guidelines of the same CBIC talk about if the patient has both intracranial pressure monitoring and PbO2. So both are invasive things. And here come another protocol, which is the Kriwais protocol, which says that if the patient does not have any monitoring with only clinical and radiological things, how to monitor the patient. And we have algorithms for that. And then why just to leave the patient alone without monitoring? We have a lot of non-invasive tools, tools where now everywhere people are using ultrasound, pupillometer is coming in a big way. So why don't we employ these monitors? So non-invasive ways of monitoring the ICU. And now recently what we are thinking is that even if we have invasive modules, we just can classify the patient, which patient really needs invasive monitoring, and whether with non-invasive tools employing first, even if invasive monitors are available in our department, it may be like in our hospital or most of our Kauvery units, we'll be having invasive monitors, but it's not necessarily that all the patients has to undergo the invasive monitor. We can take the patients like this. So head injury, a patient coming like this, so what do you see? Is it okay? This is a classical signature of a increase in intracranial pressure. With respect to the patient, I'm saying, the patient is walking, talking, I would not say this is an intracranial pressure is high for the patient. But if a patient was come with a head injury, that to a severe head injury, if I see a pattern like this, the first thing should strike is the patient is having an intracranial pressure, the two an intracranial hypertension, which has already started compromising the cerebral blood flow. So that is the inference which you give. So the diastolic flow velocity decreases, okay? So the spectrum becomes very narrow, and the PI, the pulsatility index and the resistance index go up. Normally the PI should range anywhere between 0.8 to 0.2. So the same patient, pupils bilateral dilated, patient has got a, even before shifting the patient to the CT scan, I'm getting this TCD. So what do you infer from this? See, we have only one heart, right? So this whole thing is one cardiac cycle, right? So here, what is happening here, just go to the previous slide and explain what has happened. See, this is the diastolic flow. So the brain needs diastolic flow all the time. I just ensured in the previous thing. That diastolic flow should be at least 1/3 of the systolic flow. So if you see the systole-diastolic ratio, it is 10. So it is very less. The diastolic flow is very less. And if you can see from this image, the heart is pumping blood from here, pushing into the brain, the brain is not only accepting the blood, it's even pushing the blood back into the heart. So this we call it as an oscillatory flow pattern or a high resistance reverberating flow pattern, and this is a classic signature. It's a classic death sentence for any adult patient. Any adult patient with a traumatic brain injury who has got this signature have not survived weeks. In fact, when we cannot diagnose brain death by reliable clinical examination, in some countries, this is accepted as an ancillary test. In India, we don't have any ancillary test for brain death. It is pure clinical. So, this is what it is. It is increasing the resistance here and is trying to pump the blood back into the heart. So we are talking about ONSD. So the ONSD, the problem is many a times we measure it wrongly. So if you see the ONSD, this optic nerve diameter, which is measured just about 0.3 centimeters from here. See, we should see the optic nerve. If you want to reliably measure the optic nerve sheath diameter, we should see the optic nerve, which should be hypoechoic. We should also see the optic sheath, which is hyperechoic. And after the optic sheath, we should again see a hypoechoic shadow, which is an artifact. So if you get a reliable picture like this in your ultrasound machine, then you can say in most of the published literature also, they report it wrongly and they just accept it for publication. So that is the problem with optic nerve sheath diameter, which can be done in the bedside, but it is again not a continuous monitoring. Just one point of time you are doing, and next point we don't know what happened to the patient. So pupillometry. So pupillometry is NPI. More than 4, we can relax, means the brainstem pathways are okay. And this is coming up in a big way, and there are a lot of studies which are coming, assessing the NPI. And any change in NPI from baseline to 1, they take it as significant and the patient has to go to a CT scan. So it can guide us when to get an interval CT scan, rather than doing it on every 6th hourly or next day based on expert consultation. So it can guide, it can give it can also make a prognostic marker if it is less than 1 NPI in any neurological injury. So it's a very poor prognostic marker. So NIRS came up in a big way, but there are problems associated with placing the sensor. While positioning the patient, the sensor will go away. You will not get the trends. Only the trends are reliable in NIRS when you monitor for a longer period of time. So it's more and more being used in non-neurological surgeries and non-neurological patients where they have to monitor the brain, like cardiac surgeries, during aortic valve replacements. In those cases, they're becoming more and more useful, and it's not getting very popular, even though the companies are pushing for this module. The better way to use these monitors is combine these monitors. So the guideline says that at least combine 2 of these monitors to reliably get some information that would affect the patient management. So this is the latest guidelines which is published in 2026, which talks about employing non-invasive monitors in the forefront, even if you have invasive monitoring capabilities, even in mild to moderate head injury patients. We always talk about ICP in severe head injury patient, invasive monitors. We don't talk about mild to moderate head injury patients where they can progress or where they can go into severe severe intracranial hypertension. So we can employ these monitors, and also in not all the patients eligible will be able to insert an ICP catheter because of so many issues, coagulopathy, or because of patients' affordability, all those things. So in those cases, it comes very, very handy, and we can take decisions. So this is a classical invasive ICP monitoring system which we have got. It's not only about the numbers, it's also about the compliance, which we are talking about from the morning. So that's very important. And this is the PBO2 monitor, and based on this, along with ICP, this protocol is in place where we phenotype the head injury into 4 types, A, B, C, and D. So if you look at B, it is both ICP is elevated, but the PBO2 is okay. But if the same time, if you go to D, the ICP is elevated and also the PBO2 is low. So they are very dangerous. So like this, we can phenotype the patient. Thereby, we can target the therapies, whether to give therapies to target increase intracranial pressure, or whether to improve the oxygenation by giving blood transfusion, by improving the blood flow, by increasing the blood pressure challenge, all those things can be done. So microdialysis catheters, once we talked about, we conducted various workshops, but it's not no more popular. But with the advent of triple probe, maybe it may come into use, and it gives even more information at the cellular level what is happening and how we target the therapies. So this is the triple probe which I was talking about. Through one probe, we monitor the ICP, we monitor the PbO2, and also we monitor the microdialysis values. So what we are aiming now in the maximal medical management, which we are talking from morning, is about apart from preventing secondary injuries and providing better outcomes, we aim for an auto-regulation based therapy. Means bedside, if you can measure the auto-regulation, then we can, for a particular patient, choose a blood pressure which will be optimal for the patient to maintain the cerebral perfusion pressure. So based on the computer algorithms and giving blood pressure challenges, we can say that at that particular point of time, it may change in the afternoon. When I do it in the morning, it may be one cerebral perfusion pressure optimal, but it can change in the afternoon. So thereby we can get a reliable auto-regulation curve and fix the BP. Because why it is important? Because you think that the patient's blood pressure is normal, but it may be actually hypotension for the brain, and it can increase the intraangular pressure. You think that you are maintaining a higher blood pressure to maintain the cerebral perfusion pressure, but actually it can harm the patient by increasing the intracranial pressure, thereby decreasing the cerebral perfusion pressure. So all those things can be done with the help of these monitors. And there are various indexes, and PRX is one such index. When you use ICP and blood pressure monitoring, you can use it with TCD also. The indexes are, and if you use it serially, then you can see how the patient's condition progress. This is taken from another patient. It's not a traumatic brain injury. You can see this is what I was telling about. See, the diastolic flow for this patient is even more than what is required. So that is also not a good thing. So it has become almost kind of normal, but it is not actually normal. It has started decreasing. But if you see this image alone, you will think that the patient is absolutely normal without seeing the previous image. But what is happening is that because this has become this, and later on it has become into a circulatory arrest. So this is what can happen when you monitor serially. We get a lot of information. The continuous EEG system, which is FDA approved, which I was talking about, it's coming up in a big way. And see the temperature of the patient, 43 degrees Celsius. So I want to stress that even though if you have a lot of monitors, the basic monitors are very important. All the patients of head injury should have an invasive temperature probe, should have an ETCO2 monitoring, should have an invasive arterial line, should have a central line. So these are all the basics before even we talk about other advanced monitoring. So we can monitor the brain at different level, from the pressure, blood flow, O2 delivery, metabolism, and CNS function, and we interpret this complex thing and we deliver the care. So this is all about multimodal neuromonitoring. What we employ, some of them are applicable and some of them may not be applicable out of institute, but we should not forget the basic. Clinical examination, correlation with the radiology, as well as strengthening the system and strengthening the basic monitor. Many centers we see, they don't even monitor the temperature. They just see the axillary temperature, which is no way going to reflect the core temperature. Even 1 degree Celsius fever control will do dramatic improvement for the brain's metabolism. Thank you.
Now I request the next speaker, Dr. K. Madhusudan, to please deliver his lecture.
Good afternoon, everyone. So I am Dr. Madhusudan from Kauvery Hospital, Trichy. So I am going to talk about cervical spine. At last we have come one step below. So my disclaimer is that it is not for the experts who are sitting here. It's for, I think, a lot of PGs are here. I think it will be useful for you. So what is the incidence? So cervical spine in head injury. It is about 1.2% to 20% in various studies. Let's go vice versa. Primary cervical spine injury with head injury is 24%, and primary head injury with cervical spine is about 6%. So they are always going hand in hand. So if you see a cervical spine injury patient, never miss a head injury. And if you seeing a head injury patient, unless proved otherwise, he is having a cervical spine injury. And you have seen various studies like occipital bone fracture. The incidence of cervical spine injury is around more than 20%. So In head injury patient, unless proved otherwise, the patient is having a cervical spine injury and the care should begin from the ER itself. So always it is better to go into the guidelines. It is for the ER physicians and the neurosurgeons also. This is a nice guidelines and Canadian C-spine rule are there to guide you to image the patient and know the guidelines. So when you need a imaging, that is a CT scan or an X-ray, whatever it is, we will get back to it later. So the nice guideline says when the GCS is less than 13 or a head injury that needs intubation, or you need to rule out cervical spine injury before you are taking him for an emergency surgery, or when multiple images are needed, and age more than 65, and the dangerous mechanism of injury, I think Joe sir already spoke about it, which is elaborated here. When the fall is more than 1 meter or 5 stairs, axial loading to head, like diving injuries, high-speed motor vehicle accidents, like rollover injuries, recreational motor vehicle accidents, ejection from seat and bicycle collisions. So the NICE guideline says whenever you have this, always do a CT cervical spine, that's what they say. And know the guidelines, but in your setting, maybe you are practicing in a level 1 center or level 2, level 3 center, always your judgment is the final thing. So whenever there is a severe head injury patients, unless proved otherwise, the patient is having a cervical spine injury. Either you rule out with a C-spine X-ray or you do a CT cervical spine, which is readily available. So when there is a no dangerous mechanism of injury, you have a patient who is sitting in your casualty, he is well alert, GCS is 15 by 15, there's no cervical tenderness, rear end motor vehicle accident, only delayed neck pain is present, not acute neck pain, only delayed neck pain is present. You can rotate the head 45 degrees to either side, and if it is okay, there is no need for imaging. That's what is given in NICE guidelines and the Canadian C-spine rule. But I always say, keep it always flexible. If the patient, in our setting, always the imaging modalities are always available. If your patient asks, sir, I'm worried about my C-spine, go about do any imaging, whether it can be CT cervical spine, X-ray or an MRI, go by what the patient and patient attenders are worried about. It always saves you in the longer run when you are doing a clinical practice. So this is for the PGs. Let's go about the fractures. This is the Atlas fracture classification. Type 1 fracture is either an anterior or posterior arch fracture. Type 2 is a dual fracture but in the anterior or posterior arch. 3A fracture is in the both anterior and posterior arch. 3B is associated with the ligamentous injury. Type 4 is a facetal injury and type 5 is a facetal injury with the involvement of the vertebral artery foramen. Know that type 3B and 4 are unstable fractures. So whenever we are talking about any spine injury, it's about stability and the neurological deficit. So know what are the unstable fractures, and you know the odontoid fractures, Anderson-Alonso classification. Type 1 is tip fracture, type 2 is the base of odontoid fracture, type 3 is a oblique fracture. Even in type 2, we have this classification of a horizontal fracture, anteroposteriorly oblique fracture, anteroposterior oblique fracture and posteroanteriorly oblique fractures. What is the importance is this, when you are going to do surgery, these kind of fractures, type B fractures, usually they reduce with flexion, whereas type C fractures reduce with extension. So you need to position the spine properly before you are placing an odontoid screws. And for all these fractures, dorsal fractures, lumbar fractures and cervical fractures, we have the AO classification. AO classification is very simple. Type A, there is a bony injury alone. Type B is a tension band or a ligamentous injury. Type C is a translational injury. You just remember that alone. We will not go into the details. Type A is a simple bony injury. Type B is a ligamentous injury. Type C is a translational injury. So B and C are always unstable fractures. Subaxial cervical spine, we are talking about C1, C2, then C3 to C7, we call it as a subaxial cervical spine. So here we have A0, that is spinous process fracture or a chip fracture are called AO fractures, which are stable fractures. A1 is a wedge compression fracture. A2 is a split fracture. A3 is an incomplete burst fracture, which can be superior or inferior end plate. A4 is a complete burst fracture. This A3 and A4 are unstable fractures. As I said, B is tension band injury fractures, which are ligamentous injuries. Posterior tension band injury fracture is B1. B2 is a posterior tension band injury, where the injury traverses through the bone and also the ligament structures. Sometimes we call it as a chance fracture. B3 is an anterior tension band injury. Sometimes B2 and B3 are unstable fractures which need stabilization. Type C is a translational injury. It can be an anterior translation or with rotation. So type C fractures are always unstable fractures. And also there is a classification for facetal fractures which you can get in any AO book, which I am not going into the details. So with neurological condition also, if N0 is neurologically intact, N1 is transient neurological deficit, N2 is radicular symptoms, N3 incomplete spinal cord injury, N4 is complete spinal cord injury, which cannot be assessed with NS. And M1 is, there is M2, we'll come to M2, which is a critical disc herniation, which I will discuss later. And then M3 and M4, M4 is a vertebral artery injury. So why you need to know this? In spine, when are we going to intervene? As I said, whenever there is a head injury, kindly consider there is a cervical spine injury, unless otherwise it's ruled out. Once you know there is a cervical spine injury, next thing we need to know whether it's an instability or it's a stable spine injury with or without neurological deficit. If the patient is going to have a neurological deficit, whether you are going to intervene or not, and if the patient is having a stable fracture or an unstable fracture. If there is an unstable fracture, yes, we are going to intervene the patient. So what is this? It's a type 2 odontoid fracture. It is an unstable fracture because left untreated, it is going to cause malunion or non-union and chronic neck pain and sometimes with neurological deficit. It can be dealt either anteriorly or posteriorly, and we have placed an odontoid screws for the patient. So this is one type of odontoid fracture. It's a type 2 odontoid fracture, and these are the various ways of fixing it. It is a transfacetal screw fixation, transarticular screw fixation. So we can see both sides. This is the C1, C2 joint, facetal joints. You can see the transfacetal screw fixation, which is done for type 2 odontoid fracture. And this patient, you can see a type 2 odontoid fracture, but you can see the end plates are sclerosed. It was a long-standing injury, and it can be fixed by posterior fixation, because in these cases, though it's a type 2 odontoid fracture, the end plates are sclerosed, so you can't go about do a odontoid screw fixation. We have to go with posterior stabilization. So in unstable fractures, you go about stabilizing. So this is an occipito-cervical fusion. What happens is you have got an extensive facetal injuries where you cannot put your C1, C2 screws. We have to include the occiput to the subaxial cervical spine. So this is a what type of fracture? It's AO type A, type B, type C. If you see the vertebral bodies alone, you can say it's a complete burst fracture with cord compression. But you can see posteriorly there is also a ligamentous injury is also there. So automatically it becomes type C fracture. So these needs complete fixation. So you have to decompress. There is a lot of controversies whether you go from front or you go from behind. Since the compression is from front, you always go decompress, put up cage or plate and go behind and fix. This is called a global fusion. This is done in a cervico-dorsal junction, C7, and a lot of times it is a blind area. You need to use O-arm if it is available, or sometimes it has to be done blindly. So lot of times if there is a cervical instability, maybe in future in your careers, if there's a bifacetal dislocation, that is a type C injury with bifacetal dislocation, whether to go anteriorly or posteriorly, there is always a doubt. So if there is a bifacetal dislocation, this Tellerman's algorithm, you go put a patient in GA, give a traction, most of the time it reduces. In that case, only anterior fixation is alone enough. If you can't reduce, put the patient in prone position, take the facets out, put a posterior fixation, then turn him and do a global fixation. So this is a pure anterior injury. There is a type B3 injury where you can see there is a disruption of the anterior longitudinal ligament with the disc fragments getting extruded. So it's a type B3 injury which is involving only the two columns, but because of the discoligamentous injury, patient is having a neurological deficit. Here you need to fix the spine because it's both unstable and also with neurological deficit. There is one concept that is called, I think you will be asked in exams about the Dennis 3 column. I think you know about the Dennis 3 column. So anterior column is about the anterior longitudinal ligament and half of the vertebral body. Posterior longitudinal ligament and the posterior half of the vertebral body is column 2, and the column 3 is the pedicles, facets and the spinous process and the lamina. If there is involvement of 2 or more column, it's an unstable injury. That is a very simple concept which we call it as a Dennis 3 column concept. So this is the type C injury which has been fixed globally. And thank you. So just know your criteria and guidelines, the NICE guidelines for selecting when to do a CT scan and when to do an X-ray. Anyway, in head injury patients, very unstable patients, unstable means, I think sir, it will create a controversy. Whenever you are going to do an imaging, multimodal imaging, you can include the CT cervical spine along with CT brain. And very stable patients, as I said, you do check for the rotations and movements and everything is normal. I think there is no need for imaging, but in our setting, if the patient attenders or the patient asks for any imaging, don't hesitate to do a imaging in our patients. So these are the concepts. So head injury, cervical spine injury is associated with head injury unless proved otherwise. Rule out whenever possible, rule out a cervical spine injury. And remember the stable spine injuries and unstable spine injuries, and depending on your experience, you have to take them for surgery. Thank you.
Thank you, Dr. Madhusudan, for highlighting the importance of ruling out cervical spine injury and head injury. Even in neurotrauma center study, AIMS Trauma Center study, they have highlighted that there is a 28% of associated cervical spine injury, especially if the patient is having a GCS of 8 or below. So that is important. Thank you. And there are 2-3 questions are allowed in the discussion part for the speakers. First, just I want to highlight one single point to, since Pune has mentioned about no ancillary test from our country in a brain death, just I want to highlight that we are doing regularly the DSA and CT angio to assess the brain death category. 4 points criteria are there as an ancillary test, especially if the patient is having bilateral ICD and clinical apnea test cannot be done in that scenario, we are doing CT angio. You have mentioned about the role of your that investigation modality, and we are doing CT angio and DSA in Alvar Pet Kauvery also to find out.
I'll answer that question, sir, very clear. The guidelines which has been revised, the international guidelines if you're talking about, CT angio has no role in diagnosing cerebrovascular. DSA we can do, and DSA also now recently there was a study in which there is no well set defined criteria even among the neuro interventional radiologists. And second thing, what I said was ancillary test, because brain death we can determine, don't we know that the patient is brain dead? We know, everybody know. But the problem is it is not written in the law book. That's what it is. If you are doing that and if you are declaring it, it's up to you to defend that. Of course, nobody is going to object that, but thing is that it is not been described in the law. That's it. Maybe it may be changing, it may change later on, but that's what it is. But CT angio is out, EEG is out. There's no EEG for ancillary test. There is no CT angio for ancillary test.
But what I have mentioned is a TransTan criteria It has been revised in 2023.
No,
That
that's
is
fine,
following
sir.
in Tamil Nadu, that's all.
Transatan, SOTO, everybody can create criteria. Even Ministry of Health can also create criteria, but they don't become law. I'm talking only about law. Law means it has to be passed in the parliament, it has to be in the law book. So death comes under law. So unless you have a law, it is up to you as a medical practitioner to defend it. See, don't we know that Harish Rana was vegetative, we can withdraw the support. As a doctor, you can do that, but why should somebody approach the Supreme Court? Because it's a law. All right. So if you are abiding by the law, we have to change the law. So many societies can form guidelines. Doesn't matter. But that is not law. It is up to you to defend if you are following the guidelines. Even many hospitals have their own criteria. But that will not fall under the purview of the law.
Yes, sir. Any other questions for any other?
Question is to Dr. Ranganathan Jyoti about lax duroplasty. How often are you able to do it? Do you think it's absolutely necessary? Because I almost never do it.
Malignant MC infarct. I do lax.
I think
head injuries I don't do, but because this topic is decompressive craniotomy for both traumatic brain injury and malignant MC infarct. For malignant MC infarct, I do. That's why just a principle of surgery I have written.
Most of the time in head injuries, we are doing it as we want to rush the patient and we want to finish the case as early as possible. So how many neurosurgeons are doing lax duroplasty with fasciolata, or how many neurosurgeons are doing simply removing the bone flap and closing? Just I want to check with all the neurosurgeons.
One question you ask, people can raise their hand.
Yeah, only the first question, how many of you are doing lax duroplasty? Trauma, in case of trauma, traumatic brain injury, subdural hematoma. No, only for the. Then removing the bone flap, how many of you are keeping it inside the subcutaneous plane? How many of you are keeping it in the refrigerator in a bone bank or something else? But in the recent JCA accreditation in the Alvarpet Kauvery, they are against it. They specifically told don't keep it in the body parts inside the, they mentioned, they have.
You cannot keep it, most often when it is kept in the blood bank refrigerator. Most places. That is objectionable. You need a separate refrigeration with minus something degrees where you can keep, see, even liver harvests arteries and all that. So to use for grafting. So all that bone, all that can be kept there. You cannot keep it along with blood.
Question to Dr. Ponnaya.
Madhu?
What is the role of jugular venous oxygen saturation in the monitoring of ICP or traumatic brain injury?
Yeah, again, it came up in a big way. Previously, it was in one of the tired algorithm. When we use hyperventilation, when nothing works as a last resort, in selected patient, we use the jugular venous oximetry and see if it is decreasing or if it is maintaining or normal. So we can use hyperventilation with that, but that is then removed and it's gone out of even jugular venous oximetry, and the central venous oximetry which we used for sepsis is no more being popular and we are using it.
Sir, sir was talking about the replacement of the bone flap as a free riding flap, which we do, sir. And sir also mentioned that it doesn't have overall outcome is the same with decompressive craniectomy and also keeping it as a free riding flap. So instead of placing it in the abdomen, we can also keep it as a free riding flap in the scalp itself.
Any other questions? Thank you. Thank you for all the speakers and all the participants for the session. We will with this we conclude the session and we will move on to the lunch.
Thank you so much, everyone. Thank you, sir. Thank you so much. And thanks for the wonderful session. So it's time to go ahead for a lunch break. So it's 1:35. Please take 45 minutes, not more than that, and please be back here. But with this, I will be signing off, and the sessions will be continued by somebody else. And thank you so much for this opportunity, being associated with Kauvery for almost 3 years, and it's always a pleasure being here with all of you. Thank you, and this is Akshaya signing off. Take care, bye-bye. Have an amazing rest of the day. Active clinical case discussion. I would like to invite our panelists, Dr. Jose Jasper, Dr. Raghunathan, Dr. Muthukumaran to the dais, please. And the moderators for the session are going to be Dr. Punaya Vanamurthy and Dr. Satish Kannan. Over to you, sir.
Thank you. Welcome back. Welcome, sir. So, the question about putting the bone back on subdural hematoma, sir, Ramakrishna was telling about the advantage and disadvantage. So, this is the case, sir. Young boy, GCS, E2, VT, intubated, and M4. Should we do a DC for him or medical management?
Okay. I think in a subdural, acute subdural, always safer to first do a craniectomy, go in, remove the subdural hematoma, then we see how tense the brain is. If the brain is relaxed, then usually you can comfortably put in a bone flap. But if the brain is very tense and you think it will worsen again, then obviously we leave out the bone flap.
How do you decide? If tense, it's okay. If it is not tense?
If in a younger patient, I would be more comfortable not putting in the bone flap. But in an elderly patient where already brain atrophy has taken place and there is lots of space inside, then most of the times we do get away with putting in the bone flap. Trauma, acute, most of these are youngsters, 18 years, 20 years. There, I normally like to wait on replacing the bone flap.
Sir, so in this case, based on GCS, let's say same scan, GCS 13, 14. So in that case, would you like to put the bone flap right away? Or same scan, GCS around M4, 5 to 6?
I think the GCS is only part of the story. Don't decide based on the GCS alone. A patient with a poor GCS can have associated brainstem injury because of which he is having a low GCS in addition to this. So if your entire brain looks swollen in the scan itself, if all your cell cycle are lost, if your gray-white interface is very bad, not looking very good, then all that status, if your basal cisterns are lost, then again now we do cystinostomy. Half the time we can get away with replacing the bone flap. I think it is a very individual decision. That is what I still think.
On the whole, Raghu, does it make a huge difference in the patient
Yes,
outcome?
sir.
Putting
Sir,
the bone
based
back or
on
not?
the etiology of the acute subdural hemorrhage, there are two types of acute subdural hemorrhage in a traumatic brain injury setting. One is the burst temporal lobe STH. Those patients, they have GCS less than 8/15, so we will remove the bone flap out. There is no, but there is another category called bridging vein acute subdural hemorrhage, where the brain will be lax, only subdural hemorrhage will be there. If the GCS is more than 10/15, you can go ahead and replace the bone flap. But provided the post-op neurocritical care should be available, because otherwise, suppose the post-operatively the patient is more aggressive or the BP is more than 150/100, there is high chance of recurrence of SDH. So sometimes it depends on the hospital care setting.
You mean to say there's a high chance of recurrence of SDH if you put the bone back?
Sir,
I'm saying that if you don't put the bone back, there's a high chance of subdural hygroma. So, your take on that?
No, actually, that is CS of dynamic issues. But in terms of acute recollection, I don't think putting the bone flap is an issue. Because I just want to ask whether any faculty here, do they have the practice of making perforations in the bone? Just for any collection, it can come out. Many multiple holes in the bone for any collection to come out if you're going to put the bone flap back.
No, the acute subdural hemorrhage is a clot. It will not come out.
No. When you keep the bone flap back.
After you do a subdural hematoma evacuation, I know of 1 or 2 surgeons who do that. When you replace a bone flap, you make like small burrows in that so that it can come out. Some do that. I have seen a few other people. What they do is when they replace a bone flap, the anterior end of the bone flap, they oppose it properly to the bone in the front. But in the back, you can bite off 1 or 1.5 centimeters of bone and put in a drain there and take it out also. I've seen surgeons do that also. Yes.
Yeah, because what we have noticed is when we used to, the giggly sauce days, when we used to cut the bone, we used to bevel it very well. So when you put the bone flap back, it used to go and sit very well. But currently with using the motorized drills, we cut the bone very like this, so the bone doesn't sit very properly. There will be some overriding. So you need to probably take a tie, or sometimes we even put a plate. We are very sure that's not going to be in recollection. So that is what something I want to know, because in that case, whether holes will help or not.
Sir has a question.
Craniotomy or craniectomy, described by many people, including Anil Pitambaram from Trivandrum, has spoken about making it into 4 and allowing it to expand if there is a collection. I think
there is an article, sir. There is an article, sir, but it is a time-consuming procedure, sir.
That doesn't matter.
Sir,
So
but
once you have the acute subdural out, you can take all the time in the world to put the bone back, unless you are in a setting where you got 4 other patients waiting. But here we are just discussing, should we put the bone back or not?
Variation of that, sir. What I do is, like, in fact, US, they have brought in plates. When the ICP goes up, the bone flap comes
Expandable
up.
plates,
Yeah,
yeah.
expandable
Those are there,
plates.
yeah.
Yes, that have come. But
So-
you can do something very simple. You just put one single plate, keep it in the center, so when the pressure goes, it opens up like a trap door.
Yeah.
When the pressure goes on, it goes on. So I'm sure all surgeons are using
Have
some
their
variation
techniques.
of the other. There is no one factor which tells you the brain will not become tense again.
Because the Anil Pitambaram's paper, which was being practiced in Trivandrum, now they have stopped doing that. Because the hinging out, making it into 4 cuts, and they have stopped using that because they had their own share of issues with that.
Yes.
How about putting
If there is a recollection, it is going to be a clot, sir. It is not going to be liquid.
That's
so it
fluid,
will
yeah.
not come out. There is whether it is a recollection, they have to open it
the
again.
More than recollection, like you said, it may be associated with a brain injury itself, which can swell up later on.
Yes.
So how about putting ICP catheter and putting the bone back and treat with maximal
Yes, sir.
medical
That's what I am
management?
trying to say. It's a neurocritical care. Post-operative neurocritical care based on the ICP monitoring.
So
if you are-
based on the setup and where you practice. it-
That decides, sir.
Okay. So that apart, that is well taken. That apart, what is the problem? Just leave the bone out. What is the problem? We are safe, no recollection.
No
Is that
bone at-
only
no
the
bone at all.
resurgery, or we are worried about something else? It's only about one more surgery, or we are worried about the overall outcome of the patient or something?
I think replacing the bone at the right time definitely gives clinical and neurological improvement to the patient. So if at all you do a craniectomy, you have to think of early cranioplasty. It can be normal bone, or it can be a titanium mesh or whatever it is, because I think studies now, lots of studies have come out saying you don't really need to replace the same bone. Lots of studies are saying you can use titanium mesh easily. Yes.
So currently, actually, that is what next point. As of now, most of the Western centers, replacing autologous bone has come out. Because there, what they believe is, even that 1 or 2% chances where the bone go for resorptions, it creates a lot of cosmetic issues, mental stress according to the patients. So now, as a protocol in Western cultures, in Australia at least, they have moved to 3D mesh. The bones are discarded. 3D printed titanium mesh is being the standard of care.
Sir, in Western culture, the whole cost is it is borne by the insurance company, sir. But in our regional setup, it is not quite possible because the 3D model per se, the implant alone, it costs more than 1.5 lakhs.
No, yeah. Now there are, the options are given 75,000. But the thing is that we should also look at, you keep a bone flap, it gets infected, you need to take it out. You can't put the bone flap 3D. So that.
So we have not encountered such like infection. Market
True that.
Sir, in our setup, like you all know, we have many surgeons in our setup. Like Madhu does it his way, Srihari does it his own way, and I do it my own way. Last 7-8 years, I have not replaced a single autologous bone. I've always used a mesh. The patient is not very affordable. I use the ordinary mesh. In fact, with the ordinary mesh, you spend a little time, you get results better than the 3D mesh. Because the 3D mesh, once it comes, even if it does not sit a little properly, there's always one small parallel gap, and it never takes into account your soft tissue. So what happens when the mesh comes, the mesh actually does not sit in the temporal base because you have a bulge of temporalis
So,
muscle there.
actually, putting a 3D mesh requires a lot more technical work than
Yes.
your routine autologous bone. You need to remove the muscle out, go up to the skull base, and then do that.
Yes.
And But currently what has happened is the cost has significantly come down. Now there are enough companies doing 3D measures for 60,000. 3D printed measures, not 3D
Sir,
molded.
in my early phase of the career, I myself use myself as a test and control, sir. First, I have using the, initially preserve the bone flap in the patient's abdomen wall itself.
I think what I would suggest is, like sir said, everything what is coming from the US, we cannot just discard as that it's company driven or market driven. So now we have a control center, Kauvery Trichy, we have other Kauveries, maybe probably we can compare our results.
Because the way myself and Madhu manage our patients itself is very different.
So that is because you don't have a bone bank or a bone freezer, or you don't like keeping it. Yeah.
I have certain problems with keeping the same bone in. One, I have to preserve it, either in the person's body or outside. Then I have to go, again, harvest it. And then when we place it, the bone reabsorbs. Definitely the bone becomes smaller. It is not vascular. We have to accept that also. It is not vascular. We can keep the same bone back, but it is not vascular. And some patients do get reactions to the dead bone that is inside also.
Okay. So just to extend this, usually...
Sir, I usually do cranioplasty as early as 6 weeks, sir. That's what, in the first surgery, what I do is I will do a lax duroplasty. I will keep that G-patch, that surgical G-patch. It will have a plane. It's very easy to dissect the pseudodura and the temporalis muscle. So for me, I have not encountered any complications. Even as early as 5 weeks, I have done the cranioplasty.
True.
So before avoiding the complication of all CS
infection rates are slightly higher than when we do earlier.
No, sir. So far, we have not encountered. Sir, gives a good cosmesis results, sir. Second thing is patients, you can avoid the CSF hydrodynamics disturbance also. Hygroma, hydrocephalus, all you can avoid.
Madhu?
We have stopped doing autologous bone grafts, sir. We had a lot of issues, infection issues, wherever we have stored, either in the abdomen.
Different centers, sir. Different centers, good.
So, to avoid that, nowadays I use in some cases when the brain is relatively lax, as sir said, I use to a overriding bone flap. To just take care, no, we can't say that we can't create a beveled edge. Yes, with the drill also we can create a beveled edge. You make sure you create a beveled edge, and you can keep it as an overriding bone flap. So once the brain settles, automatically it fuses.
You can fix that manipulate in one side or
yeah, that can also be done.
On the other side, you cannot. You need not
I think we'll move on.
Yes.
Well, the UK practice is quite clear. You're not allowed to store bone anymore. And we don't do abdominal pockets anymore because of resorption, infection, loss of vascular supply. The only way is either titanium or PEEK or custom bone, hydroxyapatite bone flaps made to the defects. And the problems, obviously we all know that having such injuries is a hugely morbid condition. Patients struggle no matter what you do. And I don't think there is a clear answer. Even if you put the own bone back, there are plenty of occasions when I've gone back in, taken it out because of infection, reaccumulation of a bleed, one way or the other. If you put a cranioplasty, you have long-term after effects. Titanium can come out. There are plenty of pediatric cranioplasty studies which show that titanium comes out over 10 to 15, 20 years. If you operate on a 60-year-old person, maybe that's not so much of an issue. But if you operate on someone who's only 10, they have another 70 years of life left. You will inevitably have cranioplasty-related problems. They end up needing plastic surgery, grafts, rotational flaps, taking out the old cranioplasty. So there is a lot to think about anyway. I don't think there is a very clear-cut answer, but in a young patient like this, I would have a very low threshold for leaving bone out, because saving the life at that point in time is more important, I think.
So this patient, the bone was left out and... Okay. So this patient
sir, actually, that matters a lot, sir. Actually, because in like level 3 or 4 centers where neurosurgeons work, we don't have that privilege of having neurocritical care or neuroanesthesia. Only common pooling of the anesthetist will be there. Very difficult to manage in the post-operative periods.
Okay, Raghu.
So this is the post-operative CT scan. So my point is, we encounter a lot of CSF dynamic changes after, most often we see after DC. Could this be prevented by putting a bone back, or it will happen despite?
Sir, I'll just tell you, like, I don't want to name names, but we had a neurosurgeon who recently had a trauma. We know that. The bone flap was kept in his abdomen, and that whole place developed a fungal infection. Then we had problems with that, managing it. We have seen it quite often, putting it there. So, like he said, if we can place it back where it belongs in one way or the other, I think that's the best solution. The second best is throwing it away and maybe using mesh.
The question was different, sir, means about the CSF dynamics. So, is there a difference with bone put back or bone not work?
Put back is better.
Sir, in the acute phase, life saving is the first priority, sir. So if the GCS is low, if we expect a stormy post-operative course, we take the bone flap out. We will let us worry about this hydrocephalus after 6 weeks. Suppose if it is possible, if you just do early cranioplasty, you can avoid the CSF dynamics complications.
True, but thing is that whatever you are thinking us will not do harm, can do harm also, because when we don't know, we employ enough mind. In this case, after evacuation of hematoma, the bone flap is out, so you see the TCD finding. They are not benign blood flows, okay? So most of the times when the DC is done, it loses the resistance which the intracranial pressure gives to receive the blood. When it's atmospheric, when the brain is so lax, especially in acute injury, your arterioles will dilate. It's not at all good for the cells. So I don't have enough data to document it, but this is a personal observation of me. Okay, this is not at all a good flow. Yeah. So I'm just telling, this is a precision medicine if you go by this. Okay.
Sir, coming into the physiology, obviously the CSF dynamics will change. See, you need to have a closed space to increase the intra-CSF pressure so that it drains into the superior sagittal sinus. We obviously lose that. In an head injury, with a severe head injury, our subarachnoid granulations is not going to work properly as before. The opening pressure is going to change. So there are multiple factors, not just a single factor, that the decompression alone. There are multiple factors. So if there is a abnormal CSF collection or something like that, it can happen even after replacing the bone also. In that case, you need to be careful whether it can be an hydrocephalus. So maybe he may be having a hydrocephalus which he has developed after a 3rd week or 4th week. So it can also be a factor.
So these are the things.
Size of the bone flap also matters, sir. Suppose if you extend the bone flap till the midline, definitely the patient is going to land up in CSF dynamics complication. If you stick to the bone flap in the mid-pupilar line, the incidence of hydrocephalus is less, because the CSF absorption more happens in the convexity only. If most of the convexity is compromised, the CSF hydrodynamics is going to get altered.
All right. So like we had discussion in the lectures based on the guidelines, which say that decompressive craniectomy clearly is life-saving. But I'm talking about with respect to diffuse injury, not about a straightforward surgical lesions like the case which we discussed before. As a part of refractory intracranial pressure management, most of the centers, we don't have intracranial pressure management. So we employ decompressive craniectomy in the early stage of the care itself. And that has also been approved by the revised guidelines that when we don't have the setup, you can employ it early. Even in centers where we have everything, maybe the financial aspects of the patient and the social aspect may not permit a lengthy hospital stay. So we go for a early decompressive craniectomy. But if a patient is, you're given an option for an early decompressive craniectomy and ICP-based tired therapy and management in a scan like this, in a patient who has got a GCS of less than 8, intubated, so what would you prefer? From first we'll take a vote and then we will justify it, sir. So this case.
Before the vote, sir, wait a second. Before the vote, I have a flight to catch. I require. I know you. I request. I request Dr. Madhusudan to come here. Thank you very much.
Thank you, sir. Thank you.
Sorry, real sorry.
Thank you, sir. Thank you. So in a case like this, is it better, considering the, anyway the patient medical management may not work, so we go for early decompressive craniectomy in our setup or in your setup where we are practicing, or we have to go a tired approach? If the medical management doesn't work, then we have to go for a decompressive craniectomy. So for DC, sir,
Right-sided.
so everybody agrees only for medical management. Raghu, your thoughts on the
First
Muthu also you can
72
join.
hours ICP, tired ICP management protocol, sir. If after 48 hours we'll follow repeat CT, the repeat CT and the GCs is the same, go for a secondary disease. That is refractory hypertension therapy, decompressive craniectomy.
So in that case, the decision is made only on imaging and clinical status. You mean to say first 72 hours, you go clinically and imaging,
Repeat
but
CT and just check for the basal substance effacement. If the GC is still persistently less than 6/15, the patient is not improving. The CT is also more or less the same. Go for a secondary disease.
same scenario, you have the facility of an ICP, you put in an ICP. ICP from day one is very high, not responding to medical management.
If ICP is not, it is not responding to medical management, refractory ICP, then there is no point in waiting for the clinical improvement or clinical deterioration. So we don't regularly do ICP monitoring, but if you are doing ICP monitoring and is refractory to medical management, then we have to do a decompressive craniectomy. There is no doubt in it. Either you are going to do on right side or left side, or you are going to do a bifrontal decompression, it's individualized. But if it is a refractory ICP, don't wait for clinical deterioration or any change in CT, go about a decompressive craniectomy.
Sorry, the quick question was, what was the clinical status of this patient to begin with? How did they come in, do we know? Because just if we comment based purely on that scan, that does not seem like a scan that's compatible with any kind of quality of life. I mean, not even life, forget quality of life. Now, we are talking a lot about surgical intervention, major surgical intervention, doing things like bifrontal craniectomies, which are hugely morbid. And what are we going to do in the end? Probably create a cabbage.
No, that's a good point which you have brought in. I'll bring it to the devastating brain injury concept here. Do you think this injury is a devastating injury?
See, if the patient GCS is 3 and the pupils are dilated, then there is no point in doing anything at all.
That is exactly why I asked.
But what if
Looking
the
at this
patient,
scan.
so this is a scan, what if the patient is in GCS 5 and his pupils are bilaterally equal and reacting? And your ICP monitoring shows refractory ICP, then what you will do?
Again, even if it's GCS 5 with pupils working, with this kind of a scan, if you follow them through with enough cases like a case series, with the brainstem looking the way it is, presumably Duret's hemorrhages also present, they're unlikely to do anything at all. The MRS is not going to be better than 4 or 5.
Actually, as per the textbook description, even I have gone through recent times, sir.
So what is your definition of a devastating brain injury? So the radiology itself is enough, because you're saying clinical doesn't matter with the scan.
No, I'm not saying clinical doesn't matter. That is why the first question I asked was, what was the patient like? I do go by clinical status, but if we are going to debate and comment purely based on these scans, I would argue this is a devastating
E1
brain
VT
injury.
and M2 is decerebrating, and the pupils are equal, but it's not reacting.
Okay, so I can only comment on the experience I've had. In the UK, that would be considered a devastating brain injury.
Devastating.
There is no chance they would get a decompressive craniectomy because there is no chance of a reasonable dignity of survival. That would be
So
the,
this decision is made only by the surgeon, or in with
No, the combination.
let's say the same situation, the family wants surgery.
So, you see, the UK is a diverse community. There are lots of different ethnicities coming into the discussion. And the decision is made by the family, the surgeon, the neurointensivist, the emergency care physician, and sometimes even the radiologist. We sit together, have a multidisciplinary meeting, and then we decide. But most of the cases like this are devastating. I mean, we have plenty of case series and publications.
So I think that is
Crossroad
the
trials.
standard. We always do an MDT in these kind of cases. We probably paint the worst possible picture. But after all said and done in private practice, when the patients want for surgery, we've seen patients, we've all been proved wrong, where we thought this patient will not survive, but we've seen these patients like this come walking to us. So that might be a very small percentage, totally not fitting the actual data. So I think that call to be made at that point of the time is little difficult.
I think our Brain Trauma Foundation guidelines, nothing says that you should not operate for this GCS.
No, that is what
they will never comment on the cultural aspect of
but
practice.
they always say it's individualized on case-by-case basis.
Absolutely, which is why, if in the end, in our cultural context, practicing in our country, if the family are absolutely insistent they want you to do everything, fair enough.
That's what we always do, no? Put the ball in their court. You say the prognosis of...
I think putting the ball entirely in their court.
I think we will be discussing this in detail in the third session. So right now we'll just touch upon this and we'll go. We are going to have a detailed discussion on this. So this for a decompressive craniectomy, we know it's going to prolong the life, but morbidity, we cannot comment about the morbidity. All right. So in the rescue acute subdural hematoma trial on 2023, said there is no significant difference between craniectomy and craniotomy when you do for subdural hematoma. There's a slightly higher risk for rescue following up surgery for solution.
Sir, actually, the trial is ongoing, sir. It is not yet finalized.
No, it's still ongoing, but the large term results are there.
No, it's a multi-center trial. It is ongoing.
Yeah.
It's not
So
yet
most of
concluded.
the results, nothing has changed. Most of the things are the same. Only thing which is actually very useful is, initially they were promoting ICP monitoring very aggressively. Now, actually what you said, like what you practice, 72 hours, that is more than enough. They say an expert with his own radiological imaging and his own follow-up is more than. ICP itself is not made decisions or not made changes in outcomes. That is something which we had, but pursuing it aggressively made no difference.
So now the concept is totally changing, sir. Now we are not like bothered about the ICP values like 20, 25 for more than 50
No, I'm talking about ICP monitoring
now
required or not.
We are going beyond the ICP. That is based on the brain tissue oxygen tension and then other parameters. We are not solely relying on the ICP alone.
See, this is with this I'll just conclude this session. See, this article, nobody talks about it. So decompressive craniectomy in patients with traumatic brain injury, always we relate with secondary decompressive craniectomy. Most of the guidelines, the BTF, everybody talks only about secondary decompressive craniectomy and the outcome, the mortality is not good. But when it is done for primary thing, the mortality and morbidity, everything is actually good. And if you see in this study, the real world and the clinical trial disconnect, they felt that almost, if you see the qualified patients for DECRA, there may be only 10% of the overall population which we see. For the rescue ICP, it will be only 16%. But rest of the disease, the majority of the disease is done for primary disease. So that is a straightforward decision. You see the radiology and you apply the decision. So this is one point which we need to remember when we talk about decompressive craniectomy. We need to segregate.
Sir, both the DECRA trial and the rescue ICP trial, the methods vary, sir. Surgical method in DECRA trial, the choosing the patients.
I'm not going into that. I'm just telling about the concept of decompressive craniectomy, how it is perceived by the
because in DECRA trial, all the patients went for early DC, sir. But in rescue ICP trial, only the secondary DC has been done, sir. Not in the first 48 hours.
Yeah.
Also, in like rescue ICP trial, the ligation of the anterior superior sagittal sinus is done, sir. It's not done in the DECRA trial.
All right, Muthu, to just close the remarks. So,
why don't you take into consideration the biomarkers, blood biomarkers like lactate, the ratio between the lactate and other ratio. If it is less than 1, then the death is, whether you do decompressive craniectomy or not, the death is imminent. So you take the blood biomarkers are taken into consideration before taking decision of this surgical decompression at all.
So that is all at the study level, but it's not.
Pyruvate lactate ratio, that gives you whether the patient will survive or not. You include that also, then you decide about the craniotomy.
Point taken, sir. Muthu, you want to just comment on the medical management aspect?
The medical management, we do as a tire protocol, and we do the accordingly to the cerebral perfusion pressure, and we decide on osmolar therapies which mannitol or hypertonic saline, and CSF diversion methods are practiced. The second tire.
So for the students' benefits, just I'll finish off these slides. So there are various algorithms which is available, which you are using. If you are using only ICP, there is a way, there is an algorithm. If you are using both ICP and brain tissue oxygen monitor, sir was insisting on using biomarkers as well. So there is an algorithm which classify the patient into A, B, C, D types, which we are in. And if you don't have anything, if you go only by clinical and radiological, there is an algorithm to monitor the patient and also to de-escalate the care. So if you don't have invasive, if you have only non-invasive ways of monitoring, when invasive systems are not available, then we have the B iconic statement, which is published on 2025, and there are algorithms to escalate the therapy and de-escalate the therapy. And if you have invasive monitoring, but still you can use non-invasive monitoring tools as a first priority, we can triage the patient who will benefit for invasive monitoring. So thank you panelists for a wonderful discussion, and thank you all for actively participating in this discussion. If somebody wants, just you can text me, I'll just forward it to you.
Thank you. We are going for the next session. I would like to invite the chairpersons, Dr. Ranganathan Jodi, sir, Chief Brain Spine Surgeon, Director of Neuroscience, Kauvery Hospital, Vadapalani. Dr. Ponnaya, sir, I mentor, Head and Senior Consultant, Neuro Anesthesia, Neurocritical Care, Kauvery Hospital, Radial Road. And Satish Kannan, sir, Senior Consultant, my friend. Neurosurgeon, Kauvery Hospital, Radial Road.
Program, please.
Start the next session, wherein I'll call Dr. N. Sridhar, Consultant Intensive Care Specialist, Kauvery Hospital, Alvarpet, who is going to talk on optimizing unstable traumatic brain injury.
Afternoon all. So I'm Sridhar. I work in the ICU at Kauvery Hospital, Alvarpet. So my talk is on traumatic brain injury in unstable patients. So essentially, I'll break into 3 parts, and each part will have 3 things. So I'm going to talk about, you all know about ATLS, ABCD approach, so I'm not going to go into all that. I just want to hand over a few practical points that I picked up over the last few years. So 3 procedures, 3 drugs, and 3 concepts. That's all I'm going to talk about. So the previous hospital I worked in was part of a trauma network. It was considered one of the best in Europe. And this is what they used to do. So if somebody is collapsed with a traumatic brain injury and they're unstable, the patient is going to die of 3 main reasons. A traumatic brain injury causing such severe injury that the patient is going to cone at that point, or something to do with airway or breathing causing hypoxia, or third thing, hemorrhage at the site, hemorrhagic shock. So these are 3 things that are going to cause death for the patient. So before they had 2 approaches. One is stay and play. They will stay on the site and try and resuscitate the patient, or scoop and run, pick the patient and move. So they arrived at an approach which was giving the best possible outcomes. So this involved 3 procedures. Okay, so this patient had clearly major brain injury, is unconscious, has got some sort of respiratory compromise, is hypoxic, and their blood pressure is low. So three important procedures. One, we all know, rapid sequence intubation at the site with cervical spine protection. The second thing they would do if there was a breathing problem is there is no time to auscultate properly, get X-rays at this site. So what they will do is they will go for mini thoracotomy, as I said, bilateral mini thoracostomies. So they don't want to put in a small needle anteriorly in the mid-axillary line or mid-clavicular line as per these things, because either there's a pneumothorax and you released it, but then it will reaccumulate, or you're causing a pneumothorax, there's no underlying pneumothorax. We are acting in an environment where there's a lot of doubt. There is diagnostic uncertainty, and that's one of the features of management of trauma. Normally in medicine, we want diagnostic certainty, we want confirmation before we do. But in trauma, in an acutely changing situation, if there is any doubt, then we want to go down a pathway which will be life-saving. So what they will do, secure the airway, bilateral mini thoracostomies. In other words, they make a cut above the rib, open it, enter the pleural space, and leave it open. Don't bother putting chest drains in, don't waste time securing all this, move. Okay, so once there are thoracostomies, there's never going to be accumulation of air. The patient is not going to die of a pneumothorax. The third thing they would do is get rapid vascular access. Now, if this patient is shocked, this can be very tricky. So what we would do is swan sheets. You all may or may not belong to the generation where you've seen swan sheets. Take one and quickly place it with manual method, not radiology, into the subclavian line. Now, of all the venous access that we have, the subclavian vein is the one surrounded by fibrous tissue and hence least likely to collapse. So you get a wide bore cannula into this, you can resuscitate with whatever volume you want, whatever fluid you want very quickly. So 3 procedures, scoop, brought to ER. In the ER, 3 drugs are essential. And I'm not going to talk about rapid sequence intubation drugs. I'm not going to talk about antibiotics. 3 drugs will prove life-saving in a patient who is unconscious, bleeding, and has got low oxygen. Okay, 3 drugs. One, we all know, tranexamic acid. Especially in the first 3 hours, patient has come in, lots of trials proving beneficiary. So just give 1 gram over 10 minutes. And then you can talk about the infusion later on. Or if you don't want to do that, give 2 grams over 15 minutes and don't have to worry about infusion. The second drug that is going to save life is hypertonic saline. Okay, just give 200 ml of 3% hypertonic saline. Do not worry about, has this patient got any contraindication to this, what electrolytes can I give. If the patient is unconscious, is waiting in ER before you go to get confirmatory scan, no harm can possibly arrive from giving 200 ml of 3% saline. The third drug that we all use is adrenaline. Take 1 ml of adrenaline, dilute it in a syringe to 20 ml, and this is going to be in a pocket. I don't want to waste time asking nurses to get ready, noradrenaline infusions, putting pumps, connecting to lines. Every time the patient's blood pressure drops below a certain target, you just give 1 ml and feel the pulse and move. Because right now, what is our goal is stabilization and going for imaging. Now, people used to talk about E-fast, lost. We've all moved on from that. Now it's all CT, head to pelvis, and further down if required. So the main thing is moving there. So 3 drugs, 3 procedures, and 3 concepts. 3 concepts, the first and most important concept is permissive hypotension. Now, we all know about permissive hypotension, but the person who used to push this forward talks about in a different way. I want to talk about his view because I thought that was very important in changing how I looked at it. So we see somebody without intracranial injury and we say, okay, blood pressure 70, 80 is okay. That all we all know. And we all say, oh, it's okay. But he said, do not call it permissive hypotension. It gives you a feeling of calmness and you're accepting something that is not physiological. Call it deliberate under resuscitation. So it means you know that this is not acceptable, but you're deliberating, waiting for a short period of time till you get access to the bleeding point. This is somebody with hemorrhage, somebody with shock, somebody with coexisting injuries. And where did they learn all this from? Not from hospitals. They learned all this from what they're doing now, attacking countries that possibly don't need attacking and getting their soldiers wounded. So this was all learned in the battlefields of Iraq and Afghanistan. So if you look at those commando teams that went there, there would be 4 people in each SAS team, and there would be multiple trained. We had SAS commando teams come over to our hospital to learn how to do tracheostomies. That's how good they are. And in their packs, in addition to communication, explosives, and other weapons, they would carry something called lyophilized plasma, which is basically plasma that can be given to anyone. You take this plasma, you mix it with 200 ml of saline, and boom, you have readily available plasma with concentrates that you can give. So initially, when somebody was bleeding, they would try and push this in. And more people were dying before they got them to the ER center in these war zones. So what they would do is say, let us not push all this, let us get access. And as long as the patient has not got, or soldier has not got head injury, they're talking, and you can feel their radial pulse, don't do anything, do not push fluids. And they found that these people were much more likely to survive, and hence the concept of permissive hypertension, or what we call deliberate under resuscitation, was born. But we cannot practice permissive hypertension for more than 1 to 1.5 hours. Beyond that, all other organs will start getting damaged. So now we move to the situation, what blood pressure are we going to target? As we had divided everything into 3, I'll divide this into 3 also. So we accept a blood pressure of 70 systolic if you can measure it, or if you can feel the femoral or radial pulse and the patient is talking. The patient has got traumatic brain injury, we do not go for 70. We want a higher one because now we know for sure the systolic blood pressure is less than 90, you're going to cause secondary brain injury, which is what we are trying to avoid. So in these cases, aim for a higher systolic of 90. So one blood pressure of 70, no brain injury, massive hemorrhage, systolic of 70. With coexisting traumatic brain injury, systolic of 90. And we need one more, isn't it? So an in-between blood pressure of 80. And what is systolic blood pressure of 80? It is what our goal is when we want to transfer the patient. You know, when you are resuscitating the patient ER, we are now, our goal is to find out what the problem is. We are stabilized, we have looked at and done the 3 drugs and the 3 procedures that is otherwise going to kill the patient. You want to go to radiology to gain as much information as possible. So in this context, a systolic blood pressure of 80 is fine. We don't want very high blood pressures, we don't want very low blood pressures. If I have 80 and I have my syringe of adrenaline with me to walk with the patient, I can keep giving 1 ml boluses to bring it up whatever my target is, 70, 80 or 90, then that's fine. So this is one concept. The second concept is damage control surgery. So trauma does not come neatly packaged in a traumatic brain injury. There can be rib injuries, there could be lung injury, there could be cardiac contusions, there could be intra-abdominal injuries. So previously they would go to theater and say, okay, let us fix all these injuries together. So for example, there's large liver laceration, they will go and spend hours trying to get control over this bleeding. Now the concept is simple. If the patient is not going to die from it, do not mess with it. So the patient has got large liver laceration. The present concept is just pack it and come out. Do not do anything in the acute phase. Do not have to do anything in the first 3 or 4 days. If the patient has got bowel injury, do not spend time trying to repair the bowel, trying to do an anastomosis. Just bring the top end of the bowel as a mucus fistula out and the bottom end as a stoma, and then forget about it and you can fix the bowel later. So this is the second most important concept. And the third concept that I want to talk about is once again, which you all are probably aware by now, is the 1:1:1 transfusion. So we are going back to the days wherein we want to give whole blood, but we don't have whole blood now because we've already broken down its component. So anytime you're heading towards massive transfusion, in other words, you need more than 3 to 4 units, and your patient is responding temporarily, blood pressure is going up and starting to drop, then we have to look into giving 4 units of blood with 4 units of FP, with 4 single donor platelets, or sorry, 4 random donor platelets or 1 single donor platelet, whatever you have, we need to do this. Another trick I want to tell you is the blood that we always used to have in our trauma centers, we would always have O negative blood available, 4 units at all times. But what do you do when you don't have? Can we give O positive blood? Yes, we can. And why is it safe? Because your anti-O, anti-A, anti-V antibodies, which are going to cause your hemolytic reaction, are already preformed. You're born with it based on your blood group. But RH you only get out of exposure. This is the reason behind giving anti-RHD for pregnant women. So if you gave somebody who's negative, positive RH group, they will not react to it immediately unless in the very likelihood they already have it. They will have to form antibodies to it. So that will take another 2 weeks. So in initial resuscitation, especially if they are men, by all means give O positive blood and don't have to worry about it. Even if they're O negative, if you give O positive, nothing is going to happen. And for the first 2 weeks in which antibodies are not formed, first 2 or 3 days you can give whatever you want. For pregnant women or women in the childbearing age, try and avoid it. But if life or this is at risk, I would say screw it and give the O positive blood. So these are the 3 concepts. And from here we move to CT scan. And from CT scan, once again, we go to one of 3 areas. You found CT, you found the injuries, you found a blush, then you have to look at cath lab and interventional radiology if you have those facilities. You have any other injuries that need addressing in theater, then the second area you go to is theater. No other injuries, you just want to keep the patient warm, rehydrate the patient, prevent any acidosis, then you come to ICU. So I think this is my general rule of the 3s. I think the fundamental principle is we're operating in an area where there is a lot of diagnostic uncertainty. Let us do those things quickly that will save life, and let us do these things. Thank you. Questions later?
Towards the end.
Thank you.
So for the next talk, I call up my colleague, Dr. Sindhu Priya, consultant neuroanesthesiology and neurocritical care, Kauvery Hospital Radial Road, to talk about a nightmare for neurosurgeons, anticoagulations and antiplatelets in TBI.
Good afternoon, everyone. So like Dr. Satish said, this is a nightmare for all neurosurgeons, and it is a fire in the brain. So we need to know how to put it off. So there has been a lot of studies which have said that a patient who is on antiplatelets or anticoagulants, simply put antithrombotics, the risk of hematoma expansion is manifold when compared to a patient who is not on any of these medications. So now, first of all, we need to know why the patients are taking these medications. Now with the advent of complicated cardiac procedures, cardiac stenting procedures, and stroke intervention procedures, and patients with stroke, and patients with mitral valve replacement, the indications for antiplatelets and anticoagulants have become increased. So in a patient with mitral valve replacement or a DVT, or if the patient is having atrial fibrillation, they become candidates who have to be put on anticoagulations and antiplatelets. And if these patients have a road traffic accident, the management becomes a little complex. So now, how do we reverse the antiplatelets? Do we have a specific reversal agent for our antiplatelets? The answer is no. So what do we do then? So do we give platelet transfusion? Yes, we do give platelet transfusion only if the patient needs an emergency neurosurgical procedure. Otherwise, we do not. But there has been literature based on vasopressin infusion or methylprednisolone and even tranexamic acid, but the data is inconsistent and there is a lot of heterogeneity in practice. And it has been found out that patients who are on single antiplatelet versus dual antiplatelet, it has been found that patients who are on dual antiplatelets, they have a risk of hematoma expansion much more than a patient who is taking a single antiplatelet. And clopidogrel patients, they have more hematoma expansion when compared to a patient who is taking ecospirin. And we also have to know that the lifespan of the platelets is 7 days. So even if you do give platelet transfusion, it's not going to be beneficial. It's going to get inhibited. So what do? Do we have to discontinue the antiplatelets? Definitely yes, do it. And give platelet transfusion only if the patient needs neurosurgery or any EVD insertions. And there's a trial, the patch trial, which has said that the transfusion of platelets is inferior and a single donor platelet is more than enough. Otherwise, one SDP is equivalent to 4 to 5 RDPs, so you can convert it. And vasopressin, we usually do not use here, but yes, it has been considered. And ticagrelor is a reversible platelet inhibitor, so it will, even if you give platelet transfusion, it's not going to be beneficial. Now, say for example, the patient is there in our hospital and is being given unfractionated heparin. If this patient has a slip and fall in our own hospital, the patient can have TBI. So how do we reverse this? So the reversal agent for unfractionated heparin is protamine sulfate, and we have to give in a dose of 1 milligram for every 100 units of heparin which has been given in the last 4 hours, because most of the times we give unfractionated heparin as an infusion. And the maximum dose is 50 milligrams, and we need to keep in mind the side effects of giving protamine, that is bronchospasm and hypotension. So we have to be vigilant and monitoring whenever you're giving that, and you cannot give it as a bolus. You have to give it over a period of 10 minutes under strict monitoring. What about low molecular weight heparin? So low molecular weight heparin again can be reversed with protamine, but its efficacy is not going to be as good as how it reverses an unfractionated heparin, and we have to give 1 milligram per mg of enoxaparin which the patient has received in the past 8 hours, or a maximum of 50 milligrams. As far as dalteparin is considered, we have to give 1 milligram for every 100 units of dalteparin, and here FFP and vitamin K are usually ineffective. Now coming to warfarin, usually all the patients with mechanical heart valves will be put on warfarin, and it is a vitamin K antagonist. So very important is a prompt reversal of the anticoagulation. And it's a well-known fact that as a hematoma size keeps increasing, the patient's outcome is going to keep decreasing. So we have to act fast, and we have to give the reversal agent immediately. So what is the reversal agent for warfarin? We have prothrombin complex concentrate, which has a high concentration of the clotting factors which are synthesized in the liver, that is 2, 7, 9, and 10. So the onset of action of prothrombin complex concentrate is within 5 to 15 minutes and it lasts for 6 to 8 hours. And as you know that the hematoma expansion is the highest in the first 24 hours and it's very, very high in the initial few hours. So we have to utilize this time and give the prothrombin complex concentrate. And yes, of course, this is not devoid of any complications. There can be DVT, pulmonary thromboembolism, and myocardial infarction, but we always have to benefit the risks versus the benefit and give it. So I mean, we have a 4-factor prothrombin complex concentrate, and there is also a 3-factor prothrombin complex concentrate, but the direct comparisons have not been made. And Factor 7, recombinant factor 7A has also been tried for warfarin, but it does result in a rapid INR reversal, but we have to know that it is a highly thrombogenic drug, and so you give it, the risks are more when compared to the benefit because it results in thrombotic complications in many places like pulmonary thromboembolism and DVT and so on. So how do we dose our prothrombin complex concentrate? It can be dosed based upon your INR or even weight-based. So just remember that at least an average of 20 units per kg of prothrombin complex concentrate has to be given. So we can also utilize thromboelastograms to guide our treatment, and here you can see that this is the complete warfarin effect. There's a prolongation of R, and there is also a decrease in the amplitude. So once you give the warfarin, the waveform has completely normalized. So that effective is prothrombin complex concentrate. And along with prothrombin complex concentrate, we need to give vitamin K as well. 10 milligrams has to be given. Now coming to oral anticoagulation, the novel oral anticoagulants like the rivaroxaban, apixaban, edoxaban, the factor 10A inhibitors. So these patients also we have to discontinue. Once we know that the patient is on these medications, we have to discontinue it. FFP and vitamin K are not effective. We can consider activated charcoal if the last dose was administered within the previous 2 hours, and prothrombin complex concentrate at a dose of 50 units per kg can be given. Although the agent-specific reversal agent is andexanet alpha. Till 2024, it was not available in India. From 2024, it's available, but it's very, very expensive. So prothrombin complex concentrate is equally effective. And there's no role for factor 7A. Now coming to dabigatran, which is a direct thrombin inhibitor, the agent-specific reversal agent is idarazumab. It is available in India, but it is not kept in every hospital like it is supposed to be because of the limited availability. So we can give prothrombin complex concentrate to these patients at a dose of 50 units per kg, or activated charcoal can be given within 2 hours. And if they come within the time limit, we can even consider dialysis. Now we have stopped it. Now we also need to know when to resume it. So if the patient is having a traumatic, in traumatic brain injury, if there is a contusion, we can consider starting it within a 2 to 4 week after the injury has happened, especially the anticoagulation. And if it is a large ICH, then we can consider restarting it after 6 weeks. And if the patient has had an SDH, then at least we have to wait for 6 to 12 weeks. And I would slightly favor starting it slightly lately to prevent the recurrence of the bleeding. So just for the resident's sake, so what's the role of platelet transfusion? It's a no if we don't contemplate any surgery. It's a yes if we contemplate surgery, you can give platelet transfusion. For warfarin, what do we give? We give vitamin K as well as 4-factor prothrombin complex concentrate. And for dabigatran, the agent-specific reversal agent is idarazumab, dialysis, or you can even give 4-factor prothrombin complex concentrate. And for apixaban, the agent-specific reversal agent is andexanet alpha, or we can even give 4-factor prothrombin complex concentrate. Thank you.
Yeah, thank you, Sindhu. For the next talk, we call Dr. Buddhan Rajaratnam, Senior Consultant and Head, Critical Care Medicine, Kauvery Vadapalani, to talk about problems and solutions beyond acute care and weaning home. So as surgeons, when we operate and the patient survives, that is the best thing for us. But this is actually the real thing, the Dunning-Kruger effect. When the patients have been in the hospital for more than some time, that's when the real stuff starts, because you tend to know what's happening. The patients are, attenders are slowly realizing what's happening. The difficult part is now. So very interesting topic.
Good afternoon all. Let me start with familiar neuro ICU story. A young man suffers traumatic brain injury following a road traffic accident. He undergoes neurosurgery successfully, comes to ICU intubated, sedated with low GCS, and after a few days of stabilization, we give trial extubation. His ICP and CPP are getting stabilized. So after a few days, we give trial extubation, and he fails, gets re-intubated, develops pneumonia, sepsis, septic shock, multi-organ failure, which is very common in neuro ICU. So after this, all this eventful stormy ICU course, finally he survives. After a few weeks, currently he undergoes a tracheostomy as well during the stormy course. Currently he is on tracheostomy, still ventilator dependent, extremely weak, confused, agitated. Now the family wants to know what to do, what is the next step, when we can take this patient home. It's a very common scenario. The patient, the acute phase is over. He is ready to go out of ICU, but still not ready to go home. So there are many patients, such patients are there because of a rising road traffic accident. This is road traffic accident data from our Tamil Nadu government. Unfortunately, India tops globally in road traffic accidents, and Tamil Nadu consistently tops among Indian states. So in 2024 alone, almost 19,000 patients lost their lives, and almost 13,000 patients were critically injured, most of them with traumatic brain injury. I'm talking about this number, 13,000. So this is a huge number. How to stabilize these patients, how to wean these patients from support and send them home, that is a huge challenge. So when we talk about weaning, we normally think it's only ventilator weaning, which is not true. Patients with a traumatic brain injury, they have to recover from multiple domains. They have to recover from multiple areas, like they need to breathe independently, and they need to recover from the muscle power, cognition recovery, and behavioral stability. More importantly, we need to make the family ready to take care of these patients at home. So to do that, to wean these patients from multiple domains, we need support. Unfortunately, in our country, that's very difficult to find support, post-acute care rehabilitation support. So there is a big gap. We have excellent acute care hospitals, but post-acute care rehabilitation centers, we are still struggling. In developing countries, we have in-hospital rehabilitation facility, long acute care homes. They have specific ventilator weaning centers, traumatic brain injury rehabilitation centers. But in our country, still under construction, the bridge is under construction. In this paper, WHO initiative, they have highlighted a global gap in neuro rehabilitation, specifically particularly in low and middle income countries like India. India-specific rehabilitation data is limited, but whatever available data consistently shows that we have deficiency in post-acute care rehabilitation. So naturally, the responsibility lies on us to bridge the gap, to take care of those patients and send them safely home. So how to do that? There are many challenges. The number one challenge is liberation from ventilatory support. This is the most important one, because once we wean these patients from ventilatory support, it's easier for us to take care at home. Even easier to do physical rehabilitation. So this is the most important step. But when we talk about weaning, we always think about lungs. But in traumatic brain injury, it's mainly neurological rather than pulmonary. So mainly neurological challenges, what are the challenges we face? They impaired consciousness, and they have a lot of secretions, and they may have bulbar dysfunction, they have poor airway reflexes, so they have increased chance of aspiration in this group of patients. And sometimes they may have abnormal respiratory drive because of injury to the respiratory centers. They have irregular breathing, and sometimes they have apnea as well. If these kind of patients, if they stay in ICU for a longer period of time, they develop a lot of complications which may further delay the weaning, like ventilator-associated pneumonia, deconditioning, extreme muscle weakness, diaphragm weakness, and a critical illness, polyneuropathy. So to overcome these weaning difficulties, first we need to decide, we need to have clear strategy regarding extubation. Many times it is not based on GCS. In this paper, Coplin and his colleagues, they showed even with low GCS, we can extubate these kind of patients, even if the airway reflexes are good, if the secretions are under control. So the cough strength, secretions burden, airway reflexes are more important than the GCS. We need to remember that. If needed, we can calculate the airway care score. So in addition to that, we need to keep the respiratory muscles active, like diaphragm and other muscles, to keep them in spontaneous mode of ventilation, decrease the sedation, and daily assess the readiness for extubation or weaning by doing spontaneous breathing trial, which is very important in weaning. In addition to that, we need to prevent the infection like ventilator-associated pneumonia by following the bundle, ventilation prevention bundle. Physiotherapy and mobilization all would help in the weaning. Every neuro ICU should have clear written extubation and weaning protocols, which would, based on guidance, which would decrease ventilation days, which would facilitate the earlier extubation. So when the prolonged ventilation is anticipated or unavoidable, we may consider early tracheostomy in selected group of patients. Available RCTs show that in early tracheostomy, the duration of mechanical ventilation can be decreased and length of ICU stay can be decreased. But there are no mortality benefits by doing early tracheostomy. Recent meta-analysis showed that there is a trend of increasing mortality among these early tracheostomy patients. So routinely doing early tracheostomy is not recommended. So when we think about weaning these patients from ventilation, we cannot have fixed ventilation targets. Every patient is different, they recover at different rates. For example, some patients, they may have good airway control and may be extubated early. Some patients may struggle and aspirate, getting re-intubated, and they undergo tracheostomy. And out of the group which undergoes tracheostomy, some of them may get decannulated in another few weeks. Other patients may continue to require ventilatory support. So in those patients, we may consider home ventilation like BiPAP support. So the bottom line is, while considering weaning, we need to have a flexible weaning targets. Next challenge is the functional recovery apart from the ventilator weaning. This is what happens when the patients are getting admitted prolonged in ICU. They become very weak, the muscles are lost. So the reasons are many. The number one is immobility. They are because of impaired consciousness, and they connected to ventilator and sedated. So they remain in bed for longer time without mobile. So that causes a muscle loss. As per the study by Puducherry et al., almost 20% of muscle loss is happening in the first week of ICU admission. So next is hypermetabolic state, catabolism, which also decreases the muscle mass. In traumatic brain injury is hypermetabolic state, and the basal energy expenditure is very high, almost 200%. So if you don't provide adequate nutrition, they are going to lose their muscles. And third factor is most of the ICU patients, prolonged ICU patients, they develop muscle weakness, ICU acquired weakness, which is very common. 1/3 to half of the patients, they develop the weakness. All these factors would contribute to delay in functional weaning. In addition to that, they have neuromotor complications like spasticity and joint stiffness and contractures. All this will affect the mobility and will affect the functional recovery. To address the deconditioning, we need to concentrate on two factors. One is nutrition and second is mobility. To address the nutrition, we need to start feeding early. Within 24 to 48 hours of admission, we need to start feeding. Start gradually up to start with 70% of the requirement and go up to 100%. Sometimes they may need 30 to 35 kilocalories per kg. And in addition to calories, we need to concentrate on protein as well. We need to give almost 2 grams per kg per day. And sometimes in patients with traumatic brain injury, we face difficulty in enteral feeding. They may have delayed gastric emptying, aspiration, vomiting, paralytic ileus. So we can use prokinetics, and sometimes the post-pyloric feeding may be required. Next to nutrition, mobility. That also should be done early, within 48 to 72 hours of admission. Maybe we can start with passive limb movements. Once their ICP and CPP are stabilized, we can consider on their little bit more awake, we can consider active limb movements. So, and many times we forget about one of the important muscles like diaphragm. So that also we have to give training like inspiratory muscle training, expiratory muscle training. Mobilization like this in phased manner would help them to become more independent. Cognitive problems are also common, delirium and memory and attention problems. Behavior problems also very common. We can make the family to stay with the patients, and sometimes drugs can be required. Importantly, the family members will be already stressed because of the long ICU stay, because of the trauma. So they'll be stressed with finance or emotional. So they need to learn, in addition to that, they need to learn about a lot of newer things, how to take care of these patients, tracheostomy. So we need to teach them, and the best way to teach them is to allow them to come inside the ward or rehabilitation center and monitor and observe what we are doing, how we are taking care of those patients. And maybe sometimes we can give clear written instructions regarding tracheostomy and feeding. This is newer developments, and so finally it's a teamwork. Successful recovery depends on coordination between ICU, rehabilitation, and family. Thank you.
Thank you, sir. I think the last slide is very important because, at least in TBI, this is what I believe, the surgeon's role, though important, is very limited.
Yes.
The most important deciding factors are how good is your ICU care and how good is your rehab. I think that decides the outcome.
Yes.
So I think moving on to the next, thank you, sir.
Thank you.
So moving on to the next topic, we would call Dr. G. Balamurli, Senior Consultant, Spine and Neurosurgery, Kauvery Hospital, Alvarpet, to talk about a road to recovery, rehab in TBI.
Thank you. Good afternoon, everyone. Thank Dr. Sridhar for the opportunity. After a day of exciting talks, we're going to finish the last talk with something not as exciting, but I'm going to try to make an attempt to keep you all awake. Because this is, as correctly said, is probably the most important part after you leave your hospital. With all the care that you have taken to get the patient alive, save him, do the surgery, and give your best efforts in the hospital, if the post-hospital care, which is rehabilitation, is not successful, then your outcomes are not going to be as great. So we all know that the incidence is high in India, and the hospital burden is about 30 million in India. This is slightly older data, but very reliable data. So, in severity, there's a significant number of patients who need post-rehabilitation. So after your acute phase, nearly 30% of them need rehabilitation because 70% probably would die. In the moderate category, again, you have nearly 50% of them who would require rehabilitation post-surgery, and the mild probably need more of home therapy and outpatient-based rehabilitation. So what is rehabilitation? It's an active process by which those disabled by injury or disease, any neurological problem, achieve a full recovery or a partial recovery. And if it is not possible, at least you optimize their physical, mental, and their social potential to integrate them into the society. So you make somebody who's got an injury from a not very useful member to somebody who's society useful in the society. The aims are to get them to a maximum independence, prevent complications throughout life, and minimize restriction and limitation of their problems, and also fit them into their environment, depending on what job they came from, what background they came from, what ability and disability they had, you try to make them as useful as possible. So there's some key components which I feel are important is education. I think the education should start from the medical community. I think the medical community is probably still doesn't, is not aware of the real potential of rehabilitation, and that's why, the number of referrals that come to rehabilitation are significantly low. And it's an active process. So it's a teamwork, which we will discuss. It's patient-centered. Every patient's requirement is different based on their severity, their problems, and their disabilities. And minimize disease impact, and then facilitate self-management and evaluation. So sometimes rehabilitation is a continuous process, not just in hospital, in rehab, and also at home and in the society. So there's so many disabilities that people with spinal cord injury, but the most common are the locomotor, physical mobility, psychiatric problems and cognitive problems, headache, epilepsy, giddiness. So these are all various aspects that you need to take care of, apart from spasticity, swallowing issues, speech, sensory impairment, various autonomic dysfunctions, respiratory problems, bladder bowel incontinence. So I would say that having been experienced for nearly 7-8 years in rehab, the stroke and brain injury patients are the most complicated patients to rehabilitate. And compared to spinal cord injuries, probably the easiest to be rehabilitated. So who requires persistent and stable neurological deficit, who are medically fit. So once they are ready to come out of ICU, ready to come out of hospital, that's when rehabilitation in a center starts. And you need active participation of the patient. There's no point in having a comatose patient in a rehabilitation unit for months together where you have no participation from the patient. You can only do a passive rehabilitation. So there's a big difference between the two, which I probably won't go into detail. But why do you need to do rehabilitation? The most important thing is here we are trying to prevent the secondary cascade of injury. The primary cascade, of course, we can't do, and that's because of brain plasticity. So what happens to the brain after an injury? So the brain's capacity in plasticity is to shape or mold by experience, the capacity to learn and remember, the ability to reorganize and recover. So it's because of this brain plasticity is why rehabilitation makes a huge difference. And this can be by two processes, either a neurogenesis, where new neurons migrate from the normal side to the abnormal injured part, or there's lots of synaptic firing that happens between and new connections are formed within the brain. And this is what is the basis and why rehabilitation is so essential. So the brain can change in many ways. It can change, internal structure can change, the neurons can reorganize, it can increase the number of synapses. And this rule of Hebb rule, where neurons that fire together, wire together, when cells are active together, synapse and strengthens, and the neurons synapse and activate repeatedly and preserve those who are not. So this is the reason why starting rehabilitation is very important. And this process is something that you relearn. Like for example, if you have somebody with an hemiplegia, if your one side of the limb is not used, if there is refiring on the other side, then these new cells form. So there's a term that's called as recovery and compensation. So in recovery, you restore neural tissue, you restore movement exactly as performed prior, and you restore activity exactly it was performed in the previously. So there's neural level, behavioral level, and various other levels. And compensation happens when there is recruitment. So recover, recruit, and train. So these are the common terms that are used in plasticity, and you see that in different phases. So in the first 3 to 6 months, you have a spontaneous recovery phase, where you actually have restoration phase, where you try to restore function, compensatory movements, cortical firing happens. Then the next 6 months to life, you have the recruitment and the retraining. So you keep repeatedly training the same function to the brain. And so the admission really for this is patient who is stable, patient who is ready for discharge, who can learn and engage. And what is done? Many things are done. So it is not like rehabilitation is just a few people get together and do something. It is a complete teamwork of medical care. A lot of comorbidities have to be managed. Some of the elderly patients are already comorbid. You have to treat other injuries. Patient may have a spinal cord injury, an orthopedic injury, pelvic trauma, various other chest injuries. Then you have to also deal with all the complications that happen: respiratory, spasticity, heterotrophic ossification, bed sores, cognitive problems, DVT prophylaxis, aspiration pneumonia, pain, repeated readmissions to hospital. So really the goal is to maximize their function, evaluate and train the sensory and motor function, speech, language, and swallowing function, evaluation, train cognitive and behavior, and train bladder and bowel. So it's a big teamwork, usually led by a rehab physician, but they are very far and seldom less available. You need good trained nurses in rehab, which again very difficult to find. The good things are that we have excellent physiotherapists, we have lots of them, occupational therapists, again minimum, speech therapists, psychologists, dietitian, vocational and trainer, behavioral therapist, social worker. So this is the whole team that you need in a multidisciplinary rehab center, and this is what is rehab. And you also need a lot of doctors to be involved, because these patients will have continuously problems: neurologist, neurosurgeon, urologist, plastic surgeon for bed sores, psychiatrist, respiratory physician, and so on. So you can usually do this in 3 phases: an acute phase, which starts immediately from ICU up to about 3 weeks, and then from 3 weeks to 3 months in a subacute phase, and then long term, which is 3 months and up to life. And there are various phases. in acute where you want to restore passive movements in the ICU, and then chest physiotherapy, bowel bladder, then you move on to preventing secondary complications, and then you want to get them muscle strengthening, mobility, and get them to as much as possible. There's a lot of debate as to when do you send them for rehab, because what I see commonly in my practice is patients are sent home, they go there, they get complications, and that's when they go and come for rehab. Seldom patients are referred directly from a neurosurgeon or a neurologist directly to a rehab center for many reasons. So the evidence says that early rehabilitation is ideal, and it should be done very early, and early as in ICU. That's to prevent complications, DVTs, pneumonias, ventilator-acquired infections, early tracheostomy, as was very beautifully mentioned by our previous speaker. So these are all very, very important things that we have to follow. And there's plenty of evidence after evidence that says early rehabilitation from as early as post-ICU care is when you start. And as you know, that coma stimulation and various other things, as was mentioned previously, starts from ICU. I'm not going to go into details of what is done in rehab, but there's 90% of what you see in India is a conventional rehab by physio, OT, speech therapist, and they know what they're doing. I'll just show a few advances which are there, that's available and it's coming up now. Bed sore is one of the commonest problems that we see. And now we have a lot of pressure mattresses and various other devices in bed, and technology has moved so far ahead in how you can automatically shift the patient, how it shows pressure points, and so these things are there. Respiratory complications, again, ventilator and all those things are available. Pain is an important problem. Once patients have recovery, they have pain. They have either musculoskeletal pain or visceral pain, or they have a neurogenic pain. So you have to deal with the pain differently. And there are so many things available, spinal stimulators, pumps. There are even morphine pumps and various other pumps available, apart from the baclofen for spasticity. We can do various surgical procedures, bowel irrigation systems, how to manage bowel, how to manage your bladder, how to manage spasticity through baclofen pumps, which is a very percutaneous small procedure, can be controlled from outside. We can do various procedures which we do for selective dorsal rhizotomy, DRES lesionings for pain management, especially in stroke patients. You see that more than in brain injury. The future is also coming up with a lot of devices and a lot of robotic technology. Virtual reality, wearable technology, many things that we have in our rehab center are gamified, because patients also get very bored within a few months of doing repetitive movements or repetitive therapies. Tele-rehab is something that is coming really up, because especially a country like India where rehab is not accessible, tele-rehab is going to be the future, and the government is spending huge amount of money and research resources on this. And the brain-computer interface, which is more for spinal cord injury, and there are 2 centers set up, one in Trivandrum by ISRO and one in Delhi, with which we are collaborating in some patients. So we have virtual reality, you have functional electrical stimulation devices which do repetitive movements coupled with stimulation. We have a lot of biofeedback from EMG related, which are in all the devices are now coming with functional electrical stimulation, freehand systems for both upper limb and lower limb, exoskeletals. We have 2 companies that manufacture exoskeletal in Chennai through IIT, and we have robotic. In India is now coming up with lots of robots, though most of the robots are international. And robot is there for everything, for upper limb, lower limb, for various other treatments, wheelchair and mobility devices, adaptive devices. People with brain injury, spinal cord injury can drive vehicles now. You can control them through various devices. If you don't have upper limb function also, you can, voice activated systems are there, air and blow activated systems are there. Many neural prostheses are available and coming up. The brain-computer interface, as I said, there are 2 trials going on in India on brain-computer interface. This is mainly for spinal cord injury. So neuromodulation is also slowly progressing. And if you look at what is the evidence, I'll just take 30 seconds. What is the evidence? Okay, is really rehab, a hype, or is it something that, is being driven by the market and industry? Definitely no. I'm just going to take one single study, which was a 2-city study. One was from Harvard Medical College and one is from NIMHANS and AIMS, data put together. And if you see this data, very interestingly, the number of patients who actually had rehabilitation were significantly high in about 200 patients in the Western country. And if you look at the outcomes and death, If you see all the reds, these are people who are alive, discharged home at 3 months, 6 months, 12 months, they die. So almost about 20% of our patients die because they don't have rehab. Whereas if you see, the rate is only 1% when patients are in rehab. So again, death, vegetative status, good recovery, significantly change. And there's a paradigm shift in how, the disease patterns are changing. And road traffic accident is the commonest cause. And if you look at the global DALI, which is the Disability Adjusted Life Index, if you see that we are better with AIDS and infectious disease and diabetes, we're better. But if you still look at road accidents, we are the #1. So we still are significantly very low. We live longer, but we live with more disability because we don't have rehabilitation. And there's a huge gap between what is needed and what is available. And even, WHO has looked at 2030 as a main theme, a recent meeting which was there, India is the capital for head injury. We're also the #1 population. So we should be having more rehabilitation centers than anybody in the world. So it's a teamwork of surgeon, therapists, and technology. There are lots of barriers why there's no rehabilitation. Human resources are not available. If you look at acute care, we have plenty of acute care in our country. If you want the neurosurgeon in Chennai, probably has 200 neurosurgeons. But if you have rehab specialists, there's probably about 5 or 10 of them. And that's because this is the partiality between doctors versus rehab physicians. So the government itself has got everything wrong about rehabilitation. And that's when I came back from the UK, I thought that, we should start something, and we've been having this for the last 8 years with Kauvery Hospital. We have about 100 physiotherapists and 100 therapists in 6 centers in 4 cities. And I think rehabilitation is something that we should really be aware of, because that's the best that we can do for our patients. Because we do a lot of effort in trying to make them, better in the hospital setup, but once they go out, I see a lot of patients come with significant complications, and of course money, financial, so many reasons why rehab is not yet popularized, but I think we need to push that as a community. Thank you.
Thank you, sir. So for want of time, we'll just take one question to each speaker. So one question which I have to Balamuli sir is, see, in the Western world, once the acute care is done, once they check out of the hospital and they check in,
Reason is there is not many rehab centers for our population. For a population of 10 million in Chennai, you need at least 3,000 to 4,000 beds, and we have less than probably 100 beds. And next is rehab specialists, even physiotherapists. I interviewed probably every therapist who comes into Hamsa, and 99% of them have never been in a rehab setup. So we don't have rehab people as well. So many reasons why rehab is not there.
Hello, mic testing. Hello, don't go to sleep. Mics. We have been focusing on rehab, and it is very, very important. And it's not only for the previously injured. That's the point I want to make here. It's also for the minor head injuries, for the concussions, that you can get a lot of cognitive issues, and cognitive rehabilitation is something which also needs to be focused on for things to become better in our society. So while what Dr. Malamurli said, it's important. There's a big rehab team from Radial Road sitting there. It is very important, but we often forget the minor head injuries where things are brushed under the carpet. CT scan normal, you are normal, don't come back to me, you've got problems. You're okay, yeah, but they are not okay. So I think that is something also which needs to be focused. Thank you.
I think very important point, sir. We see a lot of patients in our behavior and cognitive therapy specialists for people with minor head injuries, which they say happened 1 year ago, 6 months ago, and they've never seen anybody after that, and they keep coming back with so many cognitive issues, sleep disturbance, memory issues, and all that. Thank you so much.
thank you. We conclude this session.
Thank you, sir. Coming to the last session, I call upon the panelist, Dr. Arsha Narayanamurthy, Senior Consultant Neurosurgery, Kauvery Hospital, Bangalore. Dr. G. Balamurli, Senior Consultant Spine Neurosurgery, Kauvery Hospital, Alvarpet. Dr. Madhusudan, Consultant Brain Spine Surgery, Kauvery Hospital. Dr. Emmanuel Das, Senior Consultant Neurosurgery, Kauvery Hospital, Radial Road. And Dr. Ponnaya sir, with Neuroanesthesia, Critical Care, Kauvery Hospital.
Thank you. Welcome to our esteemed panelists. So, like we are discussing from the morning, Dr. Emmanuel, you have to come here. Moderator. So, this is a very interesting case. A 65-year-old male, RTA, severe TBI. He was resuscitated in elsewhere and he was transferred to our center. Within 6 hours, we received the patient. Of course, intubated, ventilated, he was hemodynamically normal. He had medical history, diabetes, hypertension, ischemic heart disease. Twice, he had a coronary stent, and he was on dual antiplatelet therapy. So, airway secured, C-spine cleared, hemodynamics normal, and later in the course of the ICU, he was needing vasopressor support, probably related to the sedation. There was no ongoing hemorrhage. So his best GCS in ICU was E1 VT M5, and pupils were bilateral equal reacting, temperature 35.6. Secondary survey, there was nothing very significant. There was a left deformity, and he underwent a pan CT, and there's only an ulnar fracture. And this is the CT scan. So we hear the lecture about antiplatelets influencing the management of TBI. And studies after studies show that patients with antiplatelets have poor outcome when they have traumatic brain injury. But there are also few papers and studies which show that antiplatelets as such does not increase the hematoma expansion. When you compare with anticoagulants like warfarin, acetylene, Novax, but antiplatelets, especially single antiplatelets, do not influence the risk of hemorrhagic expansion. So I'll open up this for discussion. Thus, patient having an antiplatelet, should we even stop it? If it doesn't expand the hematoma, should even stop antiplatelets? Even if you stop, the effect is going to be there for another, at least maximum effect 3-4 days. Then for all the effect to go, it will take 7 days. But anyway, even if you're stopping antiplatelets, it's not going to do anything to the patient. Are we going to transfuse platelets because you fear that the hematoma can expand? So these are all the questions which we need to answer, and I'll open up for discussion. I'll first go to Madhu. And
So you yourself said not with single antiplatelets, what with dual antiplatelets? So obviously there is a risk of hematoma expansion is there. And what about the studies with ticagrelor? So we have studies with clopidogrel and niclosporin. What about the studies with ticagrelor? Nowadays we see a lot of bleeding per se complications with ticagrelor. So obviously hematoma expansion is possible for up to 24 hours. It's maximum up to 6 hours. This patient presented within the only after 6 hours. Still there is a risk.
Before you go, we'll just clarify. Is this a devastating injury?
Obviously.
Sir?
It's a severe head injury and significant intracranial pressure is going to be there in this patient. And obviously on 2 anticoagulants.
Antiplatelets.
Antiplatelets, yeah. So yes, I probably would want to stop this.
Transfuse platelets?
Unless if I'm not going to do surgery, I probably wouldn't transfuse.
That's what exactly the guidelines also align with. So when we go for procedure, you give transfusion. Otherwise, there's no need for transfusion.
Transfusion is not going to prevent your expansion, clot expansion.
So
what is the role of invasive ICP probes.
Does this patient qualify for ICP monitoring if you have a facility where you practice invasive ICP monitoring regularly? So,
Taking into the fact that the patient is on dual antiplatelets.
I definitely think there is a role of intracranial pressure monitoring, yes, mainly because you got bilateral mass occupying lesions, and in case you need to operate, you need to know, potentially if there is expansion on one side, where might that be happening, when might it happen. The ICP monitoring gives you, I think, more in the way of timing. You can say as much as you want.
With antiplatelets on board, are you comfortable putting the probe?
I think that would be counted as a surgical procedure that would need antiplatelets to be dealt with, i.e. stop and then platelet transfusion and then proceed.
Or shall we go with a non-invasive ICP monitoring rather not to risk the patient?
My practice preference would be invasive monitoring. I would always prefer invasive ICP probes. And so I would, as my colleague says, the platelet transfusion is not going to reverse the antiplatelets. It'll give you some functioning platelets at the time of your operation, so you don't cause extra problems. That is about all. But yeah, I would have an invasive ICP monitor if I can.
Same patient. The patient is not on antiplatelet, but he is on anticoagulant. Will that change your decision, or you still stick on to your decision? Will you reverse it?
I would want to reverse anticoagulation, absolutely. For starters, anticoagulants have a higher risk of clot expansion whenever they're in the system. The advantage of the NOACs would be that their half-life is much shorter than the antiplatelets. So in a way, if you're pushed, you could wait 24 to 48 hours. It would be out of the system if you just stopped it. But then with the clots this size, I would be very uncomfortable doing that. And I would definitely want some invasive monitoring, in which case, I think the treatment has to be tailored, hasn't it?
If you do an antiplatelet study before proceeding for a surgical intervention?
Please repeat that. I didn't get it.
Platelet mapping studies. Take platelet mapping or some study to assess the platelet function.
I mean, if someone's been on antiplatelets for a long time, in a trauma situation, I'm not sure that I would waste time trying to study platelet function and things like that. I would make a decision that...
But it's not an emergency procedure, that ICP probe insertion is not an emergency.
I would consider it an emergency one with these mass lesions, the size of this, hematomas. I would consider it urgent.
Just add a small twist to that. If the patient has not undergone, see, first of all, this patient has no business to be in dual antiplatelet for so long. All right, the surgery was done, the stent was done long back, but still the practice of the cardiologist is more than 1 year also. The patient will be on dual antiplatelet, and none of the physician even stops that. Even if the patient come to hospital admission, nobody even stops that. It just continues. Okay, so in case if this patient has presented within 2 weeks of stenting, where if you want to stop it, it's going to risk a major coronary syndrome. So what would you do? Would you continue the antiplatelets in the benefit and the risk ratio, or would you still want to follow the same approach? So this
we have been discussing since morning. See, we have discussed that ICP monitoring doesn't add to the overall outcomes. That's what the recent guideline says. And whenever you have an option of going for ICP monitoring, non-invasive monitoring.
No guideline says that it doesn't involve the overall outcome, nothing like that. When you have ICP, you follow the ICP-based protocol. That's it. Nobody says that. Nobody says that it is a wonder, it is a magic thing which can.
But no study says it's a must.
No study will ever say that.
So in that case, when there is an option for non-invasive monitoring, in these settings, we can better go for non-invasive.
Okay, point taken. But for my next question, the patient has been stented within 2 weeks, and the cardiologist is adamant that he is a VIP. I have to protect because the stent is going to get thrombus. If you want to stop the antiplatelets, then how do you approach these scenarios?
Both ways, there's a high risk of death or high risk of complication. So we have to now judge which is the right way to do. At that point, And obviously, it's a discussion with the cardiologist that you have to have. And if he says that definitely you can't
He is
stop,
saying that you cannot stop.
then you just go for non-invasive monitoring and then wait and watch what happens.
No,
with the
will you
ICP
continue the antiplatelets?
Probably, yes.
At point of time, we can do the TEG and platelet activity and decide on whether it is really working or not.
No, it is working for them. We have done the platelet mapping. So, so that's a question. So, there are situations which we can be in such a scenario, but if it is anticoagulation, there's no, heavy no. But antiplatelets, maybe within 1 month we can consider, because we should also protect the heart, and probably we can go for even yearly decompressive craniectomy. Just continue the platelets and put the bone out.
Stop ticagrelor, sir. I think we can consult with the cardiologist, stop ticagrelor and continue with single antiplatelets. Single antiplatelets, we can stop ticagrelor.
But that is not enough to stop acute coronary stent thrombosis. They need dual antiplatelet. Single antiplatelet is not enough. So what I am suggesting is that can you go directly for a decompressive craniectomy? Even if the hematoma expands, it will be handled.
We have faced this situation of a patient who's had a stent about 2-3 weeks back and then who comes with a dual antiplatelets. What our cardiologist says is that for a very short period of time, until the neurosurgical crisis is over, you can tide them over with low molecular weight heparin instead of using any antiplatelet drugs. That's one possible way of looking at it.
But that is not a guideline aligned practice, sir, because when it comes to stent thrombosis, antiplatelet is completely different from anticoagulation. Maybe for our sake we can give, but no, patient is already on antiplatelet therapy. The effect is not going to go till 7 days. And in addition to that, you are adding one anticoagulation that's going to cause more harm to this patient in this scenario. I'm saying so that may be more harmful for the patient, and that's never been recommended by any guidelines. So all the guidelines and all the
another
protocols.
way of approaching this patient is directly you can go for a decompression.
Yeah, that's what I was asking.
And then
you are keeping quiet.
you can continue the antiplatelets.
Okay.
Very comfortably.
So Raghu would like to go directly for a decompressive craniectomy because anyway he is expecting an expansion. So why would you take the patient once it deteriorates? Rather you go for a prophylactic decompressive craniectomy. Maybe with respect to setup also he is considering all the factors where he don't have a very good coverage.
In this setup, whether we are going to go on the right or left, because he has got a bilateral bleed. So you are exposing the patient to major morbidity, no?
Why are you doing a decompression? To save life. Full stop. Morbidity is the next step if the patient survives. That's all. The surgery per se, I don't think you can call it a morbid procedure. Because at the end of the day, the question is, therefore, are you going to do a bilateral decompressive craniotomy or a frontotemporal, can you put the scan? Bifrontotemporal
Bifrontal craniotomy will not cover that posterior temporal.
So you'll have to do
you have to go bilateral procedure, sir. Probably the bone flap can go small and then you could do a cystonostomy.
No. There is no evidence as of today, except for the person who has been talking about cystonostomy a lot, that cystonostomy can replace a decompression.
No, sir, it's not going to replace, but it
So
acts as
doing a
adjunct.
small decompression is worse than doing no decompression because the brain will herniate.
So you have a good neuro-intensive care cover. They say that the ICP is okay, just come on, you wait. So are you comfortable with that or still want to go for a decompressive craniectomy?
If you look at this scan, I would prefer to wait with maximal medical management. Why? Cisterns are reasonably open. Look at the cortical sulci gyri. Look at the first scan on the left. You can see the brainstem nice and round. I would still think if I can pull it off, I will pull it off.
The left
I
side,
go with you, sir.
the basal system, I mean, that the perimesencephalic system, left side is widened, sir. Right side is compressed. It's impending herniation is there.
It is only impending. In a scenario like this, if we are talking about the patient has just come, say maybe less than around 12 hours, 6 hours, 12 hours.
6 hours.
So if I can give the maximal medical management benefit to the patient and try to pull him out, I mean, that would be my thing.
The age of the patient
for me
is
still definitely wait. And
age of the patient is around 65. It's an atrophic brain.
So definitely
it
wait.
Can accommodate.
Definitely
so
wait.
Still there is a lot of possibility for a conservative management.
So definitely wait. No surgery and definitely no cystinostomy. With dual antiplatelets going in, that would be like disaster.
Actually, if you wait for 24 hours, the patient will herniate, sir.
With the patient on dual antiplatelet, it is worthwhile waiting because during surgery, after surgery, we have seen patients on platelet and doing after surgery, next day you do the scan, the hematoma is larger, it has bled everywhere, subcutaneous hematoma is so much. I think if the patient is, pupils are equal, the brainstem, the cistern around the brainstem is good, worth waiting, pushing the maximum medical management, because we have seen even with a single platelet, decompressive craniotomy, and next day taking the scan, the hematoma will be bigger than this. And this patient having ticagrelor along with ecosprin, I feel it's worth waiting.
So I would add that we can wait, but along with aggressive non-invasive monitoring and seeing the patient throughout the night. So that is what we have decided, and that is what was done for the patient. So there's no role for platelet transfusion in this case. Forget about other interventions to do the patient. So this is a kind of non-invasive monitoring which we do regularly in our ICU. So the diastolic flow which I was talking about is adequate. So that's what I said. Your neurointensivist saying he is fine. And this is the TEG platelet mapping with Dr. Emmanuel was asking again and again. It has complete antiplatelet activity. So both, every platelet is inhibited thoroughly. And in the midnight, because we have got a round-the-clock neuro-intensive care coverage, even the fellows can do TCDs. If you can see, the waveform has changed. Okay, it shows that the medical management is not working. Patient is on prophylactic and therapeutic medical management, which is not working. Transiently, it was working, but again, the diastolic velocity is going down, the ICP is going up, despite the atropic brain. If you can see the difference before and after, the diastolic velocity is going down. This is one way of judging the intracranial pressure non-invasively. So immediately, when there is a change, we have to repeat the CT scan. So we repeated the CT scan. Raghu, assume that you got a good neuro-intensive care support, okay? You try to...
Sir, this is what happens, sir. If you wait for 6 hours, the hematoma will enlarge. Straight away go for surgery, remove the bone flap out, probably...
You can see some spaces. Are you still happy about the cisterns which was opened and fine?
Do you think that removing the bone flap on both
the
sides
effects of the hematoma, sir. The hematoma, blood products are more toxic, sir. Forget about the mass effect. That hematoma will trigger seizure, raise ICT, all other secondary complications will happen.
Jyoti, sir.
No. I've got one question for Dr. Raghu. So you want to not only do a DC, you want to go in and remove the clot as well?
Yes, sir.
Full antiplatelet activity.
Sir, yes. Sir, God is not, sometimes God is not so cruel, sir. He will definitely help us during the surgery. I strongly believe in that, sir.
Antiplatelets are cruel. Remember that. Okay. So I appreciate your daringness, but I would not endorse it though. So
still you do manage conservatively.
Still you can manage conservatively good. Any difference in opinion, sir? Jyoti, sir?
At this point, you will
still we can manage conservatively. So suppose the patient...
The most important point, sir, other experience. So still not touching, other experience, because we've burnt enough fingers Still not touch.
So if the patient is not on antiplatelet, what would you say?
So still the CT also shows the sulci area in the higher cuts.
Yeah.
The sulci area is all well made
Yes,
out.
yes,
Your ICP
yes.
monitoring may be something different.
Sir, will you put a invasive IC probe at
No,
this
not
point?
now, not necessary. Go with non-invasive.
So there is a ICP burden as evidenced by the TCD. Of course, there is an ICP burden limiting the cerebral blood flow, but still there is no herniation. That's what you mean to say. Still there are space in the brain. Still we can wait, considering the patient on dual antiplatelet. Suppose if the patient is not on dual antiplatelet, would you still wait or would you go and do a surgery?
I think you do the same principle because you're not treating the scan, you're treating the patient.
Correct. Yeah.
And if you have so much of space and you're only doing a non-invasive monitoring as well, so it's not an invasive monitoring. So I think still you can wait, given the age and the two antiplatelets.
So Raghu, everybody decided to wait. So forget about touching the clot.
You asked if the patient was not on dual antiplatelet, what would you do? If the patient was not on dual antiplatelet, the right temporal lobe has expanded, I would probably go in on the right side. Why? Because middle of the night, if one pupil dilates, I don't want to go in the middle of the night with pressure on staff, pressure on everybody and do it.
So if the patient is not on dual antiplatelets, right side you want to do a formal full craniotomy or you just do a mini craniotomy to evacuate the hematoma?
I don't like this word mini craniotomy in trauma, acute subdurals, meningiomas and things like that. I would prefer to do a proper job, remove that entire clot and get out.
Sir, there is no midline shift because the bleed is on both sides. Both sides, sir. How can it is not, it is symmetrical ICPs there, raised ICTs there.
That is why we don't have consensus on TBI management. Okay, all right. Okay, so yeah, this patient was closely monitored and just a transient improvement was there with aggressive medical management. We just push 3% NS, everything. And the scan was again repeated in the morning. And is this a concern, the brainstem getting, but like you said, there is a pressure from both the sides. We may not get a midline shift, but sometimes patient can herniate. And is this a concern, or we'll just keep up with our idea of maximal medical management?
So I'll tell you the concerns. I mean, people need to know why we have circled that. What we have found is that when the round brainstem starts becoming a little elongated, it's not a good sign. Like Raghu says, pressure from both sides. Basically, that's it. But basically, when you look at the scan, it is getting a little elongated. Actually, one cut above shows it a little better. So that is what is troubling in this scan.
Jyoti sir. So you would like to take the patient or?
GCS has improved from E1 to E2.
Sir, refer them to radial roads.
You do on which side, sir? Evacuate the clot?
Second day, sir. Not even 48 hours. No, we didn't transfuse platelets. We don't transfuse now. When there is no surgery, we don't transfuse. So we are concerned. So the point is everybody treating the patients is concerned. And if the patient is yours also will be concerned. And there is a dilemma whether to go for surgery, whether it will be doing benefit for the patient or doing more harm for the patient, or restrict. But nothing is wrong or right. And now in this patient, we reversed the patient, platelet transfusion was given, and what is this? Yeah, so this patient was taken up for decompressive craniectomy. So intraoperatively, as we assessed, the brain was bulging and there was not much ooze as we expect in a dual antiplatelet therapy. Despite the platelet count, platelet activity being maximal, platelet transfusion was given, and this is the post-operative scan. And if you can see the diastolic flow, very good. Even if you put an ICP monitor, despite decompressive craniectomy, it's all okay, and the patient looks stable. And Raghu, the hematoma is not taken out, it's not expanded further also. Are you okay with this? Or?
No, sir, the hematoma should be out, sir.
Okay.
The hemoglobin, the iron degradation products, they do more harm to the brain, sir. First is ICP, second is the blood products, sir.
I completely agree with you. But the problem is what Jyoti has been saying again and again and again. When you want to do good, it should not end up in a disaster. So that is why we did not touch the cloth. But I'm telling you the decision-making thought process.
That decision.
So what you are saying is very, very correct. Satish and Emmanuel will tell you, I am somebody who is aggressive when it comes to removing hemorrhages.
Usually Sridhar sir tells us to remove the clot first before doing a big
no, actually, the very simple logic, sir. Right from when you start the skin, we know how it's going to be inside. So sometimes if they suppose if you
No, I'm very sorry. That is something which can be, 1 minute. That is something which can be very, very misleading. Skin lo onnume avade, surgery mudikara varku onnu avade. The next day scan will show you the action of the antiplatelet.
Sir, yes, sir. Anyhow, we are going to remove the blood, bone flaps, sir. So suppose even if the ICH is going to be recurrent, it's not going to be a big deal. But
there are similar patients in whom we have done just the decompressive craniectomy, not touched the hematoma. The hematoma has grown the next day. So even without touching, it grows. With touching, definitely it does happen.
Our one experience was during ECMO time, during COVID times, we had a lot of patients on ECMO who had these kind of bleeds. And they had 100% mortality. You operate, didn't operate, it didn't make any difference. No matter whatever transfusions we did, the best stance, I think that was the biggest learning experience for us. Because all those things worked. Like what Sal told, you just do a decompression, it will expand. Open the dura, it can expand. Touch, it will expand. So all this has happened. So in this case, I think we have got out, it was a great surgery, we have got out comfortably. But touching the hematoma, I think definitely I wouldn't do it.
It seems the panelist is non-agreement to what you have done, sir.
No, not like that.
No, not like that. Yeah, okay, agree.
Sometimes we remove the clot, we do a repeat CT scan, and we say, oh, have I removed the clot or not? If you are lucky, it will be like, otherwise it will be much bigger than that, much bigger than that. In that case, we are lucky that we didn't get an SDH. So I think
so you
we need not touch the clot.
You would have still done the same thing, or you would not have touched the patient?
Done the same thing if he is on antiplatelets.
Bala, sir.
I think what you want to achieve is a decompression and allow the brain to expand. And I think we've achieved that. So I think it's unnecessary, risky to go inside and try to remove the clot. You may be lucky or you may not be lucky. So I think there's no need for that.
So these are the follow-up scans which we got for this patient. So ultimately the patient didn't have a better outcome, not immediately, but during the course of the ICU stay, maybe he was shifted out of the ICU, tracheostomy.
So you can see now the sequences of not removing the clots. She has developed hydrocephalus.
What about the clot on the opposite side? Still you would have developed hydrocephalus, no? You can't be sure if I remove the clot inside the parenchyma, I would have prevented hydrocephalus because he has got a thick SAH on the opposite side also. So you can't be very sure, no?
The whole theme of the day is to mitigate the effects of the secondary brain injury, sir.
No,
we
have
just
you,
tackled
are you sure if you are removing the intraparenchymal hematoma, this patient is not going to develop a hydrocephalus?
No, just
because he has got a thick clot everywhere else also.
At least you have minimized the morbidity, sir. You would have avoided one more surgery.
See, I have seen two types of surgeons. Some say that don't chase the clot. Okay, just do the minimal thing, decompress. Your aim is to just relieve the intracranial pressure, come out. And keep the surgery time as minimal as possible. More surgery, more intervention, more you damage the tissue, the factors, coagulopathy, postoperative issues, all those things happens. See, previously people are doing lobectomies for almost all the cases. Now selectively we do if the brain is so tight and things like that. So I can see clearly that there are two ways surgeons think about it. So the panelists have a point and Raghu also have a point.
If we would have removed the clot, we would have reduced the ventilator days, we should have ICU stay, we should have avoided all those factors. Ultimately, outcomes will be much better.
Okay, so that is not the common agreement among everybody.
Just 2 points. First, that's not an ordinary clot, it's a burst temporal lobe. you chase after that. I mean, I don't know about your experience, but my experience is horrible. Burst temporal lobes are terrible. You wade into them, they bleed like anything. Okay, there is never any end, so it ends badly. The second thing is you can't get rid of every single red blood cell, and even a few are enough to cause post-traumatic hydrocephalus. You will not stop the gumming up of the arachnoid granulation simply by chasing after the clot. And as my colleague says, you will never be able to take out all of the blood in the brain. That's impossible.
So I think the only way that we could have reduced the ICU stay and the cost is the patient would have died. So everything would have been reduced. Otherwise, I don't think removing the clot would have reduced it.
Is there anybody in the hall who's saying that this patient, we should not have done a decompressive craniectomy, just patient should have been managed with medical management for another 48 hours, still it would have been fine? I think people are frightened of you, sir. Sir, is the point.
Nothing we do or not do in this patient is going to be fine for the patient anyway.
Exactly.
The outcome was going to be bad no matter
anyway.
what.
Exactly, that's what I was about to say. Outcome is going to be bad anyway. So if you want to get a bad name, you can operate. And if you get a good name, then God is with you.
I think what was missed in this story, which till now, there's still more to come, abhi picture baki hai, is that we were speaking continuously to the patient's wife and son. The patient's wife was a senior doctor. And every 6 hours, every scan, we were speaking to her as to what the options were and what could or could not happen if we took a step or did not take a step. I think that is a point which I think we have not spoken here, and which is a very important point when we are discussing a patient like this.
The ultimate outcome of the patient. So finally, the patient developed a rebleeding later on in the course of illness, after 1 month or 1.5 months.
No, that after improving, he came up to E2, E3, M5. So he improved. We were actually from our step-down ICU looking at shifting him with a home care nurse to the ward. He was slowly trying to communicate and all that. And then this happened.
We restarted the antiplatelets, sir.
Yes, we did.
Single antiplatelet was started.
Single antiplatelet. Ticagrelor?
No, aspirin.
Low dose aspirin.
Yeah, after that this happened.
But I don't think this is because of aspirin. You can blame aspirin because the patient was on aspirin, but this is what happened. So, but see, if you don't start the aspirin and the stent would have blocked, you would say that you didn't stop. Well, there's no indication that you should stop the aspirin. So this is a thing. So this all we. So this is coming to the point which you raise. Young boy, two-wheeler, unconscious on the road, nearby hospital, intubated, M2, not reacting pupils, but cough reflex present, breathing effort is present. So how do you approach it? Should you do a scan for this patient or just prognosticate, send away from the hospital? What would you do in UK, sir? Because the Indian scenario is different. I have heard such stories that they won't even admit such patient in level 1 trauma center. So is that true?
Well, they would get a CT scan. They would definitely get a CT scan, yeah. It's a 16-year-old.
Yeah.
You don't pull out until you.
That's a very important point what you have brought. Adults are completely different from pediatrics and adolescents, which will be showing in the same case. Dr. Balamuri is aware of that. But still, Madhu, you have a different.
Do a CT, sir.
Definitely do a CT, but you know that the prognosis will be bad even with the scenario. So this is the CT scan. I'm sorry for the so it's very devastating and infarct setting in. So what would you do next? Prognostication, or we want to do?
Talk to the family.
Where is Raghu?
Sir,
Talk
there
to
is
the
no
family.
argument, sir.
Tell
We'll
them.
go for
Talk to the family, tell them these are the options. We can do a decompression. The patient may not survive.
No,
but without surgery, it's very likely,
But
unlikely to
family
survive.
is asking you to take a decision. What would be your suggestions?
Would operate.
What do you
I would operate.
Operate, sir.
Just because of 16 years.
I would take it out as well.
You
yeah.
have to do surgery, sir. There's no.
I would take it out, yeah.
So again, a similar patient, but he has no cough reflex. He's M1. What would you do this case, sir?
Definitely no, sir.
So if I would add a similar point, this is of the first patient where we have got a cerebrovascular arrest. So in that scenario, would you still operate? Because once you operate, you're going to remove the bone flap. The brain is going to bulge like anything. You may not even be able to close it. The hemodynamics will crash, collapse. Should we even operate this patient? Yes, yes.
Again, it's a matter of, talking to the family and warning them that he might die on table. But
I feel that most of the time we just give the ball to the patient's family core. Means why can't we as a doctor guide the family that, with this signature, nobody in the world have survived after traumatic brain injury. Not even a single case from the time the transcranial Doppler was invented. I'll just come to that, sir. I'm talking about adults, adolescents, okay? Nobody has even survived. So why can't we guide a family? Because it's very clear that in practice of medicine, when you clearly know that your therapy is not going to benefit the patient, why would you even offer that as a choice?
Will I ask you one thing, Dr. Panayan?
Yes, sir.
I will just reverse your question. If it was your son, what would you do?
I would not.
You would not operate?
No.
I would definitely operate. Do whatever is in your
Sir
capacity.
said we'll always give the option to the family, sir. Because in this era of medico-legal cases, if someone says he might have got a 1% chance, the age of the patient, what is more important is the age of the patient.
So what I am saying is that your recommendation will be to operate, or your recommendation
would
will be
be to
choices.
operate, saying that all the possibilities, that what are all possible. That he may die on table, he may die after 1 or 2 days, or he may end up in a vegetative state, whatever that is possible. Explain to the attenders deeply, and if they give consent for surgery, go for surgery, mainly considering the age of the patient. He is 16 years old.
So this totally go against what the Supreme Court has ruled now. Okay, a young boy who was living, fulfilling his life, being vegetative for past 13 years, they agreed for him to live peacefully. So this goes entirely against what you are saying.
That is a completely different judgment. That's got nothing to do with this case. This is in the acute phase. What will you do? That's the question here.
But
so
we are talking about devastating injury,
no.
and there is no. I will tell the practical.
1 minute. You are saying devastating. I might say he's still got a cough reflex, and M2. And if you look at, there is still gray-white differentiation if you look at it in this thing. The only thing is there cerebrovascular arrest on the TCD. That's the only problem situation.
No, that is not the only thing, sir. It is
a
combined thing of radiology and this. And clinical picture.
So the only thing, pupillary reflex not there. If you go back to the scan, I didn't see whether the brainstem is hypodense.
It does appear slightly hypodense. But the perspective surely is, if you put it into the crash mortality predictor, without an operation, his mortality is probably about 95%. I mean, going off the top of my head. If you do operate, it's probably about 85%. That is the decision to be made, whether you would like an 85% mortality or a 95% mortality. I'm not giving the decision entirely over to the family. I'm sharing the burden with them. I'm sitting there telling them, we are stuck between the devil and the deep blue sea. What are you going to do?
So there is a high likelihood that this boy will not make it. I think that must be clearly put. I don't think the decision is, shall I operate or shall I not operate? I think the decision is, no matter what we do, it is very, very unlikely that the boy will survive.
So I'll just go into the other end of the spectrum, which people are talking about it, which is the neurosciences community. You should know, they are accusing the neurosciences, neurosurgeons, that there are potential donors, but because of futile neurosurgical interventions, neuro interventions, those patients become uneligible for donors.
I'm very
so
sorry.
That is a terrible perspective.
If
That's
somebody is
awful.
talking like
That's
that,
awful.
If somebody is talking like that,
My patients are not donors when they come in.
Yeah.
Okay, they are
I'm
lives.
just bringing it to your notice
No,
that
no.
these kind of...
Thank
Ponnaya,
you,
1
that's
minute.
useful, but it's a terrible perspective.
If anybody is talking like that, they are a bunch of unethical transplant doctors. Unethical transplant doctors.
See, to an extent, I would say, superior authority who decides on these things, he sent a circular from his office saying that you have to identify potential donors on road. Can you believe that? So that was an official circular from his office. So that is
Why would surgery make him not a donor?
No,
I don't
because
think
he
so.
may
You can
crash
still be a
and
donor
die.
if you want.
No, he may crash.
Sir, sir, I think you could have asked the personal experience of RK sir, Jyoti
See,
sir,
I think
and
that is
Sridhar
the
sir.
most important point, because in this case,
everyone might have had an experience where we have believed this patient is not going to survive, and the patient has survived. And if it's your kid, definitely we would have given a chance.
No, that is fine. Your belief is something different.
No, but that is also
no, sir. We are
no
saying
one says you don't
no,
operate on this.
The TCD is of no use in this case. I'll tell you why. All of us have operated enough cases here, but just looking at the scan, we'll know the outcome is. TCD is just saying cerebral circulatory arrest. And the decision in spite of the TCD or with the TCD was to operate. And at least with all the seniors here, they have seen enough patients where they've all been proved wrong, they would have survived.
See, the problem in head injury
They've
is,
survived.
the problem is what
There's no
you-
100% thing that like...
No, just don't get emotional. Just
No,
relax.
emotion.
See, the problem in head injury is what you define as an outcome. That's the whole question. So for you, what an outcome might not be an outcome for some other family. At least we need to be open with the patient family, clearly tell them this is what going to be, not immediately, but at the end of 3 months,
talk to the
if
family.
you survive, at the end of 6 months, what is going to be, and they have to be ready for that. They should not be approaching,
Nobody would argue with that.
My
Nobody would
experience
argue
with
with that.
families is that if you offer them surgery, if they can afford it, they'll definitely take it. Irrespective of you telling them that there is a likelihood of 90% mortality.
die on table also,
they'll
they will take it.
They'll
Yeah.
say, do whatever that's possible. We know the situation is bad, but do it. That's what they'll say.
Just to
that is running through. That's always changed.
Fact of life you have to live with.
This is where the cultural context comes into play. If this was the UK, half of the patient's family would say no. They would not want to, a 16-year-old, he was full of life, he would not want to carry on MRS 4 or 5. So you do have a cultural context to it. But here, I think RK sir is absolutely right. If you offer them the option and say, right, mortality is high, but still, if we operate, there is half a chance, they will take it.
All right, so...
Okay, now
I
what
think-
happened to that 16-year-old boy?
No, he didn't make it.
He didn't make it.
But what is very interesting for us, me to notice is, there are enough seniors here, but none of them were very sure I will not operate. I mean, none of them were convinced, no, I will not operate. They said we will operate. So they've all seen enough patients, they all know these patients are going to die, but still they wanted to offer surgery. Because no one would want to play the God complex. I think the God complex is something which you should get over.
The way you put it, we are not going to offer surgery in the way saying we are offering surgery, patient will do well.
No, sir, I'll tell you what happens. I've seen institutions where these kind of scans, they have documented on paper, no surgery deferred because of devastating brain injury. I've seen that. And one of the patients has
So
come to us.
You think that that is absolutely wrong or unethical?
Absolutely wrong.
Is it unethical?
No, it is God complex. It is because you're thinking you're working in an institution, you think spending one bed for this patient is waste.
Yes.
You are not there to decide that. You are
No,
not
that's
God.
what my first question was, would your hospital even admit this patient?
Exactly. There are certain hospitals, certain so-called big institutions who will send the patient away because they don't want to spend a bed on that patient. And we have got received patients whom we have operated after they have come here, and they have done reasonably well. So the question is, I think when you have a patient like this, you should talk to the family and tell them, this is bad, but this is what we can do. It can still be bad. I think
So I think,
let's
putting
get on
in
to-
nutshell what he spoke, it's about the cultural aspect. Okay, so whatever about the economical aspect and social aspect, everything comes into play. I think we need to, at the end of the day, accept it. And we draw a line and we follow the line. So there's nothing wrong or right in this. I think it's a cultural and social aspect that we all know that this patient is going to have poor outcome. In whatever terms or whatever scale you measure, it's mortality.
That's what I said. That would have
or
been in spite of the
morbidity.
TCD. We know that.
Yeah. So this is on a positive note, a 1 year, 6-month-old child fell from balcony. loss of consciousness was present, and the parents were saying apparently the child was crying on the way to the hospital. CT was done and referred here, and this is the initial CT. Raghu is here, no? Yeah, okay. Raghu, we're not doing any surgery now. Okay. So even before assessing the GCS, the patient has got seizures, poor breathing efforts, gasping. So immediately anti-epileptics were given because the airway was threatened, airway was secured. Pupils are bilateral, 3 mm reacting. Hemodynamically, patient is normal. And CT scan was again repeated. So there was a small subgaleal hematoma there. Otherwise, the scan looks okay. So patient was sedated, ventilated. The ventilation was optimized. There was slight increase in lactate. Hemoglobin was slightly less, but there was no active bleeding elsewhere. And this is the hemodynamics of the patient, maintaining good saturation. The BP was okay. Patient had a mild coagulopathy, so we didn't consider an ICP monitoring. Should we consider ICP in a pediatric patient?
It's a 1 year, 6-month-old. 1 year, 6-month-old. Not necessarily, especially when there is no suspicion that there is a mass lesion that you're likely thinking it might expand and cause a problem. So
There's no role for ICP.
Probably not, no.
So this is a monitor. The patient remains stable, but despite sedation break, the child is not waking up. So what do you do next? Oh, sorry, I gave the answer.
Whether seizures is the
Yeah.
problem.
Yes.
You want to make.
So the twist is the seizure, there's no non-convulsive status, there's no ongoing status epilepticus. It looks okay. So we are also thinking that it could be seizures, why the child is not waking up. So everything is fine. So that time we didn't have this TCD machine, but I always fond of TCD. I did this TCD. Again, this is showing a cerebrovascular arrest. You can see there's no diastolic flow, there is a reversal of flow. So what next? Of course, medical management was initiated, but despite this, the patient. So of course, we repeated the CT scan. So this was the CT scan. This is within a day. First day patient was admitted, next day child has already developed infarct and there was. So we never expected this. Child was okay, the scan was okay. So immediately EVD placement was done. The ICP was too high, the invasive ICP was too high, and the TCD flow improved after that. We didn't talk about prognosis because it's a child. Again, I'm telling you, child behaves completely differently from adult patient. In adults, we were discussing a lot about to do something or not. In this, we never even thought about it. And the patient was shifted back to the ICU. This time, the EVD was not draining. Pupils were sluggishly reacting. So the ICP showed 54 in the monitor. And again, there is a circulatory arrest. So what do you do next? Repeat CT. So that would be the thing. So CT was repeated. The ventricles were completely collapsed. And now, Raghu, would you do a DC? The ICP is so high despite.
No, so actually the pathology seems to be somewhat different, sir. Apart from the head injury, I think a child may have some like cerebrovascular injury, or with the massive refractory ICP, global cerebral blood flow has come down. So there is no point in.
No point in DC.
Yeah, DC.
If no point in DC means this patient is going to die, then means we can't help the patient. Patient can't survive because everything is going to get infarcted. Your supratentorial compartment, everything will get infarcted in no time. Sir, Bala sir, you.
I think you just have to explain to the patient about the really critical situation right here. And I think you've done what you can do. There's no more role for, I think you've decompressed and put EVD. There's nothing more medical to do
So
apart
would
from doing
that
bi-side, bitemporal. I don't know.
Okay, let me get consensus from other two panelists also.
We have done a posterior fossa decompression
Yes,
with a
yes.
revision of an EVD. So I think this is not the scan that was taken immediately, no?
Pardon?
First we have done placed in EVD alone.
No, EVD and posterior fossa decompression.
Was
Both
done
was done.
first itself.
Yes, yes, yes. Because the infarcts were already established, na, that.
Posterior fossa
Yeah,
infarcts.
yeah, yeah.
Okay.
So why the posterior circulation arrest has happened actually?
No, not arrest.
So did the
If you
CSF
go to, it is only PCA infarct, that is because of raised ICP.
No, so occipital lobe has paracoccipital and cerebellum.
No, the initial.
Related to ICP, na?
The
No,
initial.
ICP
The
burden.
anterior was spared.
Only PCA.
Only posterior was involved.
Yes. We don't know. It could be vascular injury.
That was
We
vascular
don't know.
dissection would have happened.
Okay, that is fine. But this is the situation now. There is no blood going into the brain. What to do? The ICP is so high.
No, already you have done the posterior fossa
All
decompression.
done, all done. Now what to do? Clinical status, patient still M1. Pupils bilateral 3 mm, one side 3 mm, other side 4 mm, sluggishly reacting, not briskly reacting.
So
The continuous supportive care.
In
sir.
the interest of time, you wanted to say something? No.
Wondered whether the CSF showed any possible, infection or anything like
No.
that.
Possible, sir?
Infection.
That would be too late now, sir, for us to know whether it is an infection or not.
Yeah.
So this is an acute situation. The ICP, this is an ICP crisis.
So
Dr. Bala has almost written off the patient. Means this patient will not survive if you just leave it like this.
So,
unless
Pane, I'll just, in the interest of time, I'll just tell a little bit of the story, go fast forward a little bit. So we actually agree with you, Bala. So we actually called the patient to the counseling room, parents, grandparents, and said, very bad. We don't think anything can be done. We said everything the right way with the right thing. And they said, if there is anything else that you can do, do it. Even if after that the child doesn't survive, it's okay. But if there's anything else you can do, do it. We had actually said, second time cerebrocirculatory. Now you proceed.
I spoke with sir and I was insisting on a craniectomy, okay. We did the decompressive craniectomy.
No, bilateral frontoparietal, that is the incision.
So this is the post-decompressive craniectomy scan, okay. Right. So what is most important is that there is no ICP now. The cerebral blood flow improved, and this is on day 6. The blood flow is very good, okay. Now the child started showing small movement, okay, M3 kind of movement. So should we do a tracheostomy? That was a question. But I believe that pediatric patients tolerate the endotracheal tube very well, contrary to the thinking. So we didn't do a tracheostomy. Almost the child retained the tracheostomy for almost 33 days. We retained the endotracheal intubation. Oh, sorry. So after that, we extubated the child, and I think Dr. Bala forgot this case. Already we presented this case once in our previous meeting. So the child, we are following it up for a long term. It's almost, how many years? 10 years? Almost 10 years. Child is going to school. Okay, had some small spasticity in the leg. Otherwise, the child is absolutely fine. Even cognitive-wise also, it's doing better. So my point is the cerebrocirculatory arrest, whatever we are talking about, in pediatrics, usually, like you said, pediatric, why ICP? Pediatric ICP. We should go for ICP in pediatric. Pediatric, we have to be more aggressive than the adults. So that may be one of the thing which I would want to everybody to.
Dr. Raghu, this is where we started believing in God.
Once again, what is the takeaway from this case?
Don't give up in
absence of circulation on TCD is not a death sentence.
In pediatrics.
Yeah, but is 16 pediatrics or adult?
That depends.
That is a question.
Depends on the country you practice. No, here it
but
is
actually in children, if you see, if you look at
IAP.
not only TBI, but if you look at any other complex surgical work, they say go aggressive, including AVMs. Things like that. Go aggressive in pediatrics because their recovery is much better, their plasticity is much better, and therefore they will do better.
I'll just relate a 30 seconds indulgence. I had a 2-year-old who fell from the first floor, similar story. Massive unilateral burst temporal lobe, burst parietal lobe, subdural hematoma, came in deep coma, GCS 4. I was a sort of year 1 consultant. I was unsure. Spoke to my senior and said, "Oh, what have you got to lose? Try." Took the patient to theatre, opened up. The brain was coming up to meet me. I had to cut off more than half of the parietal lobe on table and close in a rush, single thickness suture, and went and declared to the patients that the child's going to die. I was convinced there was no way he would survive this. Post-operative scan showed a new hematoma where I had created a cavity with my, lopping off the parietal lobe. Long story short, 2 years down the line, just before I left the UK, he came walking to me in clinic, gave me a hug, gave me a flower, and said, "Thank you." He was talking. I was stunned. That is when I started believing in God. That was extraordinary.
Not only in TBI, even in ICH, the Neurocritical Care Society has come up with a big guideline saying, don't be nihilistic in the initial hours itself. Even despite the patient's age, if the patient is elderly, other thing, go aggressively in the first 24, 48 hours, because most of the times, because of the withdrawal of care, because of we don't escalate the care, these patients land up in higher mortality rather than because of the illness and disease itself. Yeah.
I think nihilism is always bad. What are we doctors for? To say that nothing can be done? I don't think that is our mission.
Thank you. With this, we end this session. It was a very wonderful discussion.
We have come to the end of this conclave, and I really thank and appreciate everybody. I mean, I see quite a full room despite it being 4:30 on a Sunday evening. So thank you all very much, and I hope all of you enjoyed it as much as I enjoyed it. I must thank everybody who's come here and spent time, especially those from out of station. Thank you for being here on a Sunday. It's precious, and I do think still, as I said when we started the day, that there is a lot of scope to collaborate and bring out protocols and data from across Kauvery. And if we do that, we shall be telling a lot of people how things are to be done. Just keep that thought. Thank you very much. There's coffee and something outside.